Good morning, everyone. I hope all are fresh for the first session, and we have the session first slide, the change in program. Dr. Tashi Moto will be speaking first on Helicobacter pylori, and he has 2 lectures in this session. So I invite Dr. Tashi Moto to start the proceedings.
With the permission of the chair, I will be speaking on the gallbladder topic first, sir. उधर से माइक दे दिया. Respected chairpersons, and good morning to all the delegates and my respected senior colleagues. So I will be taking you all this morning to a different place in a high altitude area that is a land of endless discoveries, Ladakh. So this is a place and the people. So I will be talking on the gallbladder stone diseases, the incidence, presentation, etiopathogenesis, changing trend in the diseases, and the complications related to operative procedures, and the challenges and the development in our area. So gallbladder stone disease in Ladakh, it constitutes around 1/3 of all the hospital admissions, and in a population of around 2+ lakhs, it is around 28%, and average gallbladder surgery is on 1,700 annually, and around 2% of the cases of all gallbladder stone diseases in Ladakh present with complicated features, jaundice, CVD calculus, and severe complicated cholecystectomy, biliary fistulas, and gallstone pancreatitis with or without cirrhosis formation. So histopathologically, the chronic inflammatory disease and the Zinker generation are common, and after every 150 gallbladder stone disease surgery, we find 2 to 3% or 2 to 3 patients having carcinoma gallbladder. And mixed cholesterol calculus is the most common type of gallbladder stone. So as per the etiopathogenesis, the standard predisposing conditions is being taught in standard chapters. So the fair, fertile, female, and fair. This is not consistent with our scenario, because in our setup, the maximum population are lean, thin, and not fair, and the BMI not around, not more than 18-20. So the studies conducted at Leh by T. Norbu and Hitson, based in UK, they found that in rural part of Ladakh, the postponement of bowel transit in domestic affair, particularly women, they are increasing the intrahepatic circulation of bile, that leading to supersaturation and confused formation with the due to biliary calculus formation. So high sodium intake, because people are fond of taking emulsified butter tea with saturated fat. Cold and dry atmosphere of lay inhibits or from proper hydration, and chronic hypoxemic condition with polycythemia is a very common feature, and this all leads to excessive heat degradation that may be contributed to the formation of gallstone diseases. Lack of protein eliminated diet and male to female ratio is almost equal, and laparoscopic cholecystectomy has emerged as the gold standard modality of treatment in our part 2. So there is a complete evolution as word scenario from mini lab, buttonhole, keyhole, and presently only very minimal incision of 2 to 3 centimeters are being performed in the open procedure. So as Honorable President of Jakasicon and Honorable President of Association of Surgeons of India yesterday emphasized that human touch and a kind heart must not replace the technological advancement. So, applied spirituality is the mode of starting our day that helps to cultivate faith, that improves doctor-patient relationship, which is of paramount interest nowadays, and enhancing the healing power. So, it all started in lay with our renowned legends in surgery, whatever visiting lay for an academic exchange program and starting a meditation with the spiritual prayer. And simultaneously, I have started doing this pre-operative morning session of spiritual prayer before surgery that improves overall outcome. So these are the laparoscopic procedures being undertaken, and this is a complete laparoscopic setup in our hospital. So this is the starting the day with the fiber optic nasal intubation and all the procedures of laparoscopy. So academic exchange program and surgical education program is of paramount importance to keep going. We explore possibilities and we learn from the legends of our world. So these are the glimpse of the academic exchange program and lay continuous surgical education program, and all the renowned people are sitting here, and every these well-known faces and very famous personalities in the field of surgery. And these are the operative workshop team in our hospital outside the operation theater roof. So this is the second continuous surgical education program today, and I had the opportunity to visit Singapore last year, and I presented my work in the World Congress of World Congress of Endoscopic Surgeries, and these were the starting of the laparoscopic procedure in the extreme of ages, 12 years and 68-year men. And nowadays, the changing trend of disease is the increasing the disease scenario in pediatric age group. And these all are the pediatric age group patients. But I found consistently that there is increase in the BMI of the children. And so these are all pediatric patients. So definitely it is found that the BMI, as I told you earlier, it is very less in general population. But nowadays, with the lifestyle, it is they're increasing the BMI and increasing the gallbladder stone related disease in children. So these are all children as young as 1 year and 10 month kid having gallbladder stone disease, and just last 2 or 3 months back, I operated this 9-year-old female child with the laparoscopic surgery, and subsequently I had some 71-year male patient undergoing laparoscopic procedure.
Dr. Tasir, you can continue with the second presentation also.
So this is the maximum number of gallbladder stone I removed. There is 1071, and this is the largest gallbladder stone, 5.5 centimeters. So these are all related procedure, appendectomy, then cystectomy and nephrectomy, and this is a splenectomy. So these are complicated cases we face during post-operative period, and I deal with intrahepatic gallstone earlier diseases and hepatitis B concurrent infection with gallstone disease, advanced malignant diseases related to hepatobiliary system, and these are all our scenario. And this is the latest April. Just coming here, I took all these pictures, and thanks a lot for giving me a patient hearing.
Thank you very much. You can continue the second presentation. At the end, you can continue the second presentation.
Once again, good morning to everyone. So I will be presenting a different disease that is very common in Ladakh, Helicobacter pylori infection and carcinoma stomach. So as per history, there was a discovery of H. pylori that transferred the medicine, Barry Marshall and Warne, winning a Nobel Peace Prize in 2005. So they said that peptic ulcer is no longer a chronic, frequently disabling condition, but disease that can be cured with a short regime of antibiotic. So the history itself explained of the few scenarios, Mary Curie, John Hunter, and Marshall. So the disease scenario goes like this: Helicobacter pylori acquiring infection in the younger age group, then ulcer disease development, ultimately leading to precancer condition and malignancy development. So this was the self-experimenting noble work by Barry Marshall, and it all took him with the courage and dedication to write down the history in medical fraternity. So nationally, the estimated cancer is around 15.33 lakhs. So this was reported in Northeast Times. So Ladakh has witnessed a very sharp increase in the cancer diseases over a period of time, around 4 years. So these were reported in NCRP, National Cancer Registry Program of ICMR. So they emphasize that this increase in the incidence of cancer in Ladakh may be related to improved health care seeking behavior, and they also said that the rising lifestyle changes that increases the burden of non-communicable diseases, but there is a very doubtful question also. It says that CIA, there is some in 1965 there is a lost nuclear device. So there may be increasing or witnessing rise in the cancer diseases in the Himalayas. So this is the general risk, whatever. So genetic predisposition, H. pylori infection, the ingestion of contaminated soil and unhygienic food, and improper day-to-day life hygiene, and contact with the other people's saliva, and sharing utensils and personal items, and contact with body fluids, then other diseases of the stomach, then there are some extra risk factors related to my place. So acquiring H. pylori infection at a very younger age. So because the sanitary style and the hygiene are very poor in particularly villages, and consumption of leftover food is a usual habit. Consumption of stored and dry contaminated egg, they carry this meat they carry for years, and old stored fungal contaminated butter stored in particular areas like Zanskar, they are considered pests. So high salt intake is emulsified tea. This is called burbu chai. The hot water and tea ingestion related to climatic cold conditions and high altitude and atmospheric oxygen low, chronic mountain sickness, then lack of protective elements and alcohol consumption. There are other factors that may be contributing to the development of more carcinoma stomach in our part. So there are some good protective elements also available, but it is usually taken in dry and stored conditions, so they are not very effective and protective elements. So these are a few of the pancreatitis and early ulcer development videos during endoscopic features. And this was the one of the patient who had undergone irrigation treatment and relapsed. Then he developed pancreatitis, pylori ulcer, and ultimately development of malignant disease of the stomach. So this is a few of the reports of the cancer registry in our hospital. So it is the latestly there is sharp rise of the RUT positive cases and the development of malignant cases. So these are the year wise, and this is just last 3 months. I have just been getting this stool test also. So these are on the increasing trend. So this is particularly to be noted that in the age group of 40 to 50, from 70 and 70, 60 to 70. So there is an increase in the upper GI endoscopies as a development of malignant diseases. So it is last year it was around 29. So these are the majority of the cases of the carcinoma stomach are in pulmonary rectum, and 90% of the cases are advanced stages. And anyway, gastric outlet obstruction are the common features. The last modalities left are only palliative and chemotherapy with palliative care. So these are the natural treatment available for H. pylori eradication rather than antibiotic. So they said it is some effective agents available that is available in edible oils like ginger, turmeric, then curry leaves, cinnamon, and garlic. So there is one thing that I want to emphasize is that H. pylori, the prebiotic role of prebiotic and some honey and other. Just 1 minute. So they are thought to be very effective. So the overall betterment lies in the awareness program. So if one says there is no illness, they are healthy. If you don't have any creative, then you are wealthy. So the ultimate choice is go to the preventive measure or the curative measure. So the tussle is tougher, but prevention is much better. So thanks a lot, everyone, for giving me a question.
I would again welcome all of you for the second session. As my co-chairperson has already opened the session, Dr. Tashi is a senior surgeon from SNM. I am aware about his work. And he probably must have some different data because of the higher altitudes. Because you see, the cancer, if you revise now, especially gastric, this is considered now not a disease of organ, it's considered disease of lymph nodes. So that was the Japanese review that they said this is an environmental disease. Now, from that point of view of environmental disease, when we look back at Dr. Tashi, you are getting it at a very high altitude. So the environmental influences of gastric cancer could be separately seen. You revisit it because it's an endemic with us, a pandemic. I should say it started in Kashmir, of course. The hilly regions, what is there? etiopathogen, what are the genetic predisposition, what is the influence of diet. I won't be a right person to talk on that. But yes, it is an interesting subject to study high altitudes and gastric cancer and the kind of diet you are with. So that influence, you would shortly say us what exactly gets them into cancer at your place.
Yes, sir. It is now best to consider it is a overall environmental, metabolic dysregulation and overall immune system failure.
Is there anything in the diet you would incriminate?
It is more effective and more applicable to some part of the country like us.
If there are any further questions, otherwise we will go to the next speaker. Thank you, Dr. Tashi. We have Dr. Mohammed Musbat. He will present on alveolar hydatid in Kashmir and management and emerging public concern. Dr. Yunis is a senior consultant in SKIMS Department of Surgical Gastroenterology.
Good morning, everybody, and a warm welcome from me. I will discuss on the alveolar hydatid disease in our valley and its management. Actually, it is an emerging public health concern in the valley. Actually, alveolar hydatid disease it's caused by the larval form of fox tapeworm, Echinococcus multilocularis. It poses a significant public health issue worldwide. It's a serious infection that mainly affects the liver, but it can affect other organs also. The humans become infected through ingestion of eggs from contaminated food and water. This is a life cycle. In this, there's a two type of hydatid for the students, the granulosus and multilocularis. The life cycle is different, and in multilocularis, the definitive host is fox, dog, and humans are the accidental intermediate host. As can be seen in the world map, the disease is more common in northern hemisphere like China, Russia, and all the countries. It has been imported from those countries to us. Indian scenario. What is the Indian scenario? It is very rare in India. There are few case reports reported so far. It has been rare in our valley also. We have seen very few case reports. But we discovered a recent surge in these cases in Kashmir region, and there's an abrupt surge in last 3 years. This is a matter of concern. The majority of the diseases are documented in Kashmir, where the people live in close association with these definitive hosts like dogs and foxes. So what about the treatment? Surgical resection is the mainstay of the treatment, and complete resection are associated with a favorable outcome. When possible, the curative resection should be attempted. We took a study in our department. We assessed the clinico-pathological and demographic findings of this disease in the valley and what is the surgical management. This is a prospective study from 2022 to 2025. We included 74 patients. The 59 were resectable. The assessment, pre-op assessment, as you know, it includes CT, MR, chest X, and serology. In I can tell you the serology is not available in India for this disease, particular disease, because it is not in India. So before taking a patient to operation, we do something like we optimize the comorbidities. Some patients are jaundiced, some have cholangitis, so we correct those. And assessment of child food store, MAD score, and antibiotic and prophylaxis. This is a yearly distribution, as can be shown in the graph. The cases gradually increase from the last 3-4 years, and in last year we have seen 33 cases only. It is common in certain districts like Ganderbal and Shupian, and the majority of the cases are from those areas. With respect to the age group, it is found in second and third decade of life, and females were more common. The clinical presentation variable pain is the most common. The 80% of the patients were resectable in our series. It was more common in the right lobe and segments like 5, 8, 6, 7. We did major hepatitis 62% of the patients. This is the What we have done, right hepatectomies, central hepatectomies, every type of hepatectomies we have done in these cases. The operative parameters like blood loss and operative time in these patients. We followed the fast track protocol. We remove the rash on the first day, start or on the first day, and make the patient ambulate. These are some of the complications of bite were the most common complication. We followed the ERAS and we did our protocol, departmental protocol of the follow-up. The patient should be kept in regular follow-up for 2 years with albendazole therapy for 2 years. These are some of the publications from our department. This is the last year we have published in Asian Journal of Surgery. So these are some of the examples. This is the alveolar the right of the liver. The patient was jaundice. We did a right hepatectomy. Similarly, another patient we did right hepatectomy. This is also alveolar in the right lobe of the liver. This is segment 6, 7. We did post-resectionectomy of the liver. And in certain cases, we did central hepatectomy, the resection of segment 4, 5, and 8. Left liver resection, left lateral segmentectomy. This is the operative picture we did. In this patient, we did left hepatectomy. And multiple liver resection, like resection of segment 4, B, 5, and 6. In this patient, it was involved with the 4, B, 5, and 6. And in this patient, we did parenchyma preserving. The alveolar was in every lobe of the liver, right segment 2, 3, 4, B6. And we did resection, we did parenchyma preserve resection. Some patients might need liver transplant, like the lesion is involved the central light, common is the portal vein, hepatic arteries, and IVC. These are some of the cases. The data from the study provides an insight in the epidemiology, clinical presentation, and management studies and outcome of this complex condition. It highlights the recent arrival and abrupt surge of alveolar hydatid in India and highlights the importance of early detection and appropriate surgical management. These lesions must be update the list of differential diagnosis for hepatic lesions in endemic areas. Previously, they were treated as intrahepatic cholangiocarcinoma. Effective multidisciplinary management is important, and long-term follow-up are crucial for the good outcome. Thank you.
Thank you, Dr. Yunus. You precise and efficient in time. Regarding alveolar hydatid disease, the same time, 22 to 25, we came across 3 cases. And one case was operated by one of my junior consultants. He's a colorectal, Dr. Asif is a colorectal surgeon. He opened a patient on under the table. I visited, he said, "What is this like?" I said, "This looks like alveolar, just take a biopsy, don't do." As you understand, it's a very patchy problem. It doesn't locally involve a specific site like a hydatid, a kind of bone. So it becomes pestering to handle such a liver. And especially if the posterior segments like the hepatic veins are involved, then probably the problem about these is 2 patients we did a resection. And these 2 patients, one pestered us for 1.5 years, developing a fistula of colohepatic fluxure with that cystic cavity. So he pestered, something like bilis coming out. We again re-explored. Again, it did not go away. Looking back at this, the fastidious nature of the disease, we discussed this issue. In that same time, so 2 years before, Professor Kuru called us that, have you seen any cases like this? I think that time he became interested in collecting data on alveolar disease. I said, "Sir, I have seen 3 cases. One we have operated, it gave us a very bad result. 2, we have not done anything. We took a biopsy, it came out to be alveolar disease." He said, "Nothing." I said, "Could we do better than this, other than resections, lobectomies, sectionectomies, and all that?" Well, if the disease is precisely as you have rightly said, the issue is with the disease is that the recurrence is very high. It develops, comes back, and fistulation is a very pestering problem for the surgeon. These 2 issues. Then he said there are only 25 cases till date report. This is as per his data and collection. Only 25 cases have reported to him. Total incidence. Well, that would be probably a hospital-based, or probably it would have been better to do a community study where you could do this incidence. Thank you very much, because yes, it is important to understand. You put them on a mixture of praziquantel and albendazole for at least 3 to 6 months. Revisit, do an MRI, look back the hepatic veins, and most of the times they finally land into hepatic transplants. I think Professor
Actually,
Sir, in the mic.
Dr. Very good presentation. I think probably one of the first departments who has taken an outstanding decision to go for resections in these. But again, my concern is that
Can you be close to mic?
my concern is that it's a systemic disease. So how do you explain the surgical resection? How come you are sure that it's not recur? Probably Mushtaq Sahab also said that. Then long-term follow-up.
yes.
What do you think would be the
Sir,
outcome?
actually, when we see the patients, we do it is a TNM staging, like malignancy. It is also a TNM staging. We do staging, we do CT, we do chest, we do everything. Even in some cases, we do PET. But majority of the cases, I have operated almost 60 patients from the last 3 years. Majority of the patients are primarily the liver, and we did complete R0 resection. Until now, we have found no recurrence. If the it is like a tumor. If you are resecting with R0 resection, and margins are not that strict, you can take a 1 centimeter or half a centimeter margin, and you are if I planning the anatomical hepatectomy, right hepatectomy, left hepatectomy, and I have not in my series I have not found a single recurrence. And regarding bile leaks, as the sir pointed, because in these patients when we do perineal transit, we like it is small bile ducts, and there's increase. Most of the major liver resection have bile leaks in the post-op period, but with follow-up they subside. Liver, the persistent biliary fistula happens in some patients in which we have an R1 resection, because when the bile ducts go through the parasite, it is like a tumor. They don't collapse; they remain wide patent. So in one patient we had that problem. In that patient we had an R1 resection, we had a decompression, or we had an R0 resection that had a persistent biliary fistula. But till now, we have almost 50, 60 patients on follow-up, no recurrences. The last follow-up is 3 years. And we put patients on albendazole. Recommendation is for 2 years, albendazole. And in the patients who have like chest disease, who have we don't operate those patients. We operate, and majority, 95% of the patients are having disease localized to the liver. And we plan resection, we do complete R1, R0 resection. And some patients we have sent 3-4 patients for liver transplant. And they have not done transplant, they have done good resection. They have done portal vein resection, they have taken the liver out, taken the hydrated and put the liver back. And they have done some miraculous surgery. But believe me, surgery is the only chance of treatment. And if the surgery is well done, the patients don't have recurrence.
Thank you, Dr.
Can I just? You see, we have done a lot of hydatid work at SKIMS. It's in literature also. Most of the times, once we would get alveolar hydatids, it was very difficult to manage them. Putting them on chemotherapy, albendazole and coitals and other things, it would not work. And it would be in areas where it had two problems, two implications, what I have found. Younger patients, am I right, Yunus? Younger patients. One.
In our
Yes. Number two, once he started resection, liver resection in the Department of Gastroenterology, in fact, I have told him several times that we would like to have a resectional therapy for alveolar hydatids. I think it is because of that he has taken these cases. But overall, I have also found the psychological impact on young people having some lesion in the liver which is not being taken care of from the point of view of surgery. Resection would be the ideal treatment for these. In hydated multilocularis, resection would not be that much effective, because most of the times, yes, it is said that resection is the possibility of a recurrence is high, but we have not found that. But in these alveolar hydatids, resectional therapy would be the ideal treatment.
So I can give one example. There was one lady from Nishatira. She's a young unmarried lady. She has been put on albendazole for 10 years. She has been told no surgery is to be done. Then she came to us, and it was a central lesion. We didn't operate. We sent her to some liver transplant center. They did a resection. She's doing fine. So the most of the physicians, actually gastroenterologists, they don't recommend operation with this patient. They keep patient
So
follow-up for
let
10 years.
us conclude saying that alveolar disease is not like echinococcus. The problem is the multifocal. It's a satellite lesions all over this. You may do a resection if you are lucky to have a localized segmental disorder, where probably I will take what you say. But most of the times when you open the patient, you may not have a preoperative diagnosis.
No, sir, no,
Let
sir.
me complete.
That
Let
is
me
not a
complete. The
problem.
problem is that the disease disorder and these are growing in bizarrely. So if you are very sure you have done a resection, that too if the involvement of posterior involvement of the hepatic veins is not there, then probably I would take up there may not be a recurrence of that.
Most of the times you don't have a diagnosis of alveolar hydatid.
That's
Let
a
me be
problem.
honest.
Now, sir,
It's only by biopsy.
I may
Yes.
respond, sir. Basically, in our area where we work, the patient first, there was some diagnosed tumors. Previously, it was high stress. The people would confuse with the intrahepatic. Not one case where you could see how could they diagnose. Then they wrongly diagnosed intrahepatic cholangio. So now we are in my OPD. I see one case, every case in one new case in OPD. And our radiologists, they diagnosed at one glance.
Yes.
Dr. Nisha, thank you.
In our patients, in our 100% of the biopsy was positive, and we are doing genetic, we are doing PCR also, and we do pre-op workup. Either region is this.
Since we are short of time, Dr.
We are
Nisha, I think we wind up here this
One-
session. We'll do at the lunch break because we are short of time.
Concluding
Speakers
remark.
now.
I may conclude it is curable, it is treatable. We don't find surprises. We do pre-op evaluation, we do resection, and patients are doing well. This is the message.
Thank you very much.
Thank you.
And now we welcome Dr. Khalil Sen for the next presentation.
Thank you very much, respected chairpersons, my teachers and delegates. Very good morning to all of you. I'm going to present a video on laparoscopic left radical nephrectomy. 70 years old male presented with history of pain in left upper abdomen and hematuria. He was a known tobacco smoker. All routine investigations were within normal limit. USC abdomen was done. It showed 5.8 by 5.3 centimeters, well-defined lesion in the middle and upper pole of the left kidney. CSB abdomen was done, which showed 6.7 by 5.5 by 5.2 centimeters, well-defined heterogeneous novulated mass involving the middle pole of the left kidney. It was T1B and 0M0, so it was stage 1 as per American Gynecological classification system. So laparoscopic left radical nephrectomy was performed. Momentum which was added to the left parietal wall, which was
Close to mine.
separated. The adhesiolysis was done. Colon was added to the parietal wall, which was also released. Then the white line of told was incised, starting from below upwards, that is from the iliac vessels towards the splenic flexure. The peritoneum was incised so as to reflect the left colon medially to expose the left kidney. The splenic flexure of colon is being mobilized so as to expose the rotus fascia and the kidney. All ligamentous attachments to the spleen were divided. Splenocholic ligament was divided, followed by division of lienorenal ligament, so that the spleen falls medially and any injury to the spleen could be prevented. Here you can see the left colon and splenic flexure is being reflected medially to expose the kidney completely and the hilar area. The inferior pole of kidney is being exposed, keeping the rotas layer over there intact. It's very important to be in a proper plane so that the mesentery of this descending colon could not be injured, and one need not to enter into the rotas fascia. The fat overlying the gerota fascia is pale yellow, whereas the mesentery is the darker yellow. Then the ureter was identified, it was lifted up along with the lower pole of kidney so as to dissect the lower pole of kidney completely. This is the distal part of ureter, which is being dissected, and it will be ligated at this point later on. At this point, only the assistant port was used. It was used to retract the ureter and lower pole of kidney anterolaterally so that the hilum can be exposed. All the coverings over the hilar structures, they were dissected. They are identified, dissected with harmonic scalpel. All loose areolar tissues, they were divided so as to expose the renal vessels completely. This is the area where renal vein comes. Here you can see the renal vein coming into the view. It's a very delicate structure. One has to be very cautious to prevent any injury. Because of the location of tumor in the middle pole, there were multiple large blood vessels overlying this area, which were carefully identified, clipped, and then divided so as to prevent any bleeding. This is the renal vein being dissected completely and circumferentially. Here's the circumferential dissection of renal vein. One such large vessel was present overlying the renal vein, which was clipped and then divided only. This is the tail of pancreas being dissected away from the hilum so as to prevent any injury and subsequent pancreatic fistula formation in the post-operative period. This is the dissected renal vein. This is the renal artery lying behind the renal vein. Now attempt is being made to dissect the renal artery. All surrounding attachments, they were divided so as to expose and dissect the renal artery completely. This is the dissected circumferential dissection of the renal vein, and this is the renal artery, though it is not completely dissected at this point of time because of the overlying large renal vein. So it was decided to put a clip over renal artery first, divide the renal vein to get more space to dissect renal artery further for some good length so that it can be clipped properly and then divided. So removal clips are being applied to the renal vein. At least 2 clips on the patient side and 1 on the specimen side. So more space can be achieved after dividing the renal vein so as to dissect the renal artery properly. There you can see it's being dissected completely for some good length. Now it will be clipped, at least again 2 clips at least on the patient side and 1 on the specimen side. It's very important to look for some polar vessels also, especially the superior pole vessel and inferior pole vessels. After division of the main vessels, the other structures they were again identified very carefully and divided. Then the gyrota fascia is being dissected away from the parietal wall. It was not breached at any point of time during the dissection. You can see the psoas muscle posteriorly. This is the distal part of ureter, clipped and then divided. These are the lateral attachments. They should not be divided at the initial part of the procedure, otherwise kidney will fall medially and dissection of the hilar structures will be difficult. So they provide some type of attraction. This is the last attachment of the kidney. Now kidney is freed and it will be put in an endo bag for the retrieval. Thorough normal saline irrigation and suctioning was performed to check for hemostasis. Then the specimen was removed. This was just to the left of him, like this is the camera port. The upper one is the left hand working port, and the wound with multiple clips is the right hand working port. This was actually enlarged to retrieve the specimen, and drain was kept through the assistant support. This is how the specimen was oriented. Thank you very much for your patience. Thank you.
Nice presentation, good video. But I would suggest two things. See, when we talk of radical nephrectomy, we should have a pocket kidney. Paranephric fat was getting torn. It should have a Gerota anterior toward posterior zuckercundum. It should be covered because Gerota is a part of radical.
Gerota is intact, sir. It was covering the kidney. Kidney was not bared off the Gerota.
Where was your tumor?
Sorry?
Where was your tumor?
Tumor was in the middle pole, sir.
Size?
Size 6.7 by 5.5 by 5.3
You
centimeters.
left the Gerota. You left the Gerota.
Gerota was over the kidney. Kidney was removed along with the Gerotas.
Okay, that's what I'm saying. So at the lateralization of the colon where you have to stay in the dot line, that white line. Otherwise, what I could see, some of the abdominal fat will go to the, which was raw over there. If you precisely go in that area, you will maintain that sacred plane between the abdominal fat and the perinephric fat, not paranephric fat, not peri. Because you have to take the paranephric, Gerota, perinephric, and then the kidney.
So there was not much of fat on the lateral. It was male patient, so not much of fat was there on the lateral side.
Thank you, Dr. Talib. Thank you. Good presentation. He has not come. We are at the end of the session. I thank the organizers for giving us chance to stay here, along with my co-chairpersons. We wind up this session. Thank you.
I request our esteemed chairperson, Professor Dr. Ejaz Ahmed Rathur, sir, to felicitate Dr. Tashi Motuk, sir. I request Professor Dr. Mushtaq Chalku, sir, to felicitate Dr. Muhammad Yunus Bhatt, sir. I request Dr. Barinder Kumar, sir, to felicitate Dr. Talib Hussain, sir.
I would now request Dr. Fazil Bari sir to felicitate our chairpersons for the session. Dr. Ejaz Ahmed Rathur sir. Professor Dr. Mushtaq Chalku sir. Dr. Barinder Kumar sir. Dr. Bharat Bhushan sir.
Thank you everyone for the session. Technology is advancing at an unprecedented pace, but ethics remains the compass that guides us. With this, we move on to the next session of the day, which is Ethics and Advances in Surgery. May I respectfully invite our esteemed chairpersons for the session, Professor Dr. Rajinder Prasad, Professor Department of Surgical Disciplines, AIMS Delhi, Professor Dr. Nisar Chaudhary Sir, Founder Chairman Jakasicon, Professor Dr. Ravinder Sir, Professor and Head, Department of General Surgery, GMC Kathua.
Professor Dr. Vijay Kundal sir, Additional Professor, HOD Pediatric Surgery, AIMS Jammu, and Dr. Vikas Gupta sir, Service Consultant Surgeon.
Hello.
Good morning, everyone. We will start with the next session, and the first speaker is Professor Dr. Sanjay Bhasin. He will talk on what ails medical practices, 4 idiots and others, few encounters with rare foreign bodies.
Good morning, esteemed chairpersons, Dons of Surgery from Jammu and Kashmir sitting in front, dear students. At the outset, I congratulate Maria, Varun and their team for excellent performance as organizers of Jakasicon 2026. When I submitted my presentation, I did not want you to present, but they stressed that you should present something. I sent them 2 presentations. I told them choose between the 2. I have been branded to present ethics in every conference. I sent 2, and fortunately, I am presenting both because unfortunately, Professor Digra is not able to come because of some domestic reasons. And in place of him, I am presenting my first presentation, that is what ails medical profession. Disclaimer: the contents may initiate differences of opinion, but it being intellectual discussion, such arguments may be dealt with intellectually. Patient's highest degree of tolerance and polite rejection of the opinion is what is expected. There may be some pictures or statements that are without any prejudice to malign any individual, group or organization. They are for the purpose of discussion for better health of the society and the profession under reference. This is my topic, what ails medical profession. Professional journey of a medico, you see, just pictures. This is how the journey of a medico starts. When one joins MBBS, thought of saving many lives and spent endless nights giving emergency routine duties and OT duties. Sometimes डॉक्टर बनने में कितना खर्चा आता है? पैसे तो कम खर्च होते हैं पर जवानी पूरी खर्च हो जाती है. और if my doctor looked like this, I would fall sick every day. ये एक बात थी सोसाइटी में, लेकिन अब सिनेरियो चेंज हो रहा है. एलिगेशंस हैं, unnecessary operations, fee splitting, conflict of interest. And why it is so? I presume that there are 4 idiots in medical profession which are working to deteriorate the overall image of this profession, which is used to be called as noble profession at one time. And first one is the mushrooming of corporate health sector. The spirit of privatization now pervades India without benefits, drawback stratifications. Corporate hospitals with a pure motto of minting the money make huge profits and offer dividend to their stakeholder. Sharp departure from ethical practices is the outcome. Primary health care is at the mercy of failing government health sector, and this gives a frustration to the doctors working in government hospitals with a meager salary, and it paves way for inducements. But beyond any shadow of doubt, ethical values, interpersonal relations, and rapport of doctors in the society has decreased due to this first idiot of medical profession. Second is the capitation fees. We had been discussing a lot of things in yesterday's executive body meeting. Deterioration of interpersonal relations, the behavior of postgraduates, the duties of a teacher, and commercialization of health sector, what has done damage, ultimate damage. Capitation fees is directly proportional to more and more commercialization of the health sector. Unethical practices, they are gaining entry into medical colleges as students are rampant. Private medical colleges necessitate huge capital investments, and on completion of course, there is a need to recover these investments and generate a profit. Third idiot is the quackery. Quacks, India has more quacks than genuine doctors. They take acute patients and make them chronic or refer to specialists with a motto. Refer to specialists with a motto. Medical Council of India has no control, or even NMC has no control on them. Today, a doctor cannot ignore a quack. This is the reality. Fourth one is the pay and perk of doctors. So much has been debated upon this. I am more than 25 years as a surgeon. I am drawing only 1.5 lakh rupees at the end of the day. But my student in private sector is earning more than 15, 30 or even 50 lakh rupees in a good corporate hospital. This is another frustration. And sportive factors with these 4 idiots are negative media coverage. Are doctors really greedy? This media is writing. Doctors ignore government orders. Don't put names but designation on prescriptions. डॉक्टर को सादे कागज पर दवाई लिखना पड़ा महंगा. दिस इज ऑल व्हाट नेगेटिव मीडिया जर्नलिज्म इज डूइंग. गर्भवती का पेट चीर झगड़ने लगे डॉक्टर. दुनिया में आने से पहले चली गई नवजात जान. ये प्रोजेक्शन जो मीडिया कर रहा है डॉक्टर्स के खिलाफ without taking into consideration the view of the doctors. That is unfortunate. ये खुद में एक इडियट है. इसने मल्टीपल टाइम्स मीडिया डिबेट्स पर कहा है कि मोस्ट करप्ट प्रोफेशन ऑन दिस अर्थ इज डॉक्टर्स. और उसने एक अपने आप में एक जनगणना भी करवा दी कि 48% डॉक्टर जो है वो करप्ट होते हैं. और इंजीनियर देखो, सॉरी टू से, वो सिर्फ 2% करप्ट है. और IAS IPS देखो, और जज का नाम ही नहीं लिया. सॉरी टू से, कल एक जज जो है वो पकड़ा गया है, 1 साल पहले उसको पकड़ा गया, उसने मौज लड़ाई और अब कल उसको पकड़ के उसने इस्तीफा दे दिया। लेकिन डॉक्टर सबसे ऊपर है करप्शन में, थ्रेटिकली। वी स्ट्रगल द होल नाइट एंड सेव द पेशेंट। मैं बोल रहा हूँ पेशेंट को, तो मीडिया वाला कह रहा है दिस इज नॉट द न्यूज। तब हमको बुलाना जब तुम किसी को मार दोगे। ब्यूरोक्रेटिक और पॉलिटिकल इन्फ्लुएंसेस, दे आर अदर सपोर्टिव फैक्टर्स फॉर एलिंग मेडिकल प्रोफेशन। बहुत ज्यादा हमें भाषण देते हैं, प्रोफेसर भी चला जाएगा तो वो उसको आधा घंटा 2 घंटे 4 घंटे बाहर कमरे में खड़ा रखेंगे, और जब वो जाएगा तो डॉक्टर मेरा स्टूडेंट होगा, मेरी यूनिट से इंटर्नशिप करके गया होगा, लेकिन बोलेगा ऐसे जैसे वो मेरे बाप का भी बाप है। ये हिसाब है हमारे मंत्रियों का। मंत्री गलमा पकड़ लेते हैं, और मंत्री जी और मेंबर पार्लियामेंट ऐसे देख रहा है जैसे वो रेडियो डायग्नोसिस में उसने बहुत सारी डिग्रियां करके रखी है। और ये एक आदत है लोगों को, ये प्लेट लगाने की, ये प्लेट 2017 में लगी थी, एक्सटेंशन ऑफ इमरजेंसी, वो कभी पूरी नहीं हुई। वो 7-8 साल के बाद दूसरी जगह पे जाके वो इमरजेंसी की एक्सटेंशन हुई। प्लेटें लगाने में बात है। हमें भी समझना होगा, ब्यूरोक्रेट्स को भी समझना होगा, आम जनता को भी समझना होगा, मेडिकल कॉलेज इज नॉट ए हॉस्पिटल। प्राइमरी ड्यूटी ऑफ मेडिकल कॉलेज इज टीचिंग ट्रेनिंग। बट आपके बेड भरे हुए हैं और आपकी टीचिंग ट्रेनिंग सफर कर रही है, आपकी रिसर्च सफर कर रही है, किसी को ध्यान नहीं है। सोसाइटी नो लॉन्गर ए नोबल प्रोफेशन, आपको बोल रहे हैं, कह रहे नहीं है नोबल प्रोफेशन। डॉक्टर्स जो है वो बिजनेसमैन हो गए हैं, बट ओवरऑल डिवैल्यूएशन है। लेकिन अगर वाई सोसाइटी डोंट टारगेट अदर मोर करप्ट प्रोफेशंस, नहीं कर रही है। अर्नब का आपने एग्जांपल देख लिया। लेकिन इफ सोसाइटी एट लार्ज इज करप्ट एंड अनएथिकल, हाउ कैन वी एक्सपेक्ट डॉक्टर्स टू रिमेन ऑनेस्ट? ये हमारा आर्गुमेंट हो सकता है। एजाज साहब भी इससे सजेस्ट कर वो एग्री कर रहे हैं, लेकिन मैं ये कहता हूं, इफ एवरीवन इज डूइंग रॉन्ग, आर वी इंटाइटल्ड टू फॉलो सूट? बिकॉज वी वर कंसिडर्ड एज डेमीगॉड्स एंड आवर प्रोफेशन एज ए नोबल प्रोफेशन। ये सारी चीजें सोचने की हैं, चिंतन मंथन की है। प्रोफेशन इज एलिंग ड्यू टू मल्टीपल रीजंस एंड रिजल्ट इज वायलेंस अगेंस्ट डॉक्टर्स। दिस इज द एंड रिजल्ट ऑफ दोस 4 idiots एंड सपोर्टिव फैक्टर्स, वायलेंस अगेंस्ट डॉक्टर्स। और ये हालत है आज डॉक्टर की, और ये है, ये सारी चीजें हैं, ये हैं हीलर्स, दे आर द सफरर्स। लैंसेट ने भी कहा वी मस्ट प्रोटेक्ट पेशेंट्स, बट वी मस्ट आल्सो फाइंड बेटर वेज टू प्रोटेक्ट प्रोफेशनल्स। इफ वी डू नॉट, मेडिकल प्रोग्रेस विल सीज, पर्टिकुलरली इन कंट्रोवर्शियल एंड डिस्ट्रेसिंग एरियाज। ये कुछ स्टैटिस्टिक्स हैं वर्क प्लेस वायलेंस के। सबसे ज्यादा इमरजेंसी में होते हैं। डॉक्टर्स के पास इसकी थोड़ी सी हल है, एम्पैथी टुवर्ड्स पेशेंट्स, कम्युनिकेशन शुड बी देयर, option for second or alternate opinion, meticulous record keeping, periodic operative appropriate trainings, introspections. Administration को भी कुछ सोचना पड़ेगा, और positive journalism, positive constructive, bureaucratic political will, realization of society that doctors are also human beings, or strong legislation to prevent violence against doctors, or it cannot be inherited, it cannot be pursued, purchased. I have earned it with blood, sweat and tears. I own it forever, the title doctor or a surgeon. Thank you very much.
Professor Sanjay Bhasin, I think you are the best person to talk on ethics in medical, medical issues, and you have done justice with the topic. So would you like to talk on another topic of your own topic now? Okay, now we call upon Professor Fazlur.
I have one query.
Who is talking on evolution.
I have just one query, sir. What you will do when there is a, you see, doctors versus doctors? There are 60 or 70 doctors in parliament, and we could not force a law. We could not bring out anything in favor of doctors in the parliament, having 69 doctors as MPs in the parliament.
Exactly, this is a big problem. Yesterday also in the executive body meeting, I deliberately did not consider it or put it as a fifth idiot, the interpersonal relations amongst doctors. The senior doctors, they are on the same page. About 7 days back, I being chairman of disciplinary committee, one case came to me, first year student, 10 days back, he joined as PG student, he entered into ward, second year PG student, asked him to do some work, emergency work. He had a scuffle with the senior lady. The third year PG male came in between and he scolded him, he slapped him. There is a problem within our profession. That is a big problem. And that is why we are losing our title of demigods. Not even MP or at central level, many a times we requested our own doctors in Jammu and Kashmir to do something for protection of doctors. Last time we had 4 doctors as MLAs. We tried our best. It's a irony, it's a matter of discussion. Thank you very much.
Thank you, Professor Basin. I think now we call upon Professor Fazil Gyobare, who is presently the principal of the Sikkim Medical College. He will talk on evolution of erectile cancer surgery.
Respected chairpersons, it's an honor for me to have my teacher, founder president Professor Nisar Chaudhary on the dais, and my 2 students who are chairing the session. It's really an honor, and a very, very senior member of Jakasicon. So it's a unique experience of having Jammu, Kashmir and Ladakh on the one platform. I feel proud that I was one of the founder members along with Nisar Chaudhary sir to lay its foundation in December 2009. It's very heartening to see the young students whom we wish that they will be better than us in the coming years, and they have to be better than us. The topic given to me is evolution in current best practices in CRECTOM. So what we have seen, the evolution in management from last couple of decades has been, once we would think of this disease in 80s or 90s, we would think only as a surgical disease and we have to treat it completely by a surgical means. But then came the concepts of the multidisciplinary team disease, and pre-80s our concept was that we wanted to simply get rid of the disease, but now what we are focusing on, we focus on a better quality of life, sexual health, bladder health, and we consider it now a treatable disease. So this was what we had the concept before. It is purely a surgical disease. We would do APR, and would have the recurrence of 20 to 40%, which was quite high, but there were no guiding oncological principles. There was no concept of circumferential radial margin. Stoma management those days, because of the lack of the good appliances, was a shocking experience, because all the time patient would be stinking and would be left socially isolated. And then sphincter preserving surgeries like anterior resection and low anterior resection started. But ultimately, after 90s, once Bill Field studied the embryology and anatomy again, he gave the concept of a holy plane after feeling that if we want to decrease the recurrences, probably we want to need the take the rectum along with its mesocolon, and we have to get rid of the immediately lying lymph nodes and the mesocolon, and we need to work in a plane which is without any vessels. That is why it was given the name of the holy plane, and this became a bloodless surgery and a gold standard, and the concepts of sharp dissection were introduced. Then came the era of multimodality management. Why? Because the German cancer trial, this trial was the landmark, which introduced the concept of chemoradiotherapy for downstaging, tumor shrinkage. We wanted to preserve more and more sphincters. We wanted to decrease recurrences and improve survival. And this was the era once the staplers were also introduced. So we converted more and more sphincter sacrificing resections into sphincter saving surgery. Then again, similarly, the other things which were developing by the same era beyond the 2000 was the concept of CCTs, MRIs, high resolution. So the staging became more profound. Staging of rectum became more and more, it got changed. We got the concept of circumferential radial margin. We had the better decision making. We preserved more sphincters. More use of laparoscopy was introduced. The CA concept of carcinoembryonic antigen was used for this monitoring pre and post-op, and PET was used for recurrent diseases. So in the evolution, we also found it became an era of acceptance for advanced laparoscopic disease. Robotic surgery started wherever it was possible. Multi-dissection, multidisciplinary team management was always, it became a routine of discussion. And if you go to now, how do you manage it? It's a stage-specific and tumor-specific management. Then concepts like transanal excision, TAMIS, TAR-TME, intersphincteric resections, ultralar, and molecular testing, that became the part of the evolution. So now 2020 till date, what we see, we now have the concept of totally neoadjuvant treatment. We have the concept of wait and watch coming. We have the concept of recurrence management and metastatic disease management and immunotherapy. These are the new concepts which have evolved, and presently most of the world is working as per these. So what are the current guidelines? What has changed all these years? Core principles are MDT approach is mandatory now. You have to discuss each and every case with the MDT multidisciplinary team. Accurate MRI, values-based stage. That's again the most important because a radiologist has to be on board. Then you have to go for the risk-adapted treatment. You have to label the disease early, locally advanced, or a metastatic disease. And now what is very, very important, the shift is towards the totally neoadjuvant treatment, TNT, and organ preservation, what we call it, wait and watch. This is also emerging as a modality in selected cases. So standard staging workup is important. Colonoscopy biopsy is important. MRI pelvis for local staging is important. See chest, abdomen, plus minus PET if needed. Otherwise, PET is not a part of the basic screening. And CAE for baseline, these will be some important things for the basic. So in the stage-wise management, what's very important, you see early rectal carcinoma we label as T1, T2, and N0. So you may go for a local excision, or you may go for a low anterior resection or APR. But what is the new update is endoscopists, again, the colonoscopic physicians don't leave us anywhere. So they have made endoscopic submucosal dissection also as an acceptable modality for early lesions. Then if you look for the locally advanced rectal cancer, once the T3, T4 or nodes are present, then standard of care is TNT, totally neoadjuvant. Previously, we used to downstage them, do a surgery, then give adjuvant. But now we want to complete the whole course of chemoradiotherapy. Before that, after that, we do the surgery. So the advantage with TNT is better compliance, decreased distant mets, higher complete response rates. So TME, even today, continues to be the gold standard. Sphincter preservation should be done whenever possible. Lateral lymph node dissection should be only thought of in a very, very selective case. One is the lymph nodes after downstaging are still more than 7 mm. So systemic therapy would be there in the form of Folpox, Capox, or Folfirinox in selected cases. Where we can now go for even targeted therapy like anti-EGRF and RAS wild types, anti-VEGF. But immunotherapy is again emerging for MSI high cases, and this makes it mandatory that we know the status of MSI and MMR. But ctDNA, what is projected in the literature, is still a prognostic, but not a routine, not included in the NCCN guidelines. Then RAS, BRAF, HER2 for advanced disease may be needed at times. So what we find in recent advances, TNT is standard for stage 2 and stage 3 are locally advanced rectal cancer. Always first subject them to TNT, then go for surgery. Wait and watch strategy. If you find on TNT somebody has shown a complete response, then you may go for wait and watch. But a very, very strict surveillance is mandatory. Then upfront immunotherapy, if you find MSI high, then you may straightway select them directly for immunotherapy for downstaging. But major goal nowadays is organ preservation and personal therapy, personalized therapy on basis of biomarkers are the hallmark of the study. So then there is a problem with metastatic. If you have resectable mets, you may go for neoadjuvant chemotherapy plus minus radiotherapy, then surgery of rectum and liver together in one sitting. I think we did 3 cases with Yunus, with the help of Yunus, once I was at SKIMS. Then unresectable mets, pulphoxypulphury, then targeted therapy, immunotherapy, they may be for unresectable disease. Adjuvant therapy will always depend on final pathology, response in neoadjuvant therapy. Post-op chemotherapy should be given only in selected cases. But what still haunts us after so many years of working on rectum all over the world, even us, we have been doing a focused work on rectum. What we found, low anterior resection syndrome continues to be a problem, at times frustrating for the patients. Signet cell, mucin cell continues to be a problem. Still not very good at responsive metastatic disease at presentation. Again, if it's MSI stable, continues to be a problem. If the permanent stoma is there, it continues to be a problem. In some patients, ultra-erosive diaper dependence, nocturnal incontinence continues to be a problem. Sexual and bladder dependence, very rarely we find, but it has been reported. Then perineal wound morbidity at times in cases where you have given pre-op radiotherapy and you are doing APR, perineal wounds at times take a lot of time to heal and leaks are always distressing and disturbing. These are still some unexplored areas. I wish the youngsters who are here, they, in the coming years, prove us redundant, they keep on doing better and better. That's where the future lies in. And maybe there is a time once the surgeon has to drop his knife and it's all a game in the hands of the physicians again. Thank you so much. Thank you so much. Thank you so much.
Very nice presentation, Dr. Fazal sir. Very precisely you have collaborated everything. But one thing I want to add that tumor board is a need of the hour nowadays, because there is a coordination between surgeon, medical and radiation oncologist is very important. I think every hospital should have a tumor board these days so that patient can be discussed and a proper treatment protocol should be chalked out before taking the patient. Because surgeon, sometimes they need the help of the radiation or neoadjuvant chemotherapy, as you have discussed it this. I think every hospital should have a tumor board these days so that patient can be discussed in a closed room and a proper treatment protocol can be chalked out.
In fact, that's what we are doing at SKIMS. Colorectal team has always now regular discussions with the tumor board first. Even from SKIMS Medical College, I send the patients to the tumor board. Our FNB students, Professor Roop, they keep on discussing them. Plan is formed, then only we proceed. And that is what is one of the most important parts of the NCCN guidelines of 2025 and 26. It is a multidisciplinary team management. Gone are the days where we would have egos to manage the patients on your own and do this thing. No, it's a matter of life. We should try to discuss and see scientifically, logically, what's the best.
What is best for the patient, that is most important.
And before I say goodbye to you, but I will like to express my real gratitude to Professor Maria Bineet, then Varun Dogra, and Sanjay Basin, who managed all this with a great fervor, wonderful hospitality, wonderful warmth. I in fact felt yesterday evening very much humbled once Varun and Maria were time and again trying to host us and inviting us to one of the other variety. Really, we feel humbled and touched. And it's a beautiful campus. I wish that the students here prove to be very, very global toddlers and global scientists and researchers of the future. Thank you so much.
Thank you for that scientific.
Can I just put in a point? Importance. Thank you very much. The presence of tumor boards. I have been the nodal officer of State Cancer Institute. See, it's mandatory now, not only locally, nationally and internationally, to have a tumor board in every place where oncological services are being delivered. I'll tell you one important advantage, what has come out through these tumor boards. There are cases where a surgeon will straight away go in and start operating the patient, and the outcome would have been different. Now, once you have tumor boards, there are voices from different areas, whether it is radiology, pathology, oncology, or radiotherapy, or the surgeon. All these sit together and see what will be the best modality according to the clinical guidelines being set for a particular emergency. So this would change the approach to the patient management and ultimately have the best outcome. This is what we have found, and it is necessary wherever oncological services are being given. These tumor boards have to be there. Thank you.
Okay, thank you.
Our next speaker is Dr. Sanjay Bhasin, Professor. Sir. He will be talking on surgeons' autonomy versus patient's choice.
Once again, good morning, chairpersons, surgeons in front of me. What Professor Fazal was saying, see, the beauty of Jakasicon is that since its inception, it is continuously developing academic leadership. And the example of developing academic leadership is the founder chairman is sitting along with his students as a chairperson, and many teachers, they are presenting in front of their students. This is the beauty of this association. It must go on. Once again, thank you very much. पहले उसमें मैं I behaved as a Baba, delivering sermons, Magdumi sir. Now my real surgeon. Encounters with rare foreign bodies. ये आगे नहीं जा रहा भैया. वहाँ टाइम खत्म हो जाएगा. ये आगे नहीं जा रहा. Foreign body injection is a common occurrence both in sane and insane people, but entry by self-inflictions, assault or accident is another mode. Quite a good number of interesting and unusual cases have been reported in the literature. Accidental injection is by for the most common occurrence, but insanity, a dare, a habit, or medicinal therapies, there are other modes of entry of foreign bodies inside. Perforation, obstruction, abscess formation, hemorrhage, fistulas, all are the complications. Foreign bodies thicker than 2 centimeters and longer than 5 centimeters, unlikely to pass the pylori spontaneously. Foreign body can be difficult to detect, particularly if they are not inherently radio-opaque. Investigations, ultrasound, CT scans, and selectively MRIs. Most foreign bodies pass through GI tracts, and if they don't pass, they induce a dense fibrosis within the system. Common locations are GIT, respiratory system, body cavities. Notable rare, there are so many rare foreign bodies reported in the literature. Toothpick perforating the stomach, entering into the liver. Multiple needles migrating to liver, colon, duodenum, even to the kidneys. And bizarre is World War II era anti-tank shell lodged in the rectum, and a bomb squad was asked to remove it. Peanut entering into the respiratory cavity and sprouting begins. 1.5 kilogram of coins, watches, jewelry retrieved. But there is a paradigm shift for management of foreign bodies. watchful waiting to open explorations to laparoscopic interventions. My first case was 14 years back when I was an assistant professor, and looking into seeing my dynamism, my head of the unit told me, show me your dynamism on this patient. It was a acrobat who performed some act and swallowed the knife, and the knife remained there for 7 years. Patient presented to us in emergency with acute pain abdomen. My PG, he subjected patient to X-ray. He told me, sir, ये लंबी सी चीज कोई पड़ी हुई है, देखो ये कहाँ से आ गई. मैंने कहा उसकी वो जो एक्सरे वाला नीचे है उसको फ्रोलो जरा, वहां तो नहीं पड़ा हुआ ये knife. How it can enter 7 inches knife? It can enter. We did CT scan, and then ultimately I operated upon this patient, और इसने मेरे पसीने छुड़वा दिए. The C loop of the duodenum, it was almost an extended horizontal tube. मैं कभी फिंगर डायसेक्शन कर रहा हूँ, कभी मैं कैंची यूज कर रहा हूँ, और वो पता नहीं ऊपर वाले ने या किसने नेचर ने क्या किया, मैं फिंगर लगा ही रहा था कि सेकंड पार्ट ऑफ ड्यूडेनम में एक मोरी निकल गई, सुराख निकल गया, उससे हवा ऑफ द नाइफ केम आउट, और मैंने उसको फटाफट निकाला, ड्यूडेनम को बंद किया, फीडिंग ट्यूशनासनी की और नमस्ते किया कि शुक्र है ये 7 इंच का, एंड दैट गेव मी ए लॉट ऑफ रिकॉग्निशन. हर मीडिया ने उसको जो है कवर किया. अनफॉर्चुनेटली द वीडियो 1.2 आवर वीडियो गॉट करप्टेड, और मुझे उसका दुख हुआ. आई कैन नॉट शो दैट वीडियो. अनदर फॉरेन बॉडी, एक छोटी बच्ची, उसकी माँ रजाई बना रही थी, सी रही थी, उसने वो सुआ जो होता है लंबा सा, उसने सीधा उस पर रजाई पे रख दिया. बच्ची आई स्कूल से, वो सीधी उसके ऊपर लेट गई. The needle, big needle, entered from behind, and it was again a situation for us. We subjected her to all those things, investigations, and then a small video. I tried that. I contemplated laparoscopic removal. Only small video. First standard port, second port from the stem, and then it was difficult to pinpoint it, but there was a ray of hope. Just at the dome, we could see one sharp thing, just a small tip. There was some problem initially to localize, but this wonderful instrument, retractor, fan retractor, it gave us a little recipe, and this was the area, small dimple. See, small pin. When 15-20 years back, thoracotomy might be the only option. Third one, a nail cutter. This is again how patient misguides you. A small girl, 23-year-old girl, roamed from here to there, from district belt Rajouri, went to DMC Ludhiana with history that she has ingested the nail, this nail cutter. We were also in a dilemma कि ये nail cutter ingest किया, चलो हमने भी ये सोचा कि ingest किया है, हमने भी जो test available थे वो कराए. I thought, okay, let me put in the laparoscope. I put in the laparoscope. I could not find where I was expecting this foreign body to be. Invariably in the sigmoid colon, but it was in vagina. We had a tough time, dense fibrosis. We had a tough time in retrieving this nail cutter. I gave a lateral incision and then could retrieve this nail cutter. And after that, I asked my registrar, female registrar, to this is the fourth one. A wooden this thing, foreign body, entered from behind and came out at epigastrium. Fortunately enough, there was no major injury. It pierced the mesocolon, and I asked Talib to show his dynamism, and he showed his dynamism, and we could retrieve this foreign body. This is another foreign body, a laborer in conflict, and a pickaxe went inside. We subjected him to all investigations, and then there was only 2 small perforations in the lungs. We involved our CTVS surgeon, and we could retrieve the and this is a 6th one. A needle entered into antrum. The endoscopist, he was not so confident, and where the confidence of all other specialties that is gone, the confidence of surgeon comes into play. We subjected this patient to laparoscopic removal, and we could get this pin out laparoscopically. Unfortunately, the video was erased from the TV set by we could not. So foreign bodies are interesting, and many times are diagnosed incidentally in various parts of human body and can cause significant harm. Management can be challenging. It involves various modalities, endoscopies, laparoscopy, exploration, and now laparoscopy clubbed with your C-arms. Ultimately, early detection and appropriate management can prevent serious complications and improve patient outcome. Thank you very much.
Thank you, sir. Thank you for the nice presentation, sir. Sir, foreign bodies, like in adults, in pediatric patients are also very notorious. More so esophageal and airway foreign bodies. So, being a surgeon, we should have lab exposure to deal with them. But I feel for pediatric, or even for the adults also, being a surgeon should have little bit knowledge of endoscopy as well as the bronchoscopy if need arises to retrieve the body.
Right. Thank you, sir. Our next speaker is Professor Dr. M.R. Atri. He will speak on safety and efficacy in mini gastric bypass in obesity, our experience in GMC Srinagar.
from GMC Srinagar. A very good morning to chairpersons. A very big congratulations to Dr. Maria and Dr. Varun, who happens to be our student and making us proud. And a big congratulations to Jakasicon for having such events and organizing it in a wonderful place like AIMS Vijaypur, which has been one of the best institutions in Northern India. We aspire. So when I asked him, he told me to speak something about obesity because this was lacking behind, and why it is important because obesity is becoming 21st century epidemic. And as a surgeon, I no longer view obesity as a personal failure, but as a complex, chronic and progressive metabolic disease that requires active intervention like any other disease like hypertension or diabetes. So this was the basic classification. Class 1, obesity. Class 2 and class 3, BMI are more than 40, more than 30 in Asian population has been from American latest guidelines. Why it is important for India? Because, and for all of us. Because 1 out of every 4 person in India is obese. So that's a problem. And that's the reason this is becoming more and more important. And as per our National Family Health Surveys, 4 and 5, you see the progressive increase of obesity from last, these 2 surveys from last 10 years. All age group is becoming obese. And there is a urban and rural divide also. You find more obesity in urban pockets and less in the rural areas, as the reasons we all know. What are the reasons? Because of our sedentary habits. Portion from last, you see 20 years survey, again showing increase in obesity both in men, women and children, along with all the morbidities of high blood pressure, sugar, diabetes and OSA and all those morbidities associated with the obesity. So what are the risks associated with the morbid obesity? So whenever there is obesity, it comes with plethora of problems like insulin diabetes, like cardiovascular disease, arthritis, cancer, whether it is a CA breast, CA colon, OSA, obstetric sleep apnea, psychosocial problems, increased suicidal tendencies, low self-esteem, infertility. So all these plethora of problems comes with obesity. And these are the statistics which show from various studies that CA breast, these patients are prone to more ovarian cancer, colon cancer, diabetes. So now the modern pill which has come into play. So medication versus surgery. So where we stand. So modern day pill is not all what we see because we see over a period of 10 years that the absolute risk reduction is much higher with metabolic surgery than with the semaglutide or Monjaro or whatever Ozempic we are using these days. And the most important thing is cost. So if we have almost 10 times the bariatric surgery. So if you have 1 lakh rupees, you will try to cure 10 patients rather than 1 patient. So that's where the medical therapy as such, once you stop it, the weight will regain. And it doesn't come without side effects also. So this is a gateway trial where American College of Cardiology has compared role of bariatric surgery over a period of 10 years in hypertension. So they have found that bariatric surgery in obese patients represents an effective and durable strategy to control hypertension, and it's so effective that most of these patients were without any antihypertensives. These are the latest guidelines of 22 from IFSO, where they have decreased the indications for Asian populations because Asian population are prone to comorbidities even at much lower BMI than the Western counterparts. So this is what I was supposed to talk. So this is a long-term follow-up of OABGB. One anastomosis or mini gastric bypass, as it is called mini, but it is not a mini. It is a mini gastric bypass with the maximum results. So they have analyzed over 20,000 patients over 14 countries, and what they have found is after 5 years, excellent mini gastric bypass, excellent weight loss, increasing beyond 5 years. It is almost remission of diabetes in 80 to 90% of the patients, 30 to 40% of hypertensives were remission and OSA. So long-term weight loss, it can maintain up to 90% maintain over 50% of excess weight loss with mini gastric bypass. Now a bit of comparison between RU and gastric bypass, which is the most common procedure which is being done, and OAGB. So over a period of follow-up of 10 years, it has been found that both these procedures are equivalent. And why not to prefer one anastomosis over two anastomosis and a more complex procedure with more complications, more chances of internal hernias than the single one anastomosis. So where we stand in GMC syndrome. So from last 5 years, we have done almost 260, 70 patients of bariatric surgery. We do almost all sort of procedures from sleep plus, RYGB, SORDI, and then we have finally focused on the OAG1 anastomosis. So almost we have done over 200 patients by now. And this is how we do after diagnostic laparoscopy in a patient in a lithotomy position and liver being retracted by the Lithon-Sons retractor. We make a gastric tube along the lesser curvature. So we make a retrogastric window just proximal to the pylorus, just end of the you see cross foot, and fire a horizontal strapular from lesser curvature towards the gastric curvature to make a long and wide gastric tube. So we place a bougie, almost 38 to 40 size bougie, because we don't want to be a very tight like sleep gastrectomy. So we want a very loose and long gastric tube. So these vertical stapulars, where we can use any stapler which is available. We can use purple stapulars, we can use all blue cartridges, we can use the tri-staple, whatever is available and as per the convenience of surgeons. And as we move towards the angular face, we have to make it sure that we are not snugly with the esophagus. We have to be almost 1.5 centimeter away from gastroesophageal junction. So angular face is very, very important. And once that is done, then we make a loop gastrojejunostomy. That can be anterior, posterior, lateral. It has to be lateral anastomosis, a loop gastrojejunostomy. And a BP limb of appropriate length is selected depending upon the BMI, ethnicity, and the morbidity. So usually 150 to 200 centimeter of BP limb from ligament of reach to 200 to 180 to 200 centimeter, depending upon the BMI. We bring this loop and create a loop gastrojejunostomy. With again a blue cartridge, making sure that your anastomosis between the stomach and the jejunum is around about 4 to 6 centimeter. Why? Because you are making a gastric tube of around about 20 centimeter. If you are making a anastomosis of 4 to 6 centimeters, still 14 to 16 centimeter of gastric tube should be there to prevent a reflux or a gastroesophageal reflux disease. This is the optional suture, anti-reflux suture, which is usually given, not must, but we usually apply it to make, prevent, decreases the incidence of reflux. And once the stapular site is, marked for there is no bleeding or there is no other issue with the staple line, then we close the stapular opening, and after doing a leak test, we place a drain. So this was the data. So most of our patients were diabetic, take on insulin and oral hypoglycemic agents, along with hypertension, OSA, and dyslipidemia. So this is over the period of time, as the time has increased, our operative time has decreased to be almost 30, it takes 30 minutes, half an hour for doing a MGB, and hospital stays as less as 3 to 4 days. So these were the outcomes. We see the mean preoperative weight from 104. At 6 months, it has come down to 81 kgs, and BMI from 43, 44, it has come down to mean of 33. So a drastic decrease in BMI within 6 months of OAGB. So this is a faster and quicker procedure. So this is serum triglycerides. Again, it has come down to this thing. And so far as diabetes is concerned, most of the parameters are, a mean HbA1c of 9. It has come down to 5.9 in almost 12 months of follow-up. So most of these patients are off the drugs. So this is our experience. As the BMI has fallen down, so is the diabetes. And in the follow-up of 1 year, most of these patients have HB1AC of 5.9. Same is true for most of these patients are off antihypertensives within a follow-up of 6 months. So these were the few complications which we saw. We had almost marginal ulcers in few of these patients. A few patients had port-side hernias which were closed laparoscopically. The drastic thing is cholelithasis, which you see after 6 months to 1 year of follow-up, we have many patients coming out with the gallstones, and incidentally, we don't do prophylactic cholecystectomies in these patients. So we have to subject lab chole in the follow-up of these patients. And in few of the patients, we have weight regain after follow-up of 3 years. So these are the patients which need our supervision and a prolonged follow-up. So in conclusion, mini gastric bypass is combined simplicity and a powerful metabolic outcome, making it one of the most efficient procedures in modern bariatric surgery today. Thank you so much.
Thank you, sir, for the nice presentation. Any questions?
Professor Atri, nice presentation, excellent. I just wanted to know what is the status of standing up bariatric surgery vis-a-vis the new drugs or weight decrease.
I think in one of the slides I showed, because of these modern day pills which have come out, and people are, you see, they are over the counter now being available. Most of the people are endocrinologists or you see into these drugs, GLP-1 analogs. They are effective, but they are costly. One is costly, and they are not, you see, they are not without side effects. They have side effects over a prolonged period of time, like acute pancreatitis, osteoporosis, and many other side effects. And when you level it as in the cost at the end of their this thing, you have to take it lifelong. And they're costly. They cannot be, and the compliance is poor. After 6 months to 1 year, people try to stop it and then regain the weight. All these analogs are now available in the local markets, and endocrinologists are very fond of giving them. And they are very useful, especially in super obese and patients of, you see, BMI of over 50. Even if you lose 10% or 20% of these super obese patients, their OSA goes off and they become surgically fit to subject them to be any other bariatric surgery procedures. So the role of these drugs for controlling the blood sugar and controlling the obesity is mostly in super obese and other patients, where they can be, you see, it's a time buying. You can start with these semaglutide or GLP-1 analogs and watch these patients. Once they clinically become fit and their comorbidities come down, their sugar gets controlled or their OSA gets controlled, you can subject them to bariatric surgery, whatever the procedure you decide.
Dr. Atri, sir.
Sir.
Thank you very much. It was a nice study you have shown. But the question is, you didn't tell us about how many times you felt sorry and there was complications, manageable and non-manageable. Second thing is what I have seen when I traveled abroad in different places, especially I noticed in the wards as an observer that management of obesity in underdeveloped countries is much more different than management of obesity in developed countries, although there's a challenge is bigger there than what's in the underdeveloped nations. But I think that once an endocrinologist and a diabetologist or anything, or a physiotherapist and other things, once they have all joined their heads and they tell the surgeon, now there is no other way but for management, please take up the case. Because whatever we do, we have to be ready for, every surgeon has to be ready for the complications, if any, encountered. But what I have seen here, I have noticed it that two things were there, that we don't have such fast and honest and dedicated teamwork in our wards where things will come and join seriously hearts. And second thing is, I asked one of my senior colleagues who was doing how many complications. He told me that he has done 200 cases. So once by the chat, I told him how many you suffered in a complication and what headache they gave you. He didn't tell anything. So I want your viewpoint on these 4 points.
You
Thank
see,
you.
that's a reason we have switched from, you see, RYGB and sleep gastrectomies to one anastomosis, mini gastric bypass, because this is a simpler procedure. This is you see, a very fast, short operating time, and there are no chances of internal hernias. RYGP is a complex procedure. There are two anastomoses, more chances of leak, more chances of internal hernias. Sleep gastrectomy we used to do, you see, a few years back, and now the patients are again coming back with a regain of weight and a bit of, you see, resurgence of diabetes. So that's the reason we, in these Asian patients, we have, we are focused on this thing. And in our department, we have a full-fledged. Most of these patients come from endocrinologists. They work out these patients, and then we have a classified bariatric units. In 2-3 units, we are doing these bariatric procedures, and we have a good team which backs us up. And till now, most of our patients have gone home very nicely, and at the end of follow-up of 5 years, we have been quite satisfied with the results what we are getting. Thank you. Thank you,
sir.
Right. Right.
We have crossed around 250, I think.
250, yes. 260.
So we started around 2017, and now probably it is 9 years, say 7 years. And data is not much. 250 would probably be level 1 evidence. And commenting at this rate, I feel so small to talk efficiently, scientifically, to talk them. My worries are regarding Professor Fazal sir asked about the drugs. Yes, there's a lot of these drugs coming up, GLP, CLP. That's all there. But the tune of drugs with the effect of the weight loss is only 8 to 12 maximum achieved.
So it can be up to 20%. Up to 20% you can lose.
You can
these
lose.
drugs.
So it will be around 8 to 12 kg. But people like BMIs of 50, supermodels, what we call as, would apply to them. Especially if you are putting them on drugs, as rightly said, colonic carcinomas, diarrhea. There are lot of problems. They play havoc with them. They're not very safe, plus the cost. So what is now considered is that it has to be a pharmacotherapy. Surgery has to be bridged between the pharmacotherapy. So you give them a optimization time of that drugs. Then they stay, say 12 kgs. It gets the liver down. They have a supermodel's liver of 12 kg, 8 kg liver. Very difficult to hold with laparoscopy. But it does optimize the patient vis-a-vis making the surgical technique easy for the surgeon. One. Second is, of course, they do control the diabetes and metabolic problem to the tune of 20% weight loss. But for case BMIs of 50 is not an answer. They will have to go to some malabsorptive or restrictive procedures, like MGP is a combined procedure. My worry is because we are too early. I won't stand here scientifically right if I comment that this procedure is good for us. As Kashmiri population, the rice eaters, our literature should be different, observation should be different from the West. We are applying. It is not obesity. Obesity is not much in a way that the way you say weight. Let us understand there are thin obese patients. Thin obesity is a different thin obesity. Thin obesity means you don't have weight, but you have all the metabolic problems, which have touched to level 3 drugs in diabetes, 40 units. What are you going to do with these thin obese people? So for them, the answer was, there is a consensus was that you still can give them metabolic procedure, not a bariatric. This is a concept now. Bariatric will divert from the metabolic. It will be an endocrinologist, a surgeon, not an endocrine surgeon, endocrinologist. So he will manipulate their gut because most of these problems are into the 200 centimeters of the jejunum, where the most of the metabolic problems are. This concept was from Taiwan. And this man is 40-year-old, just 40 years. He was banged in his place, Taiwan. But America concepted this procedure of BJP. We did 2 cases. Next day we found hypoglycemia. We had to get the endocrinologist of Hayat and put him on glucose. It went to 25. She was on 40 units. So the concept is that this 200 centimeter, leave 20 centimeters from the DJ, then go for 200 centimeters of jejunum. Most of the metabolic problems, especially diabetes, comes from here. The concept of CLP, GLP is again this. So what do? In the proximal jejunal bypass, they bypass this part of the gut. The food will not reach there, so the contents will not be absorbed. Then the second point was, to what extent which procedure suit us?
Professor Fazal sir, I have just one more area where these drugs, as you have asked me, one more area, because we are seeing so many of incisional hernias in obesity, and we are seeing so many hernias these days. There is a loss of domain and huge incisional hernias or primary ventral hernia.
That's true.
So these are the areas, these are the patients. If they lose 15, 20%, 15% of the weight,
not only
incisional
hernia, NASH is included by American Bariatric and Metabolic Association. European Association also includes now NASH, should be taken by the Bariatric.
Thank you, sir. We are running short of time. Thank you.
Thank you, sir.
Thank you so much. Thank you.
We'll move to the next topic by Dr. Mushtaq Chalgu, laparoscopic D3 right hemicolectomy step-by-step approach. Sir, please.
Still, good morning, all of you. Thank you very much, organizers. Dr. Maria, thank you, Dr. Varun, and listening to my tantrums, as I always. So, adjusting my talk here. Thank you. And a great job done, as already agreed on by all the people. Chairperson, sir, I will start my presentation. I'll be talking on how I go to the right colon and what is exactly makes the D3. So this is some of our humble contributions, and I would also thank at the outset all those authors who contributed to the book which we edited. The book will be marketed in next month. Thank you all for contributing to this. We'll have a wide distribution globally, and I'm sure it will help all of us for understanding the new insights of different topics. What exactly makes a CME, CVL, and D3, if you totally name it? This is nothing but different perspectives of the same job, what Japanese and Europeans proposed the concept, because as we understand, the lymph node is an understanding, lymph node is a concept in malignancy, and as long as we don't address it, then it is probably unethical surgery, because it's an oncological surgery. It has to be done precisely respecting the guidelines. Now, what makes DV, CVL, CVL, and CME in right colon? It is simple. There is no confusion in the right colon. Vasculature is very simple. You understand D1, D2, and D3. But the concept of D3 would be laying the SME left and open. But the problem occurred on the left colon. There was a consensus in the last decade by the colorectal surgeons, and they assembled. They said, what makes D3? Because everybody presented his concept of D3 in the left colon because of the vasculature problems. The vasculature problem and different critical points made it that there could be a, SRS preserving D3 and SRS sacrificing D3. So as most of the people were confused, a consensus was generated. Let us have a study on it. Study is 6 years study. This we call dilemma study. It will be published in 2029, and the final publication will come in 2031. Most of us will be retired, sir, and I don't know, the young people will tell us what was the study all about. This is only 35 colorectal high volume centers are doing this research. They will tell us what exactly D3 is for left colon. As of now, everybody is justified calling it D3 for the left colon. Right colon, there's no confusion. Now, what exactly makes is on the specimen, when you, pathologists will tell you whether you have done D1, D2, and D3, that's the mesenteric length around 7 to 10 centimeters. Beyond that, probably there's no window in the areas where it should not be. That would make D3. You could see, you can measure the specimen from the apical node to the epicolic node. These are four, the draining centers. If it is beyond 7 centimeter, probably you are justified saying that you have done the DME, and the video will be checked. That's the idea, whether you have done it precisely, calling it D3. So that is the concept. Now here, it's a very interesting picture. Please just concentrate on this film. That is what exactly makes SMV. It's a all game of SMV. And unless you see this vein quite naked, probably you are not just fine doing, and you need not to see the SMA, but SMV needs to be, because the medial margin, the right margin is enough to entangle the T3 lymph node, which probably gets a prognostic value to the surgeon. And then when I will show you the video, I will show you what exactly makes the embryological plane, the posterior peritoneum and the mesenteric pocket. If you follow that, luckily CME falls into TME. So it's the one road which will go down, as Fazal sir rightly said, the CME will merge with it. But you should know exactly where not to change the road. Because if you make an injury in the mesenteric pocket, some of the nodes will stay back, probably you are not justified. And in laparoscopy, let me frankly tell you, it's one go. Yeah? You just slicing and it lifts itself. The left of the things on the top, or the what we have to remove, things down, or important structures, retroperitoneum. We don't want to go through that. Now, the European concept was length of bowel is also important, which we ignored, because 10 centimeters, depending on the leash of the mesenteric vessel, it will supply up within 5 centimeters. That's very important. We have to address the bowel length, which was consensually said by European concept should be 10 centimeters. That is the supply, and beyond that, it. Now, different approaches came. You said medial, lateral approach, superior approach, but concisely, scientifically, you follow an SME approach and a subvelial approach. But what we propose an SME and subvelial mixture of two. You cannot go purely SME. You cannot do purely subvelial. Do a hybrid technique of SME subvelial. The planes will open out themselves, and you will move up towards the TC. Now, these are the few of the pictures. We did almost 8 thesis projects on it. We have crossed around 300, 250, and 300 colectomies. We've had a global meet on this, and the concept of a hybrid technique is very well taken. This, you can see the mesenteric pocket, you see, and we make a functional incision in the 4th port and convert it to 3 centimeter wide the colon can come out. It's a compressible organ, so it doesn't matter. This is a single cell. I have not revised my records, the data, all the videos, most of the videos are with us. So we revised them. We have published 3 research articles, highly referenced all along. And then the YouTube channel, as you all understand, it's a thankless job. We keep on doing, updating, and so that everybody understands what humble contributions we do on this concept of. I'll just go for a small video. My idea is to show you what exactly should be done. Where should ports be placed for D3? If you do D3, then your port, its anatomy of vasculature of SME can be studied by doing D3. So the patient is supine, you can see. My idea is just to make a port. I will make a port quite 5 centimeters below the umbilicus. That will be my optical port. I will make a right suprapubic port, and the left hypochondrial port will be the stapler and working port. These are the ports, and the 4th additional port, accessory port, will be on the right side in the iliac fossa. I remove my specimen from there. So you can see that's the cecal tumor here, ileocecal region, some adhesions. Anything beyond T2 and 1 kindly do omentectomy. Do a good omentectomy, because omentum is the residual area where your, the relapse would come. So this can see a bulky cecum, ileocecal region, 10 to 15 centimeters would be enough. Beyond that, so what I would do is I would study the vasculature first. Now you can appreciate that the vasculature anatomy of the SMA should be luckily a good patient for demonstrating this. I'll go a little hurriedly because I want to kindly watch the actual video on my YouTube, because that is not edited. Most of the times I publish unedited videos. So push up the supracolic or subhepatic, hold the colon, put it up, expose the vasculature of SME. Now you can appreciate these veins. They make the contributions to the SME. We are doing a right hemicolectomy. Now, where should we start with? SME is basically a vein which is a very important vasculature, contribution to the splenic vein, to the portal, to the liver. These are jejunal veins on this one side, And on this side, there will be the tributary ileocolic vein, right colic, middle right branch, and all that. Appreciate I'm trying, this is assembly. Can you appreciate what I'm showing? This is an assembly. It will go up on the anterior surface of the pancreas and give gastrocolic trunk, which has a lot of variations. So be aware about the variations of gastrocolic trunk. So where should the incision be placed? Come down, start it and the L pocket. Now what exactly is L pocket? Hold the middle colic pedicle up. Start at this L pocket. Be precise. You see, if you are in the right plane, there will not be a drop of blood. Open the mesenteric pocket. In the mesenteric pocket, SM will be traveling. It is formed by Q of the jejunal vein and the Q of the iliac veins and the right jejunal first vein. It will stop. Now you can see SMV quite naked, and the lymph nodes that surround around it actually are from the arterial, that's SMA, which will lie on the left side of the SMV. We should not overdo zealous efforts to expose the SMA, but SMV has to be. And there is a different, we have seen almost all kinds of varieties of anteriorly traveling ileocolic, posteriorly traveling ileocolic. Anterior traveling ileocolic will be easy, but posterior traveling ileocolic will be very jeopardy. Now appreciate SME is totally, we are working on SME, not that we are distantly seeing SME. You can appreciate the ileocolic pedicle is getting groped up and very precise dissection has to be there. Mesentery is highly vascular. Don't tear it. There is a lot of bleeding. Now you can appreciate ileocolic pedicle very close to the SME, a flush ligation, what entails the what's called as D3. Besides precise, you can suture, you can put hemolog, you can put clip B, whatever you are available. Nothing great about that. Whatever is available, you can suture. Most of times we now suture with a single hand suturing. It reduces the cost. But in the beginning, you may probably look to take a benefit of the clips. They make the precise time. Now here I will enter, I bolt subileal. I will partly go subileal, partly do SME. Stay in the combined hybrid way because the duodenum will come in. You can see the duodenum. You can see, appreciate the vein coming on the top. Please appreciate this vein. This is the vein from the gastrocolic trunk. Now, as you go up, you will ligate first SMV, ileal vein, ileocolic vein, then ileocolic artery. Don't pull much. Now grow along the SMV. Please appreciate this picture. You are seeing SMV quite naked and everything is yellow there. So how do you differentiate? The yellow of the pancreas in the C loop of duodenum is like a butter color yellow. But the mesenteric fat yellow is different yellow. So don't, and that's what I was saying, that you should know everything yellow, yet different thing. So follow that generous plane. You can see it's not an edited video. It's precisely we are going because we appreciate the anatomy. If you know what comes next, you will know how should I go all along it without causing bleeding. Now we are exposing the gastrocolic trunk. Gastrocolic trunk predominantly is the right gastrocolic vein, right superior colic vein, and it is also sometimes the pancreaticoduodenal, but preserve that. But if you not, you can ligate. If D2 is involved, which they precisely say if you remove it, Japanese quote it with a name, then they say you have done a religious D3. If you remove that colic vein. But otherwise, you should preserve the pancreaticoduodenal veins. But you can take the right colic, you have to take the right gastrocolic, you have to take the superior right colic vein. Most of the times, right colic veins and right colic artery, we don't see. Most of the time, around 20-30% you will not cover. Now kindly appreciate how to go. Do not cauterize them. These veins are messy. Even if you find a small vein of the gastrocolic vein, ligate it. There are high pressure veins, they are directly going into the SME. So appreciate that you are exposing these veins, and an exposure of SMV will tell you that you are probably removing the lymph nodes at the same time. You can see the gastrocolic trunk at the anterior border of the pancreas, making a what's called the trunk of Henle also. These are different variations. Then after ligating them, this is duodenum, that's pancreas. Then middle colic artery can be seen here. I hope you appreciate the middle colic. So if the tumor is in the cecum, just take the right branch. If the tumor is ascending colon, then you may even jeopardize the main trunk of the middle colic. Now, at this point of dissection, you can see SME from the beginning to going up. Now, go all along the margin. Don't change to the lateral vein. You can still go and clip them and then cut. Don't ligate sometimes. Now, so you can see the middle colic artery is in my hand. I will only take the right branch because cecal tumor. If I can take the middle colic also, just believe the Drummond's is enough to sustain, especially not in diabetics and high age groups. You can take, it's a beating vessel in my left hand. So precisely clearing the lymph nodes and then taking the right branch of this is the right and left branch which will contribute, go to the either side and contribute to the marginal artery. And this should be precisely taken to help. Please appreciate this point. There is no rent in the mesenteric pocket. If you make rents, probably you will probably lose the field. The appreciation is the road to the D3, road to the colon. You see, which is in my left hand, what is in my left hand is the mesenteric pocket. And what is down is to be preserved. So you can appreciate, I will not make a hole. You go to lateralize, enter into the, now you will here you will enter into the Todd's fascia. Todd's fascia anterior, Todd posterior superconductor. And the mesenteric pocket will be attached. Lift it and drop the duodenum down. As you drop the duodenum down, move all around up. Put the clips. Now I will go to the middle colic pedicle. Beyond that, I will cut it. Then I will go up towards the TC, depending on where exactly you want to cut it. If you want to do little extension of it, if the tumor is high up in the ascending colon or hepatic, probably you may take more of 2/3 of colon. Otherwise, 1/3 would be enough to do that. Then I will do omentectomy. Now I am going supracolic, doing a dissection. Gastrocolic ligament, 1, omentum, 2, and the mesocolon. These are 3 things attached to TC. Don't confuse. They are all yellow things, but they have different attachments on the colon. Everything has to be stay very close to the TC. Don't leave this fat over there. This omentectomy should be done beyond T2 and 1 M0. Below that, no need to do omentectomy for benign lesions because there could be a residual tumor in this, and patient may come with a residual tumor. Then you go up. What I do is I go close to the margin of the subpyloric region and take the right gastrocolic vein there also, because it will come from gastrocolic trunk, go up and enter the lower border or lower the greater curve. So now we are doing the omentectomy has been done, moving towards the hepatic flexure of colon. Now I am moving to the hepatic flexure of colon. As you can appreciate, when you lift to the TC, you should see whole game naked. What should be seen? Stomach, then pancreas, then should be seen the SMV. SMV should be seen in the whole scenario. And one go, you should see it from beginning to the end. At this point, you can go lateral and do a lateral dissection. But it is important to take care of these vascular. This is right gastrocolic vein, which is going to the subpyloric region. See, we have taken it at one place. That is the gastrocolic trunk. But don't forget that you have to take it at the subpyloric region, where it will turn with the right gastrocolic artery. So as you go around this, you will move up. You will take it here also. This is the artery and the vein, right gastrocolic artery and the vein. You take it here also. Then I will move all along, just dropping the pancreas. You can see. There is no hole in the mesentery. Sir, just 30 seconds.
You are already
just 30 seconds. So, ileum can be cut there. You are taking the ileum. Lateral dissection is easy, no vasculature there. Lift it from the ureteral, gonadal vessel and all that. Just the specimen should be packed suprahepatic. So we have to do this is SME on make it on the border ileocolic anastomosis should be done. We religiously close the defect. This is a defect, mesenteric defect, Alzheimer's defect, which we have to do. Is there any questions?
I think it's over now.
Thank you, sir.
Thank you.
Thank you very much.
So, with this, we conclude this session.
So this has been since our 2011, we took first colectomy. Until now, religiously, we are following 4 ports. We make optical port for D3, we make it 5 centimeters below the umbilicus on the left side. Advantage is because if I do D2, I will go through umbilicus, optical. If I go below, I will do a good dissection on SME because then SME will not be available. Why? If you see the target organ, SME is a target organ in D3. So it should be 15 centimeters. Optical port for better resolution and better dissection should be 15 centimeters. That's what I learned. I was doing through umbilicus. I was struggling doing a dissection on SME. When I am away from it, that made me to know I should go away. Optical port should be away. So the fourth port, which you must have seen, is an accessory port on the right iliac fossa. We convert that finally into incision and take the specimen 3 centimeters. And finally, we are left with 3 ports. One scapular port on this side, one optical port, and one left. This port we convert into functional, and it is just a 3 centimeters. Huh? Specimen extraction.
Thank you everyone for such an enlightening session. May I request our chairperson, Professor Dr. Nisar Chaudhary sir, to felicitate Professor Dr. Sanjay Kumar Bhasin sir.
Do you get difficulty in sort of retracting the hepatic flexure or pulling it down because your assistant is handling only one port?
Sir, I did not listen.
Because you are using 3 ports on your side, where you are working, you are giving 1 port to the assistant. Does that give you any difficulty because he's not able to?
And much of the job is done by, you see, it's just an accessory. Laparoscopic surgery is it is the hands of the surgeon because multiple actions are done. So if you are precisely experienced, you can handle that part of his part also. So precisely, he will say, lift that middle coil. Yes, and you are doing the research. Lift the ileocolic. Listen, go towards.
I request Professor Dr. Ravinder sir to felicitate Professor Dr. Fazal Pare sir.
Yes, Professor. Thank you, sir.
I request Dr. Vijay Kundal sir to kindly felicitate Professor Dr. M.R. Atri sir. I request Dr. Vikas Gupta sir to kindly felicitate Professor Dr. Mushtaq Chalku sir.
Greetings from the department.
I will now request Dr. Bashir Ahmed Mahmood sir to felicitate our chairpersons. Professor Dr. Nisar Chaudhary sir. Dr. Ravinder Kumar sir. Dr. Bashir sir, to please felicitate all the chairpersons. Yes. Dr. Vijay Kundal sir. Dr. Vikas Gupta. Thank you, everyone. When it comes to thoracic surgery, every breath counts. So does every decision in the operating room. With this, we welcome you all to insightful session on thoracic surgery. I have the honor to invite our esteemed chairpersons for this session. First is Dr. Rajendra Prasad sir. Sir is Professor, Department of Surgical Disciplines, AIIMS, New Delhi. Professor Dr. Ajaz Ahmed Malik sir. Sir is Professor and Head, Department of General and Minimal Access Surgery, AIIMS, Saura. Next is Professor Dr. M.R. Atri sir. Sir is Professor in HOU, Department of General and Minimal Access Surgery, GMC, Srinagar.
Professor Dr. Pranav Sharma sir. Sir is Professor and Head, Department of General Surgery, GMC, Udhampur. Dr. Sartaj Guru sir. Sir is Assistant Professor, Department of CTBS, AIIMS, Jammu.
So for this session, the first, this is a session now. Thoracic surgery. The first speaker is going to be Professor Ramkaran Chaudhary. Dr. Ramkaran Chaudhary is a professor of surgery at AIIMS Jodhpur. I'm lucky to have been associated with him. He was at some point in time our senior resident. And very nice to see him grow and progress in life. And he's going to talk to you about robotic thymectomy, benefits and limitations.
So good morning and thank you, sir. I have been a student of Dr. Rajendra Prasad, sir. I worked in Unit 3 at AIIMS Delhi from 7 to 10, and Dr. Arvind Kumar and Dr. Rajendra Prasad were teachers and mentors. Right now, I am working at AIIMS Jodhpur. So greetings from AIIMS Jodhpur, and thank you, Dr. Maria and Dr. Varun and their organized team for giving me this opportunity.
Professor Ramkaran, kindly be close to the mic.
Yes.
Thank you.
Okay. So, robotic thymectomy in myasthenia gravis, I think, and kind of established surgery. And I will just say my kind of initial experience at our institute of 25 cases of robotic thymectomies. So, thymomas, rare tumors, myasthenia, kind of rare disease, but we thymectomy is an established indication when myasthenia gravis, especially when thymoma is associated. So this was the landmark trial which established that thymectomy has established this role of in managing these patients. And there are a number of publications which are showing that minimally invasive thoracic this thymectomy in the form of weights or maybe robotic far better in immediate post of recovery in these patients. So sternotomy was the traditional approach, but nowadays most of the surgeons prefer doing weights or robotic approach. Remember, in thoracic surgery or in thymus surgery also, it's better to place a double lumen tube. You need a good anesthetist. Patient position is very important. You need to position the patient well that the arms of the robot does not strike to the patient, especially the shoulder. Usually 4 forts, so 3 forts are used, and the 4th one is assistant port, and the uppermost port. The uppermost port is usually in the second intercostal space, in the anterior axial line, then the middle port kind of in the 3rd or 4th intercostal space in the mid-axial line, and lower down in the 5th or 6th intercostal, again in the anterior axial line, and behind will be the assistant port. So you can approach the thymus from the right side or the left side. I started doing it from right side because you have more of space on the right side. So it's one of my initial surgery, third or fourth surgery. I started using this with this hook. So this is monopolar hook. So now I've shifted using this bipolar Maryland in the right side and bipolar this forceps in the left side. So we use usually 5 to 6 mm of this positive pressure, so that especially on the left side, that you can push the mediastinum to the opposite side and you have enough space, working space. So bleeding is not that much issue, but especially you have to be very careful when you operate near the innominate vein, that you take care of the thymic veins if draining into the innominate vein. So going into the neck and especially taking down the both the thymic horns. And the next patient. So this was the left-sided approach. So always have a good look at the that CT preoperative, where this thymoma is localized, and you can choose the approach. So it was obviously on the left side, and just dissecting around this phrenic nerve. Always preserve the phrenic nerve. Sometimes invasive thymoma, you can. And you have to sometimes sacrifice on one side. But always try to preserve this phrenic nerve. So again, dissecting down. But what I realized and have seen that there was issue, or I felt difficulty in dissecting the pericardiophrenik thread down. The upper port will strike the patient's shoulder. So lately, last 3 or 4 cases, I have shifted kind of doing this subjective approach. That made me confident at dealing with the pericardiophrenic thread, as well as having a look at both the phrenic simultaneously. This was right side approach, so left side approach. So this is what Dr. Vijay CL mentored me. So starting with 2 ports on the left side when we approach the subsequent way. So creating or clearing the fade down and just inside the food area inside, then putting the 8 mm port, and then the left side port, 8 mm ports. So you have total 4 ports, 3 robotic ports. So before looking the robot, you have already cleared the pericardiophrenik fade on the both sides, because you will be going inside, and then you need that you clear the fade down, and then you can proceed upwards. The only thing you have to be careful that you can hit the sternum and don't damage the internal memory vessels sometimes, because the space is quite limited. So it's the bipolar, this Maryland forceps works better, and you can simultaneously have this bipolar energy source in the left hand also, and I think that works better. So only 25 cases, but what I've realized that I now feel comfortable with this Maryland bipolar forceps. Sometimes it can the whole of this tissue can get bulky. So what I do is that I can usually take the pericardiophrenik fade separately, and then rest of the thymus and the upper part together. But as far as special, we should try that we can take it as a single specimen. But definitely, when you look approach the right side or the left side approach, there may be sometimes difficulty when you want to have a look at the opposite phrenic. But I think this subsequent approach will make the things better. But you have to see a case-to-case basis, not always subsequent. You have to see the patient, the CT, and the mass where it is exactly lying. And obviously, 7 to 8 centimeter, I think, is I feel comfortable. But then you have to be prepared for plan B. So these are the all 25 cases in last 3 years we have done. So left-sided approach 12, right-sided approach 6, and last 4 have been subsequent. And this is all credit to Dr. Rajan Prasad and Dr. Arvind Kumar that we at Jodhpur in our unit are doing the thoracic work. And last year almost 110 cases in the whole year. And we do all the thoracic work of the institute. Weights and empymas and the infective disease are the main bulk of our caseload. We rarely see operable lung cancers, sometimes metastectomies, but most of the times these are the benign diseases, these hydatid, thoracic duct ligation, and everything. Segmentectomy, I was not the operating surgeon. Dr. Manju was the operating surgeon in this surgery. Rest of the surgery have been conducted by our team. So myasthenia needs a good preoperative thorough workup by the neurologist colleagues. You should have a stable patient so that the patient don't end up in crisis post-operatively. Minimally invasive weights, both weights and rates are good, but I find when we work in the neck part, I feel confident with the robot if you have availability of the robot. Thank you.
So, nice talk, Dr. Amkar. Now there are any questions, pressing questions from the house? Yes.
Thank you so very much. It was very nice. The only one thing is for we all people and the learners and the young people behind, you didn't demonstrate the both phrenic nerves in it. I got lost. I didn't find out any. And I don't know how did you safeguard all the, though I'm supposed to safeguard them. Phrenic nerves on both sides, right or left, because nothing was demonstrated to we people. You must have been sure. So we didn't know. It should have been demonstrated to the students.
So, sir, when we do this subsequent, you will be will be able to have a very good look. When you are doing the right-sided or left-sided approach, you will have obviously on the excellent side, but you kind of will need to push the heart down and pull this kind of tissues, and then you will have a look. But sometimes you need to put in another scope and have a good look, because in myasthenia it's very paramount that you preserve the phrenic nerves. So sometimes you need to kind of have a bilateral approach. Putting in a 5mm port and the scope will not jeopardize your surgery, but you cannot take things for granted and presume the phrenic to be there. It's better to have a direct view at the phrenic.
Any other question? Thank you very much. We're going to have the second speaker now in today's session. This is the recent advances in thoracic surgery and lung transplant, being presented by Dr. Harshvardhan.
Good morning, everyone. Greetings from Medanta, and thanks for AIMS faculty for inviting me here for this insightful lecture. Thanks to the chair, Dr. Rajinder is here. He is a teacher to me also. So thanks, everyone. So we'll start. I'll be concentrating mostly on the lung transplantation aspect. So this is the Institute of Chest Surgery, it's the largest department of thoracic surgery in the country, led by Professor Arvind Kumar. So in 2022, we started our journey of lung transplantation. I'll be taking you through it in the next 10 minutes. So what is the process of lung transplant? From 1963 to 84, there were 44 unsuccessful attempts at doing lung transplant around the world. In 83, John Cooper et al. Did the first single lung transplant. In 86, he did the bilateral sequential. Dr. Venugopal did the first heart transplant in 94 in AIMS. Dr. Jignesh Thakkar did it in 2011 for first lung transplant in India, and we did it in North India in 2023. This is a small slide showing the number of transplants till 2017 around the world. So there are around 5,000 transplants which are being done in the world at the moment. But it's a very unfortunate slide. You can see there is not a single dot of Asia in this slide. So our prediction or our request to everyone here is, let's try and put a small dot of Asia or India in this slide in the next 5 to 10 years. So bilateral sequential is the call of the hour. Most of the lung transplant are done bilateral sequential. Most common question asked is, what is the average year a patient is going to survive after a transplant? It's 7.2 now. So most common indication worldwide is COPD. Most common indication in India is ILD. Most of the COPD patients are managed by rehabilitation and drug management. So they are not transplanted, and because in India it's a private affair, private paid affair. So most of the patients are ILD patients. Who to transplant? $1 million question. So there was a consensus statement 2014 and 2024, which says if your patient is going to die because of the respiratory disease in the next 2 years, and there is good likelihood of this patient surviving after doing the transplant, then only you should transplant. So it's simple dictum. If your patient is around 65, he's on oxygen, his oxygen requirement is increasing day by day, he's all other organs are behaving normally, the patient is motivated, social structure is good, so you can transplant this patient very well. Contraindication, recent history of malignancy, MI, tuberculosis, uncorrectable bleeding diastasis, medical non-adherence, and a lack of social support, which commonly there is not in India. Relative contraindications, age above 65, but the Toronto is doing it up to 80 now, where we have learned it. Mechanical ventilation was a relative contraindication first. Now we are doing most of the transplants on ECMO patients. So this is a team which went to the Toronto General Hospital to learn the art of transplant. We were doing around 100 thoracic surgeries in 2022 per month. So what we thought next, what should be done? So the highest element of thoracic surgery, as everybody here would appreciate, is transplant. So we went there, learned it for 3 months, stayed there like residents, and came back and did the first transplant after 1 month of our coming back. So the process is divided between referral, evaluation, listing, recipient management, donor call, donor management, explantation, implantation, and post-operative care and follow-up. So whenever a pulmonologist refers a patient to us who has the specific criteria I already have told, we do a OPD consult, an online evaluation of that patient, and we divide the patient into 3 parts: 2 sick to undergo the transplants, merits evaluation, and 2 good for the transplant, that the patient can be managed by the rehabilitation and the drug therapy. If the patient merits evaluation, then the patient is brought to Medanta Hospital. He is admitted in our hospital for 5 to 7 days. A battery of 50 to 55 tests are done, in which right heart catheterization and PET scan, etc. is done. After all these tests are done, the patient is discharged. A presentation, a multidisciplinary board is done, in which the decision is made what kind of transplant we want to do in this patient, whether it is a single lung, bilateral sequential, heart lung. So the decision is made and the decision is conveyed to the patient. Now, if the patient agrees, everything is told, the consent is taken. Now the patient is listed on the website of Noto, and the waiting for the matching lung starts. In the duration we are waiting for this matching lung, the recipient has to be optimized. These patients are in a very bad shape. So an online daily physiotherapy and on-site weekly or bi-weekly physiotherapy has to be done. Medical management is done by a pulmonologist, nutritional support by a dietitian, emotional support by a psychiatrist, and the patient is advised to stay 100 kilometers within the hospital. So this is our first transplant patient who is doing the on-site physiotherapy on at least 10 liters of oxygen. So one fine day when we get a donor call, these donors are brain dead, heart alive donors. So we've matched the total lung capacity, the volumetric CT scanning, blood group, recipient present condition, and willingness to undergo the transplant is seen. Now starts the race against time. The team is divided between 2 parts, the donor team and the recipient team. You must be aware of this famous photograph. So the donor team, what it does, it calls up the hospital where the donor is. It optimizes the hemodynamics because remember, this is a heart live patient. Even distribution of vasopressors, fluid management, antibiotics, optimal ventilation. Then the easiest and the fastest way of going to this donor hospital is chosen. Sometimes we chose the commercial flight, sometimes private jets, whatever is available to us. At the donor hospital, one coordinator, one lung transplant surgeon, one pulmonologist is there. So we do an on-site bronchoscopy, we collect bowel samples, we collect blood samples, and the process of donation is started. So this is the donor room. It's highly crowded because 8-9 teams are there to take the heart, liver. So the first thing we do is to start a prayer for the noble soul, because this man or woman who's dying in the next 30-40 minutes is giving life to 8-9 patients. The process of explantation is started. It's done by a sternotomy, dissection of the heart first, assessment of the lungs, pulmoplasia, explantation of the heart, explantation of the lungs, packing the lungs in the fluid which is for it, and transport the lung in this specialized fridge which keeps the lungs at 10 degrees so that we can preserve the lung for the next 10 to 15 hours. So green corridor, you must be very much aware of. We get this support from the state ministries and all the stakeholders so that we can reach the Medanta hospital as soon as possible. The team at Medanta, what it is doing, it's preparing the recipient for the ultimate surgery. A clamshell thoracotomy is done, bilateral dissection and preparation of for pneumonectomy, the initiation of ECMO, VA ECMO before starting the pneumonectomy. And when we start the pneumonectomy, it's a time that the donor organ is inside the theater. So a back table is done in which we divide the both lungs into two parts. Implantation is done in bronchus, PA and LA cuff, reduction of the flow of the ECMO to half, implantation of the other side, taking the patient off ECMO, closure and shifting to the ICU. After this, 4 or 5 days after the shifting him to ICU, the patient is extubated, and then a rehabilitation phase is started. This is the picture of a clamshell thoracotomy through which we do this. Patient is put on a ECMO full support and half support after one implantation, bronchial anastomosis, PA running, and LA cuff running. So degrees of the flow. These are the first specimen of the first transplant we did. It was a bilateral extensive bronchiectasis. This is the patient doing physiotherapy in our ward. So they have to be told how to breathe. They almost have forgotten how to breathe. So this is the same patient you saw that was doing physiotherapy on 10-liter oxygen. Now he is in Kapurthala doing it and without oxygen, leading his life. Now he's settled in Australia. So these are the results which make us do these kind of surgeries. A small video at the end which will show you how this process is done. So donor lung retrieval. Packing in Perfodex Plus. India is a very emotional organ. When we come out of these donor hospitals, the recipient family, they sometimes shower flowers on us because one of the organs of their dear one is there in the dead box. So green corridor. Reaching back Vedanta. This is a 1 minute. This is the most satisfying moment in this surgery when the patient is extubated after transplant. Post-operative mobilization, physiotherapy, sending the patient back home, and these patients coming back in our OPDs in a healthy state.
Thank you, Dr. Harshit, for such a wonderful presentation. And I must congratulate and compliment you for such a team efforts and coordination between the different teams. Any question from the audience?
So, congratulations. I guess the audience is not very much exposed to this.
So if audience has any query, Dr. Makhdoumi, sir, please. Okay. Right.
I remember only two episodes.
Okay.
I remember only two episodes. Is that once in Texas Heart Institute, I met a surgeon who was doing a cardiac transplant, and he told me after introduction that he is working in Danta.
Okay.
His name is Evan Levis. The only one thing is that I was excited and I saw and I enlisted as a student of surgery, old surgeon. I was very happy and I extend my whole greetings from those people who don't do it. That means one precious life has been lost and saved, and one has been lost. Your humbleness because to the donor and your dedication to the recipient, it is all it was very exciting and energizing for anybody in the, and I wish inshallah out of the young people, some of people will become your students and they will start this. The only one thing is I was talking to Dr. Abroy, this is a very good procedure, but it's too costly for majority Indian population. They want to live, but they are made to die because they don't have this much money and this much sophistication and energy and transportation and logistics. They lack in it. And I don't think I will live that I'll see that every Indian gets this much special treatment as we gave to this man. And God bless you all.
Thank you so much, sir. Thank you, Dr. Harshit.
So we are trying to establish this network of state governments.
Oh, that's an excellent idea.
Haryana has come forward to do it in CGHS rate, which is 25 lakhs, and Vedanta is committed to do that. And two things I wanted to tell that Dr. Arvind is also a product of AIMS. He has spent 35 years of his life in AIMS, and I am the son of the soil. I have done everything, whatever I've done till now, because I belong to Jammu, is from Mata Ki Meher hai.
Oh, that's a great, that's issue. So,
very good afternoon. Now I call upon the next speaker, Dr. Abdul, to come from the stage and present his topic.
I think Dr. Abdul Samoon is not available because of his personal reasons. Dr. Harvinder Singh Bali, who is a consultant in ESCOMS and our General Secretary of Jakasicon team and a very energetic man, he will be presenting this topic.
Dr. Abdul Samoon is a dear friend, but he was not able to come because of some weather conditions. So he just requested me to present this. Let me do it. As a secretary also, it's my job to fill the gaps. So, but they have done that GMC Srinagar combined laparoscopic thoracoscopic approach for idiopathic incarcerated diaphragmatic hernia. A 27-year-old female came to OPD with complaints of upper abdominal pain associated with nausea, shortness of breath. There were no underlying comorbidities and there was no history of any trauma. So trauma was excluded. You are seeing in the X-rays, X-rays showing a haze and air is separated from the lung shadow in the left upper area of the left lung. Next. The CT abdomen was, and it clearly showed the presence of the gas, the fertile gas in the left lower chest, and also the presence of lot of fluid, the fluid in the left pleural cavity. So this was a port placement. 4 ports were placed in the abdominal and 3 in the thoracic region. So this was a combined port. 1 11 mm supraumbilical port, 1 12 mm, and 2 5 mm port in the abdomen, and then there were 2 5 mm and one camera port in the thorax. So this is the abdominal part. So we started, and after just retracting the liver, this is the part of the fundus which has gone inside the thorax, along where there are a lot of adhesions. A sternotomy was performed, which was already the gap was enlarged with the monopolar cautery, and adhenolysis was done. So get this content, and this is the dirty fluid coming out of the thoracic cavity, which you have just seen. It was sucked out, and we were trying to reduce the contents. And this is because the patient was put on single lung ventilation. That's why you are not showing any lung movements there. So this is the stomach part is being taken care of, and then this is the stomach is reduced into the abdomen. This is the thoracic part. The thoracic ports are put in 2-5 mm and one camera group, and this is, you can see the condition of the lungs, the material over this lower part of the lung. So this is, we are still, they're trying to reduce this stomach back, and then there was a big perforation in the frontal part of the stomach, which was taken care by, we just stapled this part, we excised this part. So this is the nasogastric tube was put in by the anesthetist. It was negotiated beyond the perforation. Adenolysis is done further, and you will see this is the perforated part of the stomach, the further stomach is being taken care of by staples. That is being removed. This is the final shot, and this the perforated part will be taken. This is thoracic view. You are getting this fluid is sucked out, and saline washes are done to get rid of all the dirty material from the thorax, and the defect is sutured with the polyleptin suture. Thorax, if you are doing it through the thorax easier because you are just looking at it, rather than from the abdominal part, that way you are resettled. This is intracorporeal suturing done. We are just going to finish this. So this is dry mopping is being done. And these are lungs are inflated. The second this left side lung is being inflated by the anesthetist. And we are seeing this properly inflated. And chest tube one, there's a chest tube in the chest, and then the second drain is put in the abdomen. Once again, saline washes are being done. This is the post-operative resection and the day of the discharge X-ray. You can visually see the expanded lung with tubes in place in the post-operative film. So, RASP was removed on POD3 and ICD on POD5. Drain was removed, abdominal drain on POD7, and patient was discharged on D7, tolerating orals and weight temperature. And he is in regular follow-up of the obsession. Thank you.
Thank you. Such cases come in emergency and usually pose a problem for most of the people. To diagnose them nicely and then to manage them nicely is really good. The way you have managed this patient. I mean the people, Dr. Samu.
GMC people.
Any question or any interaction any person wants to have? Yes, Professor Jackson.
It has been a very good job and commendable job, in fact, dealing with such cases, and especially when you have all the infected material in the thoracic cavity, it increases the morbidity and mortality. Because once you have ingest all the infected and perforated stomach, I have had an experience of dealing with 8 cases laparoscopically. The first one I did was a huge spleen along with the stomach, which was in the chest. Since it was my first case, I did not know how to get the spleen down because negative pressure in the chest, positive pressure in the abdomen, it has a lot of difficulty and you can't pull the spleen to get avulsion. So what I did in that case, I increased the rent, made the rent more bigger diaphragm and then suture it. That suture needs definitely here, you need a lot of expertise in suturing because it's on the top and diaphragm is very difficult to. So any expert you had in suturing.
That's why thoracic approach is better for suturing.
But as general surgeons, we don't have that.
See, one thing what I have found is that he has used stapler for a perforated stomach that has remained inside chest for a considerable period of time. I would not suggest using a stapler under such circumstances. It would have been better to use a suture. This is just a comment.
With the permission of the chair, basically once the patient came, patient had saturation of 68. For 2 days, the anesthesia people were not ready to take her up. So using some persuasion, which can be done if you are having nice face and maybe some dimples. So I was finally able to convince them, please take this patient up. And Dr. Fazal is here, he always has a look at those. So what happened? Why did we use stapler? As you can see where the perforation is, we have gone around 2 centimeters away from that. We have gone to an area which was not inflamed, number 1. Number 2, the Ryle's tube. I made sure that we don't go near the gastroesophageal junction. That was my second concern. The other concern was how we were not able to pull the stomach down. Like Dr. Ija, Professor Ija has said, we were not able to pull it down. So it was a forced thoracoscopy. But overall for the patient, it benefited. Definitely suturing the diaphragm from above was a lot easier and it helped. Thank you.
Yes. In this case, the chairman should speak from your end. It's such a nice case, you have to talk. Please, your comments.
So we have been using this hybrid approach, thoraco-laparoscopic approach, and we have published it also. It's a very good approach. I don't know how you position the patient. We position the patient semilateral and then go into the abdomen. If you put the patient supine, then you're going to be in a little bit of a trouble. So you put the patient in semilateral, go into the abdomen first, and you can reduce the contents from there. Even spleen can come out many times. Sometimes it may not. Your case was definitely unique in the sense that it was post-perforation and therefore everything was stuck up. But once you got the contents down, you go into the chest, you see the defect so nice and easy. And the suturing can be done from the top. And you can, now with the availability of robot, we have also started docking the robot and doing that. But thoraco-laparoscopy is definitely very useful for complex diaphragmatic hernia. Yours was the emergency setting, but in even elective patients, we prefer to use this approach. Thoraco-laparoscopic. For bogdalic hernias, it has to be semilateral. For Morgagni hernias, you can do it supine.
Thank you, Dr.
Are usually central. Traumatic hernias are usually central, so you can approach them from abdomen.
Okay, thank you very much. Thanks a lot.
Our next speaker is Dr. Yasir Afaq MLB. He will be talking on thoracic trauma presenting in a tertiary care center of Northern India over 1 year, experience of over 1 year. a retrospective observational study. Dr. Yasser, please talk.
Esteemed chairpersons, respected faculty members, colleagues, and dear residents. A very good morning to all of you. I am Dr. Yasir Afaq from the Department of General Surgery, GMC Jammu, and I will be presenting a retrospective observation study of thoracic trauma presenting in our center over 1 year. According to Van der Kolk, trauma occurs when both internal and external resources are inadequate to cope with external threat. We start with the statistics. Traumas are the leading cause of death in the first 4 decades of life and are mostly caused by road traffic accidents. According to WHO and CDC, more than 9 people die every minute from injuries or violence, and 5.8 million people of all ages and economic groups die every year from unintentional injuries and violence. Road traffic crashes result in deaths of approximately 1.19 million people around the world and leave between 20 to 50 million people with non-fatal injuries. The Indian scenario is no different. A trauma-related death is reported every 1.9 minutes in India. India ranks first in the number of road accident deaths across 199 countries, reported in World Road Statistics 2018, followed by China and US. As per the WHO Global Reports on Road Safety 2018, India accounts for almost 11% accident-related deaths in the world. According to the official statistics published by the Ministry of Road Transport and Highways, 153,972 persons were killed in road crashes in the year 2021. This corresponds to 11.3 deaths per 1 lakh population. Now, thoracic trauma accounts for about 10% of all trauma admissions, 25% of all severe injuries, and 25% contribute to subsequent deaths. Thoracic traumas might lead to severe consequences, even though less than 50% of them require surgical revision. 80% of the cases can be managed by simple intercostal chest tube drainage, appropriate analgesia, and respiratory support. Broadly, thoracic trauma can be classified as blunt and penetrating. Blunt trauma thorax is seen in road traffic accidents, fall from height. They are the most frequent type of trauma in Europe, USA, and even in our own country, responsible for more than 150,000 deaths in Europe every year. Acceleration, deceleration injuries can be fatal. Penetrating trauma is usually caused by gunshot wounds, stab wounds, and impalement. Mortality is significantly higher than blunt traumas. More than 90% patients are not able to reach the hospital alive, and mortality for patients with no cardiac involvement is less than 1%. We all know the life-threatening conditions associated with thoracic trauma. They are the lethal 6, which require evaluation and emergency prioritization for treatment during primary survey. These include tension pneumothorax, airway obstruction, cardiac tamponade, open pneumothorax, massive pneumothorax and flare chest, and the hidden 6, the potentially life-threatening injuries that should be detected during secondary survey. These include thoracic aortic disruption, tracheobronchial disruption, myocardial contusion, traumatic diaphragmatic tear, esophageal disruption, and pulmonary contusion. Now, ICCT drainage is the lifeline of patient as well as the surgeon. 80% of thoracic trauma patients can be managed by simple chest tube placement. Also, in cases of penetrating chest trauma, intercostal chest tube draining can be adequate in up to 95% of cases without requiring any further surgical exploration. Complications of chest tube drainage rate may vary from 6 to 37%, depending on the settings, the expertise of the resident who is attending the emergency, and that reflects the high variability of emergency setting and in no standardized definition of complication. Surgical exploration is very rare, accounting for less than 3% of trauma cases. We have the open thoracotomy approach. Usually, anterolateral thoracotomy at 4 to 6 intercostal space is performed. This approach usually guarantees a safe and large enough access for all emergent procedures, even great vessel clamping, which might allow to save time to reach the operating theatre when the emergency thoracotomy is performed in the emergency room. We have the minimally invasive VATS approach, proposed to be used in selected patients with stable hemodynamic conditions for persistent non-massive pneumothorax, persistent ALD, diaphragmatic rupture, Moreover, also trauma sequelae such as empyema can be treated with minimally invasive techniques. Now coming on to our study, the aim was to determine demographic profile, mode of injury, management and outcome of chest trauma in a tertiary care center of northern India. It is a retrospective study of cases of trauma patients with thoracic trauma admitted in the Department of General Surgery GMC Jammu over a period of 1 year from 1st April 2024 to 31st of March 2025, highlighting the demography, etiology, types, presentation, management, and clinical outcome. A total of 1,287 patients presenting with alleged history of trauma with thoracic trauma were admitted over the study period. The data was collected retrospectively from the admission register of all the surgery units and audit reports of the given period. We start with the age group. Most of the patients were in the third, fourth, and fifth decade of life, with the majority of them in 41 to 50 years of age group. We had a smaller fraction of patients in the extremes of age, with 2.3% in the first 2 decades of life, and as almost similar figure more than 80 years of age. 82.52% of our patients were males, and 17.48% of them were females. The mode of trauma was RTA in majority of patients, 57.73%. This was followed by fall from height in 37.61% of the patients. We had 4.27% patients with assault and 5 patients, only 5 patients, that is 0.39% with other modes of trauma like fall of heavy object on the chest or hit by a cricket ball. Now, depending on the type of injury, 92.15% of the patients had blunt trauma chest and 7.69% of the patients had penetrating trauma. We had only 2 cases of gunshot wounds over the study period. The clinical presentation, the most common clinical presentation was chest pain in 71.202% of the patients. This was followed by 30.92% patients having difficulty in breathing, and then 23% having abrasions over the chest wall, and then 13.99% of the patients having capitis. In almost 25% of the patients, they presented to the emergency with polytrauma, and this thoracic trauma was detected on further investigations and evaluation. As a part of polytrauma, 82.21% of the patients were admitted, and only 17.79% of the patients presented with isolated thoracic trauma. On the basis of numbers of ribs fractured on imaging, we had most of the patients admitted with more than 3 ribs fracture, that is 39.16%, followed by 3 ribs in 25.56%, 2 ribs in 18.18%, and 1 rib in 15.31%. The relatively lesser percentage of patients with 1 and 2 rib fracture is due to the fact that most of these patients were managed on OPD basis. We had almost 23 cases of Lyle chest. On the basis of imaging findings, we had pneumothorax in 25.49% of the patients, hemothorax in 8.94%, hemopneumothorax in 23% of the patients, pulmonary contusion in 2%, and then only a small fraction, that is 13 patients with lung laceration and 3 patients with pneumomediastinum. Most of the patients were given primary first aid and management in the emergency setting. So we put in the chest tube in 57.73% of the patients, because in the emergency setting, whenever we are suspecting thoracic trauma, we'll go with the dictum of putting in the tube. We managed 42.04% of the patients conservatively, and 3 patients had to undergo thoracotomy. Overall, 13 patients were lost and could not be salvaged. That is 1.01% of mortality in our study. Now concluding, thoracic trauma is a significant cause of morbidity and mortality, especially in patients with polytrauma. Mode of injury differs according to environment, geographical location, season, and age group. Presentations may vary from incidental findings in chest X-ray to open wounds in the chest. Most of the times, X-ray is the only investigation needed in addition to EFAST. However, in doubtful cases, CT scan is helpful. Thoracotomy is recommended for hemodynamically unstable patients and VATS for hemodynamically stable patients, as well as for long-term sequelae. With prompt action, patients with thoracic trauma who reach the hospital can be saved. Thank you.
Thank you, Dr. Yasser, for such a nice study which has been conducted in GMC Jammu. And I remember those days. You see, RTA is very common in GMC Jammu side.
Yes, sir.
And so far as Srinagar is concerned, we see trauma more because of falls Now the RT is picking up in Valley also because of, I think, better roads. Better roads, more accidents. This is very with pros and cons. And the GMC Jammu is almost 30-40% of admissions in casualties because of trauma. And such a nice study. I must congratulate you. Any questions, please? Any questions from the audience?
Once there is thoracic trauma, majority of patients are being managed conservatively. It's not only here, but everywhere. But if you have a chest injury, which is not manageable, these people usually die because they have a vascular catastrophe, the doctors say, associated with trauma. They hardly reach hospitals. That's why you have mobile units and other helicopters, especially on highways where you have multi-trauma accidents. And that helps to resuscitate them in proper ambulances and who are being shifted to the nearest centers of excellence where they are being managed. Thank you very much, Dr. Sam. I think with this, we close this session. Thank you very much. Thank you, sir.
I now request our respected chairperson, Professor Dr. Rajinder Prasad sir, to kindly felicitate Professor Dr. Ramkaran Chaudhary sir. I request Professor Dr. Ijaz Ahmed Malik sir to kindly felicitate Dr. Harshvardhan sir. I request Professor Dr. M.R. Atri sir to kindly felicitate Dr. Harvinder Singh Bali sir. I request Professor Dr. Pranav Sharma sir to kindly felicitate Dr. Yasir Afaq Meet sir.
I now request Dr. D.P. Singh sir to felicitate our chairpersons for the session. I would request Dr. Lilesh Kaman sir to kindly come on the stage and felicitate us chairpersons for the session. Professor Dr. Rajendra Prasad sir. Professor Dr. Ijaz Ahmed Malik sir. Professor Dr. M.R. Atri sir. Professor Dr. Pranav Sharma sir. Thank you everyone. I would now request Dr. Varun Nugla sir, Assistant Professor, Department of General Surgery, to carry the proceedings of the next session.
Good afternoon to all of you. It gives me immense pleasure to start the proceedings of this prestigious oration in Jakasicon 2026, 12th Annual Conference of Jammu and Kashmir chapter of ASI. The first oration is Chairman Jakasi oration. May I have the pleasure to call upon the chairpersons for this oration. Professor Dr. Iqbal Salim Mir, Professor Dr. Ejaz Ahmed Malik, Professor Nazir Ahmed Wani. May I now invite upon dais Professor Dr. Iqbal Salim Mir to carry the proceedings.
Good afternoon. Wonderful to see so many people inside the hall, even though we would love to have more. So we are starting the first oration, that is the chairman's oration, and it's going to be given by my dear friend, my colleague, my classmate, Professor Ejaz Rathar, who heads the Department of Minimal Access and General Surgery at SKIMS Medical College, that is associated with the SKIMS Institute. Besides that, he is also the associate dean, he is into administration also. And he's also the registrar, academic registrar. And I don't know what else. He's also the chairman of sports. And he's also chairman of that grievance committee. And, of course, I said that first. Okay. So did I miss anything, sir? Okay. Wonderful human being, a very good teacher. And I hope he'll make us wise by his words. Please welcome the chairman Jakasi for his oration.
Thank you, Professor Iqbal, for your kind words. Assalamu alaikum and a very good morning to all of you. A lot of academics has been discussed since morning, and I want to take surgeons away from the scalpel for a short moment and talk about the topic which is of great relevance at present times because of a lot of litigations and patient attendant conflicts, doctor attendant conflicts.
We are not able to hear you.
Oh, sorry. So, is okay now? I have chosen the topic which is of great relevance at present because of patient conflicts, doctor-patient conflicts, and lot of litigations which are occurring at present. So, when we were students 2 or 3 decades back, we never used to talk about professionalism and ethics. And what made the National Medical Council in 2019 to come up with the ETICOM model, that is attitude, communication, and ethics, to be taught in all the 3 professional levels, 3 phases, with marks ranging from 5 to 15 in each phase. So there have been many reasons, as I said, about the education. But first thing is, why we were not taught this professionalism? Because it was believed that that professionalism and ethics is taught and not taught. What does that mean? We would follow our seniors, our professors, our gurus, and see what good they do, and then we would do the same. Let me give you a short example that are personal examples in my life. When I was a final year student in 1988, we had a surgery class with professor. May God bless his soul, he's no more with us. Now, when I went to remind him, sir, your class is with us from 2 to 4, he said, yes, I know it. But I was amazed to see him reading a book, Belly and Law, and I see the chapter also, Gall's stone etiopathogenesis. He told me, go, I will come in 10 minutes. I was puzzled to see a professor of surgery still reading when he has a class. How many of us do it? If we introspect, I have a theory class, I tell my SR, please download this, Google it, and then he will give me a pen drive, and tomorrow I will present it to my students. Second example, which I have personally seen, I was walking with the professor in the corridor. One of the patients came to him, "Sir, I want my gallbladder to be removed in private." The professor told him, "See, in hospital, if you have any problem, talk about the hospital problem. Private things are to be discussed in private. If I am at that place, what would I do? I would give him my phone number. Okay, you go to the nursing home. I will come in the evening and I will operate you." So this is what was the hidden curriculum the students learned by watching their teachers. Next is trust deficit. There are many reasons for this trust deficit. Number one is that because our communication problem, we don't properly communicate with the patients. And then medical legal, there are many more problems of trust that we will discuss in the future slides. In medical litigations, there are so many going on because of the Consumers Protection Act, patients' rights, and they keep it on. So to conclude about this slide, so it was presumed that it's a part of character. Professionalism, and it's a part of character. But now it is recognized as a competency which has to be taught to the medical students. Now, ethics is defined as a system of moral principles that govern the conduct of an individual or a group of individuals, and according to which human actions are judged as right or wrong, good or bad, just or unjust. Let me give a few examples in general. If we are walking on the roadside and we find a wallet full of money, and if we hand it over to the person who has lost it, that means we have acted ethically, because justice and morality, they're the part of ethics. Now, going to our home, if we help these children and family in household chores and also talk to them politely, that means we have acted ethically. Now, if we are on the roadside, we find we are waiting for a bus, 10 people are there. If we don't jump and push the others and go into the bus, that means again we have acted in an ethical way. In the professional, the example is, we must be knowing, the seniors must be knowing, in most of the institutions, post-graduation was given on the basis of work and conduct. Then what happened if a Dr. A is on duty, the head of the department will tell him, go and do a T-tube cholangiogram to this patient. And he has sweated during the night, worked all throughout the night. In the mornings, Dr. B would take the cholangiogram to the head of the department. "Sir, I have done the T-tube cholangiogram." Then he would get pleased. "Oh, this boy is very good." So he has taken the right of that A who deserved this. But because of his innocence or ignorance, whatever you made, that this boy B has acted in an unethical way. So what we are going to talk about bioethics, there are many forms of ethics, and in that we'll be discussing about clinical ethics. Bioethics is the division of applied ethics that help us in defining, analyzing, and resolving ethical issues that arise from the provision of healthcare and conduct of health-related researches. Now what happens, different people have different reasons to justify it. If you tell a student, "Why don't you cheat? Why are you cheating?" He will say, "I don't cheat because against my religion." It will be answered from one student. Second student will say, "Sir, I don't cheat because it is against the ethical principles of justice." Another will say that it's against the university's policies. So there are four basic principles of medical ethics. That is beneficence, non-maleficence, autonomy, and justice, which we all are supposed to follow and must follow. What is beneficence? Is the duty of a healthcare professional to work in the best interest of the patient and promote their well-being, relieving suffering, prevent harm, and provide benefits to the patient if it involves extra effort. If a patient is suffering with severe pain, and if we don't give him proper analgesic, if we don't treat him pain, that means we have acted unethically. Now, as surgeons, we know a patient of obstruction, he needs surgery immediately. If we delay, it increases the mortality and morbidity. And if we don't operate this patient in time, that means we have acted unethically. Then also, sometimes what happens that it is 5 o'clock, a patient comes to you with shock and we treat him. Now it is 5 o'clock, I'm supposed to leave the hospital. But if you give an extra hour to treat this patient, and then this is all the beneficence you have shown to this patient. What is non-beneficence? The healthcare worker should not cause any harm to the patient, avoid unnecessary surgery or harmful investigations. Benefit risk ratio has to be seen, and also choose the intervention with minimum harm. Now, as surgeons, we know that a patient with polyp in the gallbladder 2 mm does not need any surgery. But for the sake of doing it, if you want to do it, and subject the patient to risk of complication of cholecystectomy, surgical complications, and complications of anesthesia, that means you have done a non-beneficence. And you have done a beneficence. Now, benefit risk of the drugs have also to be seen. You have to give drugs, you have to weigh which is more. Side effects are more or the benefits are more. And similarly, very important is proper training. If I have not seen any Whipples being done, if I do know how to do a Whipples and I take a patient to my theater and try to do a Whipple and will tell my colleague, oh, this patient has carcinoma, he can die tomorrow also, today also, and let me see and try. Unless you go to the wet labs, unless you get properly trained, please don't do. Autonomy. Recognize the patient's right to make decision about their own health care without any external pressure, even if it does not in the best interest of the patient. Suppose the patient has a renal failure, he needs dialysis, and patient knows that if I don't get dialysis done, I will die. But if he's not giving you the consent, it is none of my duty to force my decision on him. And we have to take the consent. And second thing, you have to discuss the different modalities of treatment. Suppose the patient has a carcinoma lower esophagus, we know it's a squamous cell carcinoma, equally sensitive to radiotherapy also. So if a patient is 80-year-old male with all the comorbid diseases, you discuss, tell him it is equally efficient. It's an alternative treatment for the carcinoma esophagus because he saved of the complications at this stage of the radical procedure. Justice, fairness in the medical care, ensuring equitable distribution of resources. This problem arose during COVID period when we were short of ventilators, we were short of ICU beds, and the patient with SPARS would come first and other poor patients would be kept aside. So as surgeons, we have to see whenever we need to have an ICU patient, just please do as per the severity of the problem. Allocate the beds. It's a problem in all the hospitals. We are having shortage of ICU beds. Similarly, ventilators. So we have to see which patient deserves more and distribute the resources. As surgeons in general surgery, we know the list of goes in government hospital for 2 years, 1.5 years. And sometimes VIPs come, infectious people come and we get out of date. And this is all injustice we do it to the other patients. And similarly, we have to treat with all patients equally, for which we have taken the Hippocratic oath also, that whether he is a poor or he is a rich person or he is a resourceful person, so we have to treat them all in the same way. Now, regarding research ethics, it means that when research is conducted with or about the people. Now, what happens, sometimes there are some unintentional errors which can occur, but in the history, there have been some deliberate and appalling violation of human beings, and because there were no institutional review boards. To give a few examples of this is the Nazis' medical crime and syphilis city in Tuskegee. Now, what was Nazis' medical crime? They exploited the German soldiers. They were subjected to hypothermia, put in the cold chambers to see the efficacy of cold in these patients, and most of them died. Then sterilization, forced sterilization was done because of racial inferiority, and they were subject to crude methods by injecting chemicals into the genitals, or by radiotherapy, or doing vasectomy without any anesthesia. That anesthesia programs were to the mentally ill and disabled people, where they were put in the gas chambers and most of them died. And in T4 program, thousands of German soldiers died because of that exposure to infections and gases. Now, intestinal infections. Again, prisoners were injected with typhus, tuberculosis, and hepatitis virus to see the efficacy of the vaccines. Another black dot in the history of USA is the Tuskegee syphilis study. So what was the study about? 600 people were taken for the CTD they were told that no consent was taken. They were told that we'll give the treatment, free treatment, we'll give also food, and also after death, we'll do all funeral expenses, will bear with this. And when penicillin was available that time, they were not given penicillin. And these patients, most of them died, or they spread this to their syphilis to their family members or their friends, and majority of them died. So then it was finally a journalist, Peter Boxter, in 1972, who exposed this whole, and what was the result? That Nuremberg's code was established, which was done in 1948, which says the voluntary consent of human subject is absolutely essential, making it clear the subject should give consent, and that it benefits of the research must be overweigh the risks. So the outcome of 46 war crimes was that at the tribunal at Nuremberg indicted 20 physicians and 3 administrators, and 16 out of 23 physicians were found guilty and imprisoned, and 7 were sentenced to death. I will not go through the numbers. No, other bioethical violations were that in 1963, Brooklyn Jewish Chronic Disease Hospital, live cancer cells were injected into chronically ill and debilitated patients who were told that they were receiving skin tests. The investigation were eventually prosecuted and found guilty of fraud, deceit, and unprofessional conduct. In another case, 1972, Willowbrook State Hospital in New York, retarded children, mentally retarded children were deliberately infected with viral hepatitis to see the natural effect of the disease. Now, what is the situation in India? We did not have any ethical codes before 1980 when first ethical guidelines came, and after that they were revised in 2000 and ethical review boards were established. The latest we have 2006, which clearly says that document stress that only such research should be undertaken whose purpose should be to advance the betterment of all. The manner in which the research is conducted should not compromise the dignity and well-being of the subjects, and it should avoid the pitfalls of unethical research. To ensure sound scientific output, the research must be subjected to a strict regime of evaluation at all the stages of the proposal. All human beings are born free, equal in dignity and rights. It is the duty of each and every man to treat their fellow beings with love and respect. Now, a word about professionalism. Professional means approach and duties of a doctor towards his profession, his patients, his families, attendants, and his own colleagues, and staff and duty towards the community. The word professor has been called professors, which is a Latin word which means to having professional one's woes. Now, what are the prerequisites for a good professional? Absence of self-interest, respect for others, empathy, honesty, accountability, excellence, and commitment to services. Now, what does an unprofessional person say? Everybody does it, so I also do it. There's no problem. This is not part of my job description, or nobody will notice, or I don't get paid enough, which is the common excuse to do that. Now, you are here for a purpose. You see the different my friend Dr. Basin has already discussed it. There are some papers which are in favor of doctors, some are against the doctors. Why doctors in India get burned out? The salary is one of the issues they say discuss. On the other side, they say helpless patients and angry doctors. So, but let us ponder for a while. Where have those days gone when the doctor would ask the history, what is troubling you? He would listen to the patient and often pause for ask more questions. Then he would put hand on the abdomen and take them where his words left and look for the pulse and look for the eyes. Then he would gently place his tattoo on the chest of the patient and hands on the abdomen. So there was a connect and there was a trust. Now what is happening today? We are on the computer, the patient comes, and just as soon as the patient comes, we start writing the history. Yes, we look at the computer and talk to the patient, what are the problems, and go on noting. Then you send the investigation on the computer to the lab, tell the patient go there, collect it, then the investigators come back on the same computer, you write the treatment and tell him go to the pharmacy and collect the drugs. So in many cases, patients get referred from one center to the other. Let me give an example of a 60-year-old lady. She reports the emergency with pain in the right hypochondrium and breathlessness. The resident in emergency calls the surgeon, and surgeon puts a hand on the lower abdomen on the right side and sees tenderness. He says it's acute cholecystitis. Put him on IV fluids, antibiotics, and analgesics, and advise UAG. The condition deteriorates. Then he calls a physician. Physician comes, he auscultates both the chests and sees cracked, says, oh, it's a case of pneumonia. Put some antibiotics. The condition again deteriorates. Then he calls a senior physician. The senior physician comes, as we had seen our time teachers, they would examine from head to toe. First thing, he had a look on the JVP, which all have missed. There was a raised JVP. He found a tender hepatomegaly. He advised for the echo. There was a right side heart failure with tricuspid regurgitation secondary to the massive embolism, and the patient was shifted to ICU. This is what is happening. There is no connect and there is a little trust. So how we can regain the dwelling trust? Let us reestablish the connect and rebuild the trust now by engaging the patient and the caregivers in their own care. That means you have to encourage the advocacy, implement the shared decision making, involve patients also in their decisions, and establish a feedback mechanism. Now, we have to have a patient-centered communication and education. We have to use plain language that we all know and show the patient. If we have a colostomy patient or ileostomy patient in the ward, give him an example. This is the patient, how he's managing himself, and you have to explain him fully. Then communication, avoid blame and shame. Then advocates patient safety culture, promote openness, and encourage that patient has to be told it is nothing about me, without me. You have to discuss your plan, discuss with him, and avoid unwanted surgeries. Decisions, as has been said, are better than the incisions. As has widely been said, it takes 3 months to learn how to operate, 3 months to know when to do, and 30 years to know when not to do it. So we should know when we have to stop our scalpel. Then we should not assume that the patients and families will not comprehend. We should not presume that they lack knowledge. We should not also have perception that patients' engagement is unlikely to yield any significant benefits and could result in more harm than good, because scientific evidence shows patient engagement reduces medication and administrative errors. Patients and family education result in better medication and administrative accuracy. Patients and family education reduces and prevents readmissions. Now, let us reestablish the connect and rebuild the trust. Remember, the right to health is the fundamental right of every citizen of India. And why do we boast of ourselves? If you go to the WHO facts, you see the harm of passengers traveling by air is 1 in 10 lakh, but in healthcare is 1 in 300. So how high is our incidence? And in US, 1 out of 136 get hospital-acquired infections, which amounts to about 2 million cases and 80,000 deaths. So in developing countries, the problem is much higher. So in 1/10 of the patients receiving health care, they will suffer preventable harm. So patient safety is not about statistics, but also involves damage to lives in their real lives. Then if we see the reused and unused syringe, the other parameters, we are also behind in that. So finally, whom should we blame? Is it the doctor to be blamed? Is it the patient? Or it is the government? It's an open question to the audience to ponder over. So to conclude, professionalism and ethics form the foundation in healthcare. They guide us to act with integrity, accountability, compassion, and even in the challenging situations. Ethical practice ensures patient safety, dignity, and justice. Professionalism is not just seeking knowledge or skill, it is attitude, behavior, and commitment to excellence. Continuous reflections and adherence to ethical principles help us to grow as responsible professionals. Delay in surgery, unwanted or unindicated surgeries are all unprofessional practices. Thank you very much for your kind sharing. Thank you.
I don't think there are words needed to describe this presentation by Professor Kajans. Rather, in a way, he has portrayed everything here. Because ethics is the basis of surgery. I think the first chapter in all the surgical books is associated with surgical ethics. Not only surgical ethics, it's basically medical ethics. Whatever ethical principles we apply to all forms of investigation, treatment, and follow-up of any patient. Since this is an oration lecture, so we need not to have any comments from the audience. You can raise this up.
Thank you, Professor Ajaz. A very nice presentation. Ours is the only profession where we have Hippocratic oath. I don't think any other profession has an oath for this because we are doing with the lives of the people. So this is a message to younger generation that we have to take care of this, which we are a little bit going away from this because of the social disconnect. Because of the things in our time there were people were connected. Now people are not connected. Even parents are not connected with their kids. A lot of difference. So this needs a lot of emphasis that we should give this training. Previously, what you said, caught, not taught, that is not right now, relevant now in these times. I think even they don't catch this, what we are doing. So we have to make them sure that we have to teach them ethics. So very well done. You have done justice with the topic. And very thankful to you for this presentation.
Professor Ajaz, I just want to make one point. Find youngsters, they learn things, they see things, they have got an easy access to information, and they rely less on teachers. But do we really introspect ourselves? Is there something wrong with our approach? We always shift the blame onto these younger surgeons. Somewhere down the line, we also have forgotten how to be good teachers, how to be good mentors. And I think if all of us look inwards, I think there are ways, there are things that we can change in ourselves. And I'm sure the students will come back to the class, they will learn the proper examination methods, they will not rely on the investigations. And you must be knowing now, patient is coming, the first investigation is now being ordered as a CT scan. But where are they only at fault? I think somewhere down the line an introspection is needed. Thank you for raising a big round of applause. Could we have a standing ovation for Dr. Ega? Thank you very much.
Now request the persons for the felicitation of the audience. Thank you so much. I thank all the chairpersons. Now we move to the next highlight of today's oration, Professor Sheetal Singh oration. I take great pride in calling the chairpersons for this oration, Professor Dr. Fazal Pare, Dr. Harbinder Singh Bali, and Dr. Shamsul Bari. May I now invite upon dais Dr. Harbinder Singh Bali to carry the proceedings for this oration.
Good afternoon, everybody. The prestigious professor Jesus oration is to be given by Dr. Bashir Ahmed Maktoumi, our senior surgeon, son of the sir. Please, sir. Dr. Bashir Ahmed Maktoumi was born in Srinagar, Kashmir. He did his MBBS from GMC Srinagar in 1974 and then did his MS in General Surgery from Government Medical College, Jammu, where Dr. Sheetal Singh was in faculty that time. He had a professional experience of serving in J&K Health Services in various capacities. Then he did his senior residency from SKIMS from 1984 to 89. Then he served as consultant. He was consultant in Ministry of Health, Kingdom of Saudi Arabia from 1989 to 2014. And now he is consultant general surgeon in Khyber Super Specialty Hospital, Srinagar from 2016. He's a great surgeon. In addition to that, he's a medical philanthropist. He's got lot. He's doing a lot of social and literary activities, and he's the best part of the program. You will always see him smiling and then asking very relevant questions to each and every speaker. He's a gentleman par excellence. Thank you, sir. You please.
Good afternoon, everybody. Good afternoon, Dr. Harvinder, for his kind words. Thank you, Dr. Harvinder. And I'm really confused. How can you talk in the presence of such luminaries who are definitely junior to me, but they are senior in experience, in the professional experience, that they are much ahead of me. Whatever the circumstances were, they stood at the front and they fought till the last. I ran away from the front in the half of the line. Anyway, the thing is, everybody has talked on this situation, and it wonders me what else I should add. But anyway, you have given me a chance. I have to only remind this younger audience this time that I have seen Professor Sheetal Singh, God bless his soul. I have seen him twice in my lifetime. Once when I was a final year student and we were about to appear in our final examination, he conducted some of a new Sardar Sahab came and conducted, very young, cute, and he came and he took our clinical bedside for some short cases. Only to he was not convinced because that MBBS that time is always a confusing time. You want to use surgery, medicine, gynecology, and other things. You are too junior and too immature. So, but I met him. It was then we passed and we went away somewhere. And next time I met Professor Sheetal Singh, then I had already complete my MS Young Surgeon, and I was a junior registrar in Government Medical College, Jammu, and he came for a short time as in my unit. I went to his unit and I met him. The great man was such a nice and jovial man that nobody could beat this man in English language. He was so proud. He was so nice. He was so elaborate, and we have not seen. And out of all discussions, he used to think about somebody which we not say. He used to say what Atam used to do. We as PGs and senior PGs and passed out students, we said, who is Atam? He was telling about Atam Prakash because he's from AIMS. And definitely he has come to Jammu, and Jammu Medical College we were not at that extent, but what All India Institute was that time. All India Institute that time, getting admission All India Institute that time was, you get a jitter that this man is from All India Institute. I am from Srinagar Medical College, Jammu Medical College. But I brought laurels to Srinagar Medical College in one of the conferences in Punjab and one in the Simla. Once I talked on AV malformations, one Sardarji, he talked me, oh Bundia, tu kithe da? I told him, sir, I am from Srinagar. And you know what he told? He told to his kids and to his big team, he had the biggest team, he told him that it was Balwant Singh Tung. He told him, oh Mundia, Manik Industry, Srinagar is the best center for learning surgery. I was very much uptaken, and I told my kids that I'm from Srinagar, though I was from the faculty. That time I was from the group, but they were talking about my students. Well, that means I have accepted that I have been born out of a very nice home. Definitely in my lifetime of 25 years in the toughest country of the world, that's Saudi Arabia, where I worked tirelessly, where I worked extensively, and I earned King's Medal as a surgeon. It was only because of you gave it to me. You told me how to see. Definitely, Dr. Abron is my friend. Dr. Bashir is my friend. What was most important, I taught everything when I told to resident in CT scan. I told him the patient kept quiet, and I auscultated the chest on both sides. I found chest is absent, so I put 2 chest tubes on both sides in CT, and the patient breathes around. They told me, how did you diagnose? I told there's nothing special, nothing special, and all credit goes to you, my teachers. All credit go you, my teachers. And once a time, one Sudani consultant told me, Dr. Bashir, I have heard a lot about you in Saudi Arabia. Can you see this X-ray? I told, why is the patient? I told that patient is walking. He cannot walk. How? Because there's a total lung collapse on the left side. Get him, give him. And they put the chest tube. And the patient was nice. These are the things which we got from our teachers. Basic education was very nice. I am very thankful to my teachers who taught us how to palpate. My friends, my young colleagues, don't forget, ask the patient 2 questions and don't see. See a pale patient, see a breathless patient, see a patient holding. Don't see a patient only holding the right hypochondrium and right iliac fossa. They will not come like this. Patient will complain many a times. I have been in touch with the CVTS people. I have told them that I feel like this, because there is a pansystolic murmur, and it was usually correct. We should have a complete composite education. We are here to talk about Dr. Sheetal Singh, a great man, a great teacher. And now that, how can I say great when there are other greats? It may come to a discrepancy. Some say it was great, but some say it not great. I will try to stand by my duty, while Professor Sanjay and others have given to me, to make it that he was definitely different from that way. He had been a good student, as the records prove, and he was born in a very decent family of Kashmiri Sardarjis in Kanihama, Baramulla. He did his schooling in Srinagar. I had to look for one of his friends on a very hard telephonic conversation. Look for him. If some senior people are here, that means he was Mr. Bhatt, Durga Bhatt. You must be knowing. Durga Bhatt, senior sounding, from my group. Durga Bhatt was my registrar, and I was his intern, and for some time I worked there with him. So I found him out, and I told him, Durgaji, I have come to tell you about Dr. Sheetal Singh because I am presenting his case. And I had seen him. And his worthy daughter told me, that once he entered Institute of Medical Sciences, State Kashmir Medical Institute, she told me, I don't know how it is correct, that he was chucked out because he was too small for a senior post, small size, young. Anyway, I believe it or not, he did his, Durga Bhatt told me that it was very difficult to enter Calcutta Medical College those days, and he did it, managed it. Then he got his MS in he did his MS in such this place. That means, and he also did he was in services, he was in Government Medical College, Srinagar, till 84. Perhaps he has gone from a lower consultancy to senior consultancy. Definitely, he enjoyed that place very much, except for unseen problems and others getting his more fortune and saving himself and other things. He came to Jammu. But I was actually wondered, did he ask somebody for a transfer? I didn't believe so. But I was wondered once I saw him in the ward. We met him, and definitely he had 2 things. Whatever we did, he used to tell us. Abdul is here. He used to tell us, no, in all in the institute, we do like this. We do like this for everything, but we enjoyed it. Anyway, we were on the receiving side, we were doing like this, but he was a nice man by heart. Then he was in Jammu till 84 onwards, and he head of the surgery department and principal of medical college. And reports write that he was the first man to work with the Dr. T.K. Advadia. I have a chance to meet him in Bombay as an elder statesman of the minimal access surgery. It was really T.K. Advadia, a great saint-like figure, a very tall guy, very handsome old man, and people were very fascinating after seeing him, because the way we look towards these days to Dr. Panlevello, we look in Kerala, but Advadia was the founder who taught Indian doctors that pneumoperitoneum coelom is not that dangerous what you look. And it has changed a lot, and he was one of them. And now his contribution says that he was first surgeon to start lab surgery in Srinagar, which I learned from his family, and a higher number of lab surgeries performed by a surgeon in J&K. Now it will be accepted or disputed, I don't know, because those heroes who are doing very day and night, now one of my shining figure is looking towards me, and I'm looking towards him. But anyway, the documents say like this: he successfully performed a lab coli in a 4 years old child. Maybe the pediatric surgeon was not there at that time, a strong pediatric surgeon. Now it is not a big thing. Our people do it like that. And great academician. Definitely, academics has got, my friends, it has got a very vast interpretation, academics. The people who can go to waste some time, our teachers who can waste some time and go to library, sit comfortably, read something new, and deliberately distribute it to us, something new. But unfortunately, we are seeing in our friends that now the people have got not much less, they have a very less time to go into the library and read something basic, teach something basic. Now the thing is, many of our teachers have forgotten their palpation and things, because ultrasound में क्या लिखा है, उधर what has he written, उधर क्या लिखा है. Same is true about cardiologists. I wonder, we used to waste near about for whole day our residents in medical ward. यार ये क्या कहता था, कहता pre-systolic मैंने सुना ही नहीं, कहता नहीं mid-diastolic मैंने सुना ही नहीं, वो कहता ये कहता pan-systolic ही कैसी होता है. If the patient has not seen those things, my friends, they have not gone waste. They are still there. They are still there. I have to tell you, my friends, my younger generations who will be much longer than I live, that the basics of medical science, basic teaching of medical science has not gone anywhere. Our basic anatomical basis, applied anatomy, surgical anatomy, short, it has not gone somewhere. We should know it. We should know. I did have a question yesterday for my professor, Dr. when she was talking about gynecology in case of hernias, because I remember everybody should know how a femoral hernia, femoral area looks. What does it contain? It contains 3 things, and how should I say everything? And if there's a weak orifice there. So, carrying on the things, definitely, they say is an institutional leadership, principal medical college, Srinagar, Jammu, and shapes the future. I have got my own opinion. Every leader comes to an institution with very big dreams. But the question is, how about their hands are tucked down? They are not being allowed to play, because he cannot punish a person whom he wants to punish. It will go as injustice. He cannot promote a person he wants to promote. Again, it goes an injustice. And he cannot give new ideas to the government. They don't have funds. They don't know. I am one amongst you at the senior most. And when they were making one institution, and I told my one teacher those days that I told him, sir, a humble submission. We have got 3 medical colleges, we know an Institute of Medical Sciences. Do you need this much expansion of these new medical colleges? Do you need it? He had no college. I not for that. I told when these boys will pass out or they will specialize, they will super specialized. Where is the job? Where is his Where is his proper armamentarium? How will he fight? I found a man, I found a DM candidate in Kangan, and I went to him personally to his room. I told him, Mr. What are you doing here? He was my resident. He told me, I am doing, I told यहाँ क्या कर रहे हो भाई? मैं कुछ नहीं कर रहा हूँ क्या? इसी से देख रहा हूँ. उसे कहता है तुम सो रह जाओ और क्या करूँगा? यहाँ कुछ है नहीं. So the thing is, I want through this August gathering convey to my government, convey to everybody and health professionals and organizers to think about it. Once they create the professionals, highly qualified, talented professionals, they give them armamentarium, they give them place, they give them staff, they may give them paramedics, and they give them time, they give them enough salary so that they live. Because a doctor, a surgeon, a cardiologist, everybody, he has to get married, not to the wife, he has to get married to the hospital. Because after every 5 minutes, I know about one surgeon, last thing he asked me, he was sleeping at midnight. You tell me, where is the pain? Is it on the left side or the right iliac fossa? He told, no, it's on the left side. So then don't worry, I will come in the morning. So the thing is, we should encourage these staff members. The only one thing that our young people are suffering is this, they are confused, they are lost. They are actually thinking and they are not interested. Many of them are not interested in medicine and surgery. Very few. I can put at the quantum that it is only 5 to 10%, 10 to 20% who are really. If you ask somebody, how did you become a dermatologist? He says, Anas, मैं क्या कर? इतना dry job, इसी में मेरी posting हो गई, अब मैं क्या करूँ? Nobody asked him. So these are the things which we carry. It was about achievements at the professor of surgery, master surgery, who surgeons who monitored and generation students, how much and lifetime award to Professor Shekhar Singh, and guidance for medical community and example of integrity and ethics. This is the debatable part. This is the debatable part, how they will do, what they will do. And everybody will discuss me in my life, what is my integrity and how much I'm up, how much I stand up to my dignity and ethics. That is a thing to be left to you as colleagues, as friends, as superiors, and as upgoing. Because everybody, I will be discussed in your home places. I will be discussed everywhere by my patient, by my team, by my empathy. The thing, it has gone so beyond our limits that many times in my private practice, I met people from remote areas. They gave me a gift because it was after your teaching. They told me, me and Moses gayi theek, meri mother theek ho gayi, ab adi, ab ada ke honge. मैंने कहा क्यों? कहता है because nobody had touched her. किसने देखा नहीं था इसको. They were getting ultrasound क्या होगा? Ultrasound ने क्या बोला? मुझे लाओ. It was the COVID time, and the patient had 6 persons with him, and he told me that I told him, doctor, are you afraid? I told him yes, because there's COVID. Nobody touched him. Touched my mother. I have to do it. Then you'll fall ill. I will fall ill, but I have this exam. So that the thing others should have like this. Surgeon instinct. That means sometimes our elder sister, they talk very, elder doctors or teachers, they talk nice. I have got a lot of experience because being inexperienced, I operate my aunt. At the last point of cholangitis, when my teacher, Dr. Nazir Ahmed Wani, left, he told me, don't operate for 5 years, don't operate. And after 5th year, I operated. And he told me, now it is better. So I told him, sir, what did you do? Because he told me that she had to settle down. And she was under us, we were watching her, and she became better. And master technique, what is the best thing somebody does? How does he teach and how does he deliberate to the people? Dr. Shekhar Singh was like this. He was very kind in teaching and in coming and in the midst of the night attending in medical college. Srinagar, I know it, that he used to come for calls and I don't know much about Jammu. I cannot talk like this. And he used to consult others and ask their opinion, because joint conference and opinion makes me wise. Whatever I was not knowing, you people were with me, and we had a joint conference, and I became wise. Whatever I had forgot, whatever I had missed, you reminded me, and it went to the best advantage of the patient. Compassion and clinical practice. That's compassion. I cannot teach. They have talked. My friends have talked better than me. I cannot talk. What is the two things that compassion has gone much lower now? It has professionalism has taken over. Professionalism has been taken over by, I should say, commercialism. The thing is, you know it. Dr. Sanjay has talked very nice and boldly, which I cannot talk. It has taken over. In a place where my professor knows it, I sent one or two referrals to one of the panelists. When I was blamed by that relevant hospital, that you are wasting our patients. I told, no, these patients should go to a panel, to a group, and they should manage properly. And these are my two friends whom I talk daily. I will not operate here. Why? Why should I operate? I have not consulted with people. It's a group discussion. Unfortunate part of it is in our even private practice for earning money, we have become single. Private practitioners have got a very bad habit. They do not come together. They don't join heads at some time. They don't have it. They should have it. And they take all the horses in one ride. Small horse, gentle horse, dangerous horse, and wattle horse. They tell you in the one ride. They should not do it. They should consult. And do our juniors who are in search of money, they are in search of comfort with everybody. We are falling very short because our children have grown. We don't have a house to live. I will construct my house and still I am wasting. I don't have a job. Now 48 years, the people don't have got jobs. He was 35 and he's post-graduated specialist, but he doesn't have a job. So somebody should think about that. And that deviates him from a determination, from a goal, from a purpose of the profession. So don't blame him. It is not his fault. It's not his fault. It is somebody else's fault. And academic leadership, and he had a lot of, Dr. Sheetal Singh had a lot of dreams in conducting these things. But I beg an apology from the time that all our dreams are not filled up and they are not successful in our daytime, in our lifetime, what we had dreamed. Definitely, doctors, I am the student of Lieutenant Colonel Esco, a great academician of his time, a man who was a visionary. And if he sees the medical college today, we had only one room ER in Government Medical College, Srinagar SMS Hospital. Now, if they see, now I go there daily and I see now there are 26 buildings. My heart gets big. That is my medical college, my place. And I don't think that the greatest reward and greatest prayers for such a gentleman must be, we should believe in the history of Medical College Jammu, that man had come here, he had long dreams. Some he fulfilled, some he had envisaged, some he had put a dream on the side, and he had made a paperwork out of that, and some dreams. Everywhere where there is a stone, there was a mason who put this stone at the right place. And we are all taking this dream and our profit and our fruits out of that. My friends, don't think that people like Sheetal Singh and others luminaries who have come and who will come, very few of them are who have got intentions. There are two types of principals and leaders who come to our medical profession. Some come to finish their job and confirm their pension. Some come to work. Some come to get all the praises. Some come to get criticism. Some come to get beaten. That's not a thing. So we should, as learned people, because doctors are highly learned people, we should see them and how they make a life and how they were, how they behaved, and finish, sir. I don't have to add anything to you, and because everything was discussed, and moreover, it gives me a lot of subject was made easier because you are all here better than me, because who knew Dr. Sheetal Singh? But definitely, please believe me, I talked to many friends, and everybody had a different. As people have many opinions about me, and any person, me about my father, he about his son. Everybody has got his, keep the dice open for the, but the question intentionally, he was a great man, he was a great teacher, he was a great linguistic, and he was a great person to discuss. You could have not in Jammu and Kashmir, in the faculty I know, in our Kashmiri way of talking in English language, and our tone and tune and linguistics would, that time I know I could have not beaten that man in arguments. God bless his soul. God bless his. He has got a nice wife, Suprinder ji, whom I know. She has forgotten me, but I have not forgotten. I know her. I don't know whether she recognized me this time or not. But the question is, he had a greater love for me. Last thing I want to tell you, he is the man who gave me maximum banking, because the first case I did independently as a registrar in Government Medical College, Jammu. I don't know what happened. After 3 days, the patient had a duodenal blowout, and it was a tragedy for me. And he was asking me, "Oh, yeah, that's a key profession. I don't know. Now I had no answer to tell him what I, because I had done it. The thing is, we had a tough time. Blowout. In blowouts, duodenal blowouts, there's one more luminary who has taught me. I was very bad man, and I'm still a greedy person in learning. That's my friend, Dr. Isar Chaudhary, my junior colleague, who told me, don't get afraid. We can manage it. And I managed it. Dr. Isar, I salute you. And I salute everybody. I remember Dr. Sheetal Singh in his best words, best days. And just try to yourself that when people talk about us when we are not here, how they talk about us. That's a real certificate. Now, not my money, not my palace, not my car, not my new suit. No, people will talk. Public will talk. And that's a word. Thank you very much.
Thank you so much, sir, for this wonderful talk. May I now request the chairpersons for this session to kindly felicitate our orator. May I also request Dr. Supinder Kaur ji, wife of Dr. Sheetal Singh ji, please join the chairpersons on stage for the felicitation. May I also call ma'am to kindly join. Ma'am, can you also join, please?
Please come.
Last year, we had Professor Sheetal Singh's oration first time. His daughter was a plastic surgeon. She was there that time in GMC Anantnag. I was lucky enough to have the first oration last year. And today, the daughter has not been able to, but we have the respected madam, madam here. And we wish Almighty bless the noble soul. We all know Professor Sheetal Singh, his wonderful way of interactions. And today again, he is one of the very close friends, Dr. Bashir. He presented the oration. We congratulate him and wish that the oration lives up to its reputation in the coming years. Thank you so much. Thank you so much.
I thank chairpersons for joining us on the dais. Thank you so much.
The sponsor of this oration, Professor Sheetal Singh's oration, is Dr. Kanchan Kaur, who is daughter of Dr. Sheetal Singh, and she is presently oncosurgeon at Medanta Medcity, Gurgaon. Thank you.
Now we move to the final gem of this oration, Professor Mahmooda Khan oration. May I have the pleasure to call upon the stage the chairpersons for this oration, Professor Dr. Nisar Chaudhary, Professor Dr. Sanjay Bhasin, and Professor Dr. Ejaz Ahmed Rathar. May I now invite upon dais Professor Dr. Ejaz Ahmed Rathar to carry on the proceedings.
A very good afternoon to all of you. So we have the next oration, which will be given by none other than Professor Rajendra Prasad, who is the head professor of surgery at AIIMS. He's a well-known thoracic and foregut surgeon, core faculty of minimal invasive surgery and breast and endocrine surgery at All India Institute of Medical Sciences, Delhi. Dr. Prasad is a distinguished surgeon, an academician, and over 3 decades of experience in clinical practice, teaching, and research. He completed the MBBS from University of Jammu in 1985 and did his MS surgery from All India Institute of Medical Sciences, New Delhi in 1989, and then Diplomate of National Board in 1990. Currently, he serves as a professor and head department of GI and thoracic surgery at All India Institute of Medical Sciences, Delhi. His area of expertise include robotic surgery, laparoscopic and thoracoscopic surgery, and with a strong emphasis on innovations and patient-centered care. He has received prestigious international fellowships, including University of Minnesota and ICRETT Fellowship at Memorial Sloan Kettering Center, and USA. Dr. Prasad has authored over 150 research surgical articles and holds at index of 35 or 31, which is very high, and is widely recognized for his contributions to the surgical education and research. So I welcome Professor Prasad, and he'll begin the oration, third oration. Thank you very much.
So, my sincere thanks to the organizers of Jakasicon for the honor of Professor Mahmooda Khan oration. It's a privilege to stand before you today to reflect on my quarter-century experience with a rare esophageal disorder. The experience of managing achalasia patients has been a lifelong journey of understanding not just a disease, but the lived experience of dysphagia, fear, and ultimately relief. Seeing a patient who hadn't swallowed food comfortably for years take their first comfortable sip of water remains the most satisfying experience in my surgical career. Now, before I proceed, I would like to pay some tributes to Professor Mahmooda Khan, though I have not had any personal interaction with her, but this is what I know about her. She was born on 23rd, 12, 1934 in Srinagar, graduated from Lady Harding Medical College, got married to Dr. Said Zahoor in 59, did her house job and registrarship from the same college till 1960, chose to be a surgeon despite being outgoing graduate in the gynae. And this was kind of against the tide, and she had a strong will coming from an army background. Then she did her specialized training in England and also did jobs in UK and then subsequently in United States of America in Albert Einstein Medical Center, Philadelphia. Then she returned to her roots, which is very unusual thing to see. People who have gone abroad don't normally come back, and joined as a professor in Srinagar Medical College, and where she went on to become the professor and head. And from 93 onward, she's been in the private practice. She's doyen of surgery, operated on all challenging, complex surgeries, taught innumerable surgeons the basic craft of surgery, a strict disciplinarian, but a soft human being. And his students, they feel like a rose, proud and fragrant like a rose. At present, she is blessed with 3 kids, daughters in USA, son working as a faculty in SKIMS in critical care, but then he went on to join his family in UK. Her husband, Professor Said Zahoor, ex-principal GMC, a par excellent physician and a humble human being, no more with us. Her favorite pastime is tending to her grandkids. Our wish is to see Madam see her unfulfilled dreams through her kids, grandkids, students. May Almighty keep her in sound health and gift her with Sarconical. Amen. A word of gratitude for Professor Munir Khan for starting this oration as a tribute to his venerated teacher, and J&K State Chapter for making it a regular annual affair. With this, I come down to the topic, 3 decades of surgical management. Actually, I had planned it 25 years, but somehow I was told somebody made it 3 decades, and I think it's Suneha who did it. So I had to go 5 years back and then, start from there. So if I exceed the time, it's her fault. So my gratitude to the divine intelligence in us that conceives, plans, and executes. It motivates us, moves us, and gets the job done. So whatever I'm going to speak I'm just the instrument, and the rest is done by the divine intelligence. My gratitude to my parents for instilling the right values. If it wasn't for them, I would not have been here standing before you. Why did I choose this topic? Achalasia is a rare disease, that's fine, but for a patient, it's a life-defining thing. Imagine yourself being hungry, surrounded by the food, but not being able to eat. So it makes the patient very miserable. And this is one of the patient's perspective Nothing had changed from the night before except for the certainty that everything had changed. Food, as I had always known, was now in the past. And this is one of the medical students who recently came to us.
Hello,
and I would
everyone.
like to
I'm
listen
Rishabh
to what he had to say.
I'm a student in AIMS Bhatinda. About 1 year ago, I started having difficulty in swallowing. Initially, it was for liquids, but gradually it progressed to solids as well. The condition became so severe that I had to drink almost 1 liter of water just to swallow one chapati. I also had severe chest pain at night, along with regurgitation of food and even aspiration, because of which I could not sleep properly, due to which I developed pneumonia frequently and fever also. It was really very disturbing and affecting my daily life.
So this is the experience of the patient. If you have just heard him, you don't need to read a textbook. He has described every single symptom that a patient can have, and he had it. So before I proceed further, just a brief introduction about achalasia. It's a progressive non-curable motor disorder characterized by absent progressive esophageal peristalsis and failure of LES to relax with swallowing. Predominant symptoms are dysphagia, regurgitation, chest pain, but 50% of them may have pulmonary symptoms, and that is what we recognize during our experience of 25 years. It matters because though it's rare, but missing it is not a rare thing. People misdiagnose it, misinterpret symptoms. People may have only regurgitation, they get diagnosed as GRD, psychiatric illness, viral encephalitis, and I have seen patients who have been diagnosed with this and neglected for long, operated, a patient who got operated, a doctor himself got operated, had a fundoplication done, whereas his problem was achalasia, just because of a miss. And this picture that you're seeing is again gastropexy done for supposedly a gastric valvulus when patient had achalasia. Etiopathogenesis is unknown, but as of today, it is considered to be a neurodegenerative disease. Current interventions include pneumatic dilatation, POEM, and Heller cardiomyotomy. None of these are curable. They only reduce the pressure across the LES, thereby palliating the symptoms. The downside is reflux, and therefore you need an anti-reflux procedure to minimize the reflux. So effectively, we need a balance between relief of dysphagia and the reflux that is going to ensue after you have divided the LES. So my journey, initially I did my MBBS in GMC and then went on to AIMS in 87, and where I am here till date, and this is where I encountered my first patients of achalasia. My gratitude to my mentor, Professor BML Kapoor, who laid the foundation of my surgical career. The early years of my achalasia, exposure started somewhere in 1994. So Suneha, you're right, 30 years down the line. I was shifted to Unit 3. I had already been an SR and a JR for 6 years, but when I got as a faculty and I was shifted to Unit 3, this is where I saw my first patient of achalasia. And at that time, Professor Chatterjee used to do open Heller myotomy. There was no anti-reflux procedure added to it. And with him for next few years, and patients who used to come were far and few between, because largely they were going for balloon dilatation. And he published also this small series of 25 patients over almost 7 years. So you can imagine how rare this was. So balloon or scalpel was the kind of thing at that point in time, and balloon dominated. But the glory of medicine is that it's constantly moving forward and there is always more to learn. Laparoscopy had made inroads into all the fields by that time, and I had some exposure to laparoscopic surgery. And at this point in time, we saw that a paper was published in 1998 which suggested that laparoscopic Heller myotomy is giving good outcomes. And I felt that this is the way forward and we wanted to start it, but there were challenges. No previous experience with Heller myotomy, laparoscopic Heller myotomy, pneumatic dilatation was involved, no manometry and inadequate instrument. But we had strengths, prior experience with laparoscopic surgery, some exposure to open Heller myotomy, motivation to help patients, and conviction that it is the way forward. So this is how we started. And from that point in time, Dr. Jatinder Rathore, we did a thesis with him. We started tentatively with some patient referrals from colleagues. And when they saw the results, we started getting more referrals. So to streamline, we started a thesis, and after that, we continuously had thesis ongoing, which helped us to maintain the database. So along the way, we forged collaborations with gastroenterologists, diagnosis, anesthesiologists, and clinical physiologists to take our journey forward. And all of them helped us, and you will see in next few slides how. So this is the kind of timeline. Started with lab myotomy somewhere in 2001, played around with different procedures, solidified the technique, started with no anti-reflux, moved on to anti-reflux. Then we started using quality of life and started AOS trial in 2010, then introduced Eckhart scoring, manometry, robotic myotomy, time barium examination, and 24-hour PS studies. So this is how we have slowly tried to progress and introduce everything in our practice. And I'm grateful to people who helped us through. So this is our current, algorithm for making a diagnosis. So we, as I mentioned earlier, pulmonary symptoms, we started noticing that these patients had, and we did a study and we published this, that almost 50% had cough and, dyspnea. And this responded to intervention, either in form of myotomy or dilatation, significant response. And also these patients had lesions on the CT scan, which also resolved, the acute lesion resolved post-intervention. So this is one of our first observation and studies. So barium studies, when we started, we had a barium swallow single, it was not a double contrast or anything, just a regular barium swallow. And this picture will tell the residents. Now, if you see this video on this side is the video of a normal swallow, how the esophagus empties, and you see how an achalasia patient's barium swallow looks like. It never empties, the swallow keeps, there is a lot of hold up and all. So then we moved on to time barium. We convinced our radiology colleagues somewhere in 2017, they started doing time barium for us. It gives us more objective evidence of column height, width and all. And we can also see the how the patient respond post-operatively. You can see the esophagus has almost completely emptied here. By 2 minutes only it has emptied. So this gives us more objective evidence of the success of surgery. And remember, there are some pitfalls. Barium can be misleading in early stages. That is why manometry is required. This patient had some symptoms, barium done, reported normal. 1 year later, this is the picture. So remember that if you suspect it, manometry is the best bet. And then you also have to learn to differentiate a smooth tapering from a abrupt cutoff and mucosal irregularity, which is due to pseudoachalasia cancer. This is how the endoscopy looks like, pooling of secretion and a tight sphincter, and it also helps you to rule out malignancy and submucosal lesion. We have seen both pseudoachalasias, leiomyomatosis presenting as achalasia, including on manometry. Patients refer to us for myotomy. Manometry, as I mentioned initially, we did not have it. Water perfusion manometry was started 2013 with help of Professor Sanjeev Sachdeva from GB Pant Hospital, subsequently high resolution manometry, and now in somewhere around 2018 it became available in our own institute. This is how it looks like, the normal HRM, and these are the different types of achalasias you qualify based on the manometric studies. Even on manometry, you can see if you do it post-intervention, the IRPs fall from 28 to 6 and 20 to 7. They cannot make history who forget history, said Baba Saheb Dr. Ambedkar. So therefore, to understand where we are today, it is important to recognize the thinking process and contributions of those before us. See, the management of Heller started with a whalebone, sponge attached to a whalebone for a dilatation, somewhere in 1672. The Heller myotomy was described by Heller in 1913. It was a double myotomy, anterior and posterior, adaptation of a Ramsted's pyloromyotomy. Subsequently, Zager said that you only need a single myotomy. People tried various things that you can see. I don't want to read all of them. And then the wraps were added on to prevent reflux. Dilatation revisited in some 70s and 80s. Laparoscopic Heller myotomy introduced by Kusheri in 91. Pellegrini attempted thoracoscopic Heller, but it never took off because of reflux. And then in early 20s, robotic Heller myotomy was done, and then came POEM in a big way. But now POEM guys are trying to kind of move on and try and add a fundoplication to it, because POEM consistently has shown high reflux rate, and the evolution continues. So this is how we evolved from short to long segment, and you will see all this in picture, use of advanced endovision systems, moving on to complex cases and all. Now just see this picture now, some of the lessons we learned. Every patient of a achalasia is not going to be the same. You see the first patient, a good intra-abdominal esophageal lung. You see the picture C, a big hiatus hernia associated with achalasia. You can't treat them same. You have to alter your technique. And if you have a hiatus hernia, you need to close the hiatus also, though not as tight as you would do in a GRD. We were using the shearing technique, which many people still do, but then we realized that it's not a very elegant method, and we moved on to using, energy devices, as you can see in the other video. Although that is very effective for, early cases, the shearing, but if you have very, very thick fibers, which I do not have time to show you, then there is a risk of creating complication. So these are some of the evolution. We defined how much higher we should go up. We now go almost 5 to 6 centimeters above the G junction. And when we started, we restricted ourselves, as Dr. Chatterjee did, to about a centimeter below the G junction. And our first study that published also said the same, that it showed a good improvement statistically, significantly for dysphagia rigidity. But when you talk to the patient, you realize there is something missing. So the quality of swallowing bothered some patient. And then we moved up and we started extending it further down. When we started extending it down, first we went towards the greater curvature, but now we restrict ourselves more closer to the lesser curvature. And the lesson that we learned was that key to success is adequate extension across the G junction. As we extended the myotomy across the G junction more, we knew that patients are going to reflux more, and therefore we decided to add an anti-reflux procedure. Which one? Nissen was not recommended. The choice was between DOR and toupee. But what we stumbled upon was angle of his accentuation. It was a patient who had a recurrence of symptoms. We went back and we found the myotomy had healed. When we did a myotomy, we said how to hold it there. And at that point in time, we did an angle of his accentuation. It kind of worked. And then we dabbled with these procedures in next, 45 patients. And then we decided to start a trial. And this was our first randomized trial between the angle of his accentuation and DOR. And this was published in the patients were recruited from 2010 to 15, published in 18. And this showed both procedures gave similar relief of symptoms and similar amount of clinical reflux. And there was no difference in the achalasia specific quality of life, whether you did a DOR or a angle of his accentuation. And this paper of ours was included in Cochrane review, which was trying to evaluate the best anti-reflux procedure to be used in conjunction with Heller myotomy. After this, we moved on to another trial where we looked at the other procedure, that was toupee fundoplication. And this, we recruited patients from 2017 to 23, and this paper was published in 25. And again, this paper showed the same thing, significant improvement in a CARD score with both procedure. And in this patient, we also objectively analyzed the patient using endoscopy to look for esophagitis, which is an objective measurement of this thing. And what did we conclude? We concluded that both the angle of his accentuation is a viable alternative to LHM with toupee fundoplication with similar outcomes in terms of symptom relief, improvement in quality of life, and post-operative clinical reflux and esophagitis. So, it was a good thing. And this is our go-to procedure now. The angle of his is our go-to procedure now. Heller we reserve for intramucosal perforation. Toupee we use very selectively. And this graph shows you how, moved in the trial settings, you have equal numbers, but after the trial, largely we now do angle of his accentuation. This is how we do our procedure now, a rapid sequence intubation, port placement, as you can see here. And we'll show you a video. And for robotic, this is the port placement. And this is a short video that will take you through the steps. So we always try to leave this hepatic branch of vagus intact, dissect into the mediastinum. Here you can see the dissection into the mediastinum. Restrict our mobilization just to the anterior part of the esophagus. Unlike circumferential esophageal mobile, that you may still need in patients who have megaesophagus and all, or patients who have a associated hiatus hernia, because you want to bring the G junction back down into the abdomen. Otherwise, they will have a lot of reflux. So anterior vagus is identified and preserved, and a tunnel is created under it. And once you have that tunnel created, then you measure from the, now you can, once you have removed all the G junction fat pad, you can clearly see the G junction, esophagus becoming stomach. Measure 2.5 centimeter down from there, and then using a hook at a low setting of cautery, we start our myotomy. And you can see here, most of the fibers will come without use of energy, but sometimes you need to use the energy. We go up about 5 to 6 centimeters, as much as is safely permitted. And then after having gone to the top, then we come down. This is the more critical part where the perforations happen. But if you're careful, then you can avoid it. The fibers tend to become very, very thin here. You see these submucosal veins, you come across them, do an intraoperative endoscopy, confirm that everything is fine. Add an anti-reflux procedure. You see that add an anti-reflux procedure, which, as I mentioned, as of today, is angle of his accentuation. So first stage, take the fundus along with the left crus of the diaphragm and left myotomy, and then 3 more sutures down the line, and it makes the angle of his acute and does the job. This is the endoscopy. Just before starting the surgery, you can see pooling, you can't go in, and here, once you finish the myotomy, you can easily enter the stomach, and you can see the G junction has opened up. So it tells you that you have done well. So this is our graph of procedures, the data that we have. There is some missing data which we have not included. This is the data of 409 patients, and almost quarter of them have had pre-op interventions in the form of dilatation or other things. Significant relief of symptoms, you will see subsequently. Only one mortality, we had 6 perforations. Significant relief of symptoms, and this is how patients feel. At least today I went to grocery store, then I thought soon I'll be able to eat stuff. Living with achalasia for 6 months was a very bad experience. I had spent my days sleeping upright because of regurgitation. So these are patients' expressions, and you can see. And then we went on to evaluate the long-term outcomes with AOH, with Heller with AOH. And this is our outcome at a 65 months follow-up, 10-year probability of success, 88%, dysphagia relief 75%, heartburn of 27%. Conclusion, lab Heller with angle of his is an effective procedure with good symptom relief. Robotics have come in, and we have also tried doing it robotically. You can see this robotic procedure under, it just gives you a lot more stabilized view. The view is much more stable, but effectively you are doing the same thing. And you again, do exactly the same thing that we do in this. And you take down the circular fibers from top down, and then do the angle of his accentuation. So this is our small experience with robotic. We did our first cases in 2015, but after that we didn't have robo. But now similar relief, but more operative time. And this is how the patient feels.
Robotic
Same patient that you saw.
By Dr. Rajendra Prasad. All my symptoms have completely resolved. I have no difficulty in swallowing, no regurgitation, and no chest pain. My quality of life has improved tremendously.
So you can see that patients do feel better. Sigmoid dilemma, traditionally they were treated with esophagectomy. We did our study, published 2 papers, and we now can safely say that Heller-myotomy can be considered as a first-line treatment for even megaesophagus. And in the era of POEM, the number of megaesophagus that we are getting is going up. See, this is in last 6 months, the number of the patients that we have done. And then we moved on to revisional surgery. I'll skip the videos because of the time, but they are much more challenging cases. And but we have done our revisional surgery using both laparoscopy and robotic surgery, which gives a little more stable platform. And this is our outcome of the robotic cases of divisional surgery. Mostly they are because of incomplete myotomy, a tight crural closure, or an incorrect wrap. These are the conclusions that we have drawn. These are our other collaborative research and presentations. We also looked at whether we need to do functional evaluation, objective evaluation in the follow-up of these patients. And we did not, we found that simple correlated best with quality of life. Barium swallow and manometry can be left to as a problem-solving tools. Some other research papers, presentations by our residents, students, all this, and these are our partners from different departments. Without them, we would not. And my residents, most of all, they are the ones who have maintained the database and helped us. So, in the end, my gratitude to my wife and children. Because of them, I have been able to carry forward the work. To my brother and his family, he has been helped me a lot. He takes care of lots of things back home. And yes, I know the time is fine, but just this last slides, if you allow me. This is Dr. Aditya has actually made this slide, so I thought, because this is a message he thinks should be given to the young people that stay with a difficult problem long enough. Let memorable patients change the questions asked in theater and clinic, refine technique, but also measure quality of life, publish long-term follow-ups. So I thought we should share it because this is how the younger guys feel. Techniques will evolve, technologies will change, but the essence of surgery remains the same: to choose wisely, to act precisely, and to care deeply. The journey continues. By the work, one knows the workman, but the work must be done for the love of the work. And this is one of my students, now a faculty, who also had achalasia. And in the era of
I can eat my food in peace, and there's no symptoms of regurgitation either. And my quality of life is good. For me, cardiomyotomy with the fundoplication is the treatment of choice if one is diagnosed with an achalasia. Thank you.
So thank you very much. I can eat my food in peace. That is the expression we have. Thank you very much for your kind attention.
Thank you, sir, for the very inspiring presentation. Your work continues to. So now I request the chairpersons to make the comments.
Thank you very much, Professor Prasad. So it was a wonderful and a comprehensive talk on evolution of management of achalasia. So wonderful talk. You made us wiser. Hearty congratulations and best wishes.
Dr. Rajendra Prasad is son of Sahil, and every time we request him to come to Jammu for teaching training, he comes smilingly and without any hesitations, and even sometimes at his own expenses. It was a wonderful talk, sir. I, on behalf of J&K State Chapter of Association of Surgeons of India, thank you very much for delivering the most prestigious oration of the chapter, Professor Mahmooda Khan oration. At this juncture, I will also like to thank Professor Munir Khan for continuously supporting this oration as a goodwill gesture to his revered teacher. Thank you very much. We close the session.
Thank you, sir. Now may I request our chairpersons to kindly felicitate our orator for the day. Thank you, sir. Thank you so much. I thank the chairpersons for being a part of this oration. With this, we come to the end of the orations for the day. I thank each and everybody present today who have been a part of this oration. Now we can all disperse for lunch. Next session will be at 2 p.m. So I hope all of us can make it back till 2 p.m.
फोटो खींचेंगे तो वैसे सर अपनी वीडियोस दिखा रहे हैं हमारा सर एक सर ये वाले सेशन हमारे हो सकते हैं हमारे लास्ट अब आप आओ खाना छोड़ो इनको देना हो गया चेंज करो मैंने बड़ा काम नहीं तो खाना नहीं खाना जा रहा वीडियोस है ना सर ये सिर्फ वरुण करता है आप 15 है अभी तो पौने 2 है आधा घंटा है हाँ सेव हो रहा है चलो वरुण आप ठीक है सर मैम कहाँ पे होंगे लंच अच्छा चलिए
maybe 15 minutes लगेगा अभी क्योंकि it is uploaded under the laptop then online it will be uploaded in this system. यहाँ पे होता क्या है पता है क्या कर रहा है यहाँ खाने के लिए लगा जो भी स्ट्रगल खाने के लिए यही है जीवन में पैसे कमा के लोग तो क्या करेगा ना अच्छा खाना खाएगा
सर आपकी सेकंड है सेशन 42 आपकी हो गई है ठीक मेरे पास गाना से काट आ जाओ आ जाओ सबको बुलाया
Unfortunately, हम totally opposite of
Master, I bet you. You will ya jadi ulang kan kan. Kita lagi mana? Cuma jadi
We can welcome you all with renewed energy and enthusiasm. The specialty where every cut is calculated, every structure is respected, and every decision carries profound significance is hepatobiliary surgery. So, with this, we welcome you all to this insightful session on hepatobiliary surgery. May I have the honor to invite our esteemed chairpersons for this session. Professor Dr. Rajinder Prasad, sir. Sir is Professor, Department of Surgical Disciplines, AIMS, Delhi. Professor Dr. Fazil Parez, sir. Sir is Professor, Department of General and Minimally Invasive Surgery, SKIMS Medical College, Bemina. Professor Dr. Ratnakar Sharma, sir. Professor and Head, Department of General Surgery, GMC, Jammu.
Professor Dr. Iqbal Salim Mir, sir, Professor and Head Department of General Surgery, GMC Srinagar. Professor Dr. K.S. Mehta, sir, former Professor and Head Department of General Surgery, SCOMS Jammu, and Dr. Zahid Mohammed Rathar, sir, Assistant Professor, Department of General Surgery, GMC Anantnag.
Good afternoon. So, welcome back after a very hearty lunch, I can say. I hope the stomach doesn't keep on grumbling. We'll now call Dr. Professor Rajesh Gupta to deliver his lecture about the surgical management of chronic pancreatitis.
I must thank the team of AIMS Vijaypur, led by Dr. Maria Kapoor and dynamic team, as well as the leadership of Jakasicon for giving me this opportunity. For me, this is like coming to your own home, and I'm very happy that the department has taken a big leap to put it on the national map. I must congratulate you, Maria, for this. And I hope we'll see more such events in future. And this department, personally, it is my desire that it should come to a national level. With this, the job assigned to me is to talk about this surgery for chronic pancreatitis. It is important to understand that this surgery for chronic pancreatitis is the major indication is pain. And the major, why is pain very important to take care is because it influences the quality of life. However, large number of patients will have morphological changes. They may have large number of stones, strictures, cysts. But if these patients do not have pain, then please understand that they will not be benefited by surgery. So pain remains the cornerstone of the management for chronic pancreatitis for a surgeon. We'll come to other indications little later. And with this thing in mind, the endoscopic and surgical procedures are designed, and both actually are to deal with the relief of pain by reducing the intraparenchymal pressure. So what are the reasons for pain in chronic pancreatitis? It is important to understand this so that we can then tailor our surgery
according to the needs of the patient. So largely it is the ductal hypertension, which is mainly due to the stress, and that gets reflected into involvement of the peripancreatic nerves, and that leads to central or the cortical plasticity, which is also called as this central hyperplasticity. So this ductal hypertension, as I was mentioning, is caused by chronic inflammation leading to fibrosis and stricture. And this obstruction of the duct leads to ductal hypertension. And this subsequently leads to compartment syndrome. And then because of this peripancreatic inflammation, the nerves in the peripancreatic tissues, they also are activated by presence of inflammatory cytokines. And all of these lead to the sensitization of the central nervous system. And that is a reason for intractable pain in these patients. Please understand that once a patient reaches this stage, any amount of surgical, extirpation of the pancreas will not bring relief to this patient. So that is important. So coming to the goals of surgery, if we look at the total spectrum of chronic pancreatitis, in different cities we find that close to 50 to 75% of the patients would require surgery for painful chronic pancreatitis at some part of the disease. And of these patients who are relieved, around 1/3 to 1/2 will have complete relief of pain, others will have partial relief of pain. So what are the goals of surgery? Our goals are to resolve this intractable pain and thereby increasing or improving the quality of life and independence. The other goal of the surgery is to retain the functional status of the pancreas, which means you design a surgery that causes less of damage to the endocrine as well as the exocrine parts of the pancreas. And when you take care of this inflammatory pathway, then you prevent hypersensitization and central hyperplasticity. Why is central hyperplasticity so important? Because even if you remove whole of the pancreas, these patients will continue to come back to you with pain, and that will be a difficult thing to treat. Of course, the surgery should reduce relapse, because these patients, even after you do resection of the head of the pancreas, can come back with a relapse, and those can be in the form of acute pancreatitis, and that can again be difficult for the patient to handle. Compared to endoscopic approach, which is being commonly adopted in the management, surgery offers a one-stop shop. But contrary to all this, discussion, whatever we may find in our understanding as well as in the literature, but what we find in the real world is something different. These patients generally go to a gastroenterologist first, and invariably all of them will have a stand-in position. So if we look at that aspect from the medical gastroenterologist point of view, so these patients will get that pain ladder from non-inflammatory NSAIDs to they will go on to the opioids. They will have multiple endoscopic interventions, and generally to take care of, now they have lithotripsy. So the idea is to take care of the strictures as well as the stones. The tragedy is that the surgery is postponed to a point where the patient has a pain which is persistent and so debilitated that no amount of relief helps him. And at that stage, when patient is referred to a surgeon, the results are not according to what is expected. So the years of opioid use, repeated interventions, they only treat the symptoms, they don't treat the disease. So that is what I think even the gastroenterologists need to understand. And also, if we are not treating the disease and also not asking the patients to reform, they continue to abuse alcohol, they will have the sequelae of the alcohol abuse, and they will accumulate significant comorbidities along with in the whole process. So therefore, when we are subjecting these patients to surgery, it is important to understand what is the best time to take up these patients for surgery. I've just put up this picture in a patient where you see so much of inflammation with the stents which have been used. This patient had 8 stents, stent exchange 8 times over a period of 5 years. There are dense inflammations. So, this patient had improvement in the pain, but then you will not find complete relief in these patients. So that is why I'm saying that timing in the early course is important. So let us say what the literature says briefly. This is a landmark trial, which is ESCAPE trial in the management of chronic pancreatitis, which was done by Dutch pancreatitis study group. And they included patients they randomized in 2 arms. One of those patients who had, all the patients included were who had opioid use for less than 6 months, or if they had, higher opioid use, then it was strong opioids, it was less than 2 months. So they were randomized into early surgery. That means once they were randomized, they were operated within 6 weeks. And the other group, which ended up with step-up approach, like the WHO ladder of the pain control, then the opioid, and then the endoscopic stent. And then if these patients did not improve with 3 stent exchanges, so they kept a number of stent exchanges 3. If they are not getting relief, then they were subjected to surgery. So these were the 2 arms, and let's see what was the result. The follow-up was, a minimum was 18 months. The Isbiki score, which is the pain score that we use for measuring pain in chronic pancreatitis, was significantly less in chronic pancreatitis, those who had surgery. And also the partial or complete pain relief was again significantly less in those who had surgery compared to those who had endoscopy. Also, if we look at the other thing is that surgery has higher morbidity, mortality, but when they compared the 2 arms, it was not significantly different. So let's come to what are the guidelines before we come to our cases where I will show you a few videos. So what are the guidelines? And these guidelines are actually International Association of Pancreatology, American Pancreatology Association, Japanese Pancreas Society, and European. So a comprehensive guidelines where they say the optimal timing of surgery is early in the disease. And they favored this over a patient who comes in an advanced disease. Why is it important? Because the risk of developing pancreatic exocrine insufficiency is less when these patients are operated early. And the long-term quality of life is also better if these patients are operated early rather than late in the course of the disease. So what procedure is recommended for chronic pancreatitis? So they said either of the 3, phrase, bagger, or burn, they can be treatment of choice and they give equivalent result. However, bagger has its inherent problems because you have to transect the neck of the pancreas. And when you do that, then the bleeding complications are higher. So otherwise, the results of phrase, burn, and bagger were equivalent. So let's come to this patient who had pain, epigastric pain for last 6 months with loss of weight, which was unexplained, and it was 6 kg in 2 years. However, there was no loss of weight and no exocrine or endocrine insufficiency, and he's been an alcohol abuser for 25 years. His workup was essentially normal with the liver function test also normal. And this patient on CT scan showed 4 into 5 centimeter mass in the head of the pancreas. And this was heterogeneous, as is being seen here. So therefore, the tumor markers were done, which were normal. EUS was performed to get a FNAC because if you have a suspicion, then endoscopic ultrasound remains a modality to take a biopsy, and which again did not show any malignant cell. However, PET scan, which was done, showed a diffuse uptake in the soft tissue. So we were not, convincingly sure that this is not malignancy. So this patient was taken up for pancreaticoduodenectomy. And so when we, this pancreatic head dissection or pancreaticoduodenectomy is little different from what we do for malignancy because you have to expose pancreas and that can be little difficult due to dense adhesions with mesocolon. And the steps are essentially the same. You have already, here we have already resected divided the bile duct. The gastroduodenal artery is being ligated. And then after you ligate the gastroduodenal artery, then you mobilize the pancreas from the retroperitoneum. And the portal vein is exposed, because that is crucial. Unless you have superiorly portal vein in view and inferiorly SMV in view, then you can cause damage to these structures, and that can be difficult to handle. So here you find that SMV is in view here. You can see this SMV, and the pancreas tissue is getting separated. And we find that in this patient there was inferior pancreatic duodenal vein, which was large in size, and that was probably the first jejunal vein was also draining there. So once you expose lower part of this SMV, this is the vein which I was talking to you. This SMV is actually densely adherent to the neck of the pancreas. And sometimes here we could make a tunnel, but sometimes the tunnel is not even made. So then you have to, in a stepwise manner, divide the pancreas from anterior to posterior in a layer by layer, making sure that we don't damage the portal vein. So this is a division of the neck of the pancreas, achieving hemostasis. Beauty of this surgery is that once you have achieved resection without any bleeding or complication, which are likely to happen, then the reconstruction is straightforward, because you will not have the fistula. Post-operative pancreatic fistula rate is very low, and that is largely because the duct is fibrosed, and there are not many acini in this fibrotic pancreas. So this is the vein which is combining both the uncinate inferior IPDV as well as the first jejunal vein, and this was taken with a vascular stapler. And then we have this SMA which is coming into view, and separation of the uncinate. You have to go up to the border of the SMV and SMV, because you don't want these patients, if they have a malignancy, to leave a margin which is positive for malignant cells. So here, the last bit of the mesopancreas is being divided, and after that, the specimen will be removed. So essentially, this is same, but you have to go slowly, respect and understand where these structures are going to be there, avoid injury to both the vein and artery. If tunnel is possible, then it is good. If it is not possible, then we resect the neck in layers so that we don't damage the vein. So final histopathology did not have any malignancy, and it was chronic pancreatitis. So this is another patient where there was diffuse calcification, which you can notice here. This is in the tail and body of the pancreas. Dr. Maria, is the time over? You have time? Okay. And this patient again had a stent in place. And when you see, this is the cored out area of the head of pancreas. Since there was a lot of calcification in the body and tail, so the coring was not only in the head of the pancreas, but also involved the body and tail. So this brings us to the third procedure, which is the burn procedure. So what is the role of burn procedure in surgery for chronic pancreatitis? It is essentially done in patients who have portal hypertension and splenic vein thrombosis, and where there are large number of collaterals in the body and tail. So there, opening the duct or doing any type of coring can lead to a lot of bleeding. So we restrict the surgery to the head of pancreas, if there is not much of calcification. So surgery allows you to tailor the procedure according to a patient's needs. Also in patients who have dense inflammation in the head of dense inflammatory mass in the head with the frozen lesser sac where the stomach and body and tail of pancreas are densely adherent. There also the burn procedure is probably the ideal procedure to take up this. So advantages are that you are removing the head of the pancreas in toto, which is the pace setter for the pain. And also you avoid resecting the neck of the pancreas compared to the bagger procedure, and that avoids the risk of bleeding. Compared to phrase, it is more radical. However, compared to bagger, it is technically simpler. So we done 3 such cases, and this was a patient who had heterogeneous pancreas, calcifications which are mainly in the head, MPD was dilated, stent was in situ, and there were mesenteric nodes.
Dr. Rajesh, I'm sorry we are constrained for time. Could kindly.
So I mean, if you want, we can stop.
Just one more slide.
No, there is a video, so I can't.
How much time?
No, I mean, it's a video, so.
Please go ahead.
So this is the Burns specimen, which we have. I mean, whenever you want, I can stop.
Okay, thank you.
So this is the last case, which we will just run over. This is a patient, middle-aged, who had pain in the upper abdomen for 6 years, localized to the epigastrium radiating to back, had a high Isbicki pain score. He was operated and actually he was discharged yesterday only. This patient had a stent which was placed in the November last year. Patient had type 2 diabetes mellitus, which had actually shown aggravation. From oral hypoglycemic, he had gone to insulin, had been abusing alcohol for 25 years, and also a smoker. So one thing important for the residents to know is that when you ask these patients for the reforming, please also take care that smoking and alcohol have almost equivalent effect on chronic pancreatitis. So if patient continues to smoke but abstains from alcohol, will continue to have a progressive disease. So it is important that we take care of both the etiologies together. This patient again had normal LFT. Endoscopic ultrasound showed echogenic foci, MPD was dilated, irregular, and pancreatic head which was diffusely enlarged. So in this patient, we did little different procedure. These are the images of this patient. Again, calcification which is diffuse, a stent in place, enlarged head. And there is a thrombosplenic vein. There were collaterals, but there were not many collaterals if you watch in the body and tail to prevent you from doing resection. And this is the last video. I'll just fast forward it also. So this patient actually has pancreas preserving head dissection. This step I didn't show in the previous surgery. So this is, you have to separate the transverse mesocolon, because this is densely adherent to stomach, and that has to be done gradually from the pancreas. If the head is not visible, you will not be able to do this procedure properly. So after that, once the mesocolon is separated, you have the head is clear, you take care of the right gastroepiploic vessels, vein, and then the artery. They can be done together or separately, but I mean, whatever is easy.
Professor Rajesh, could you just
move
forward?
So we can, you take up questions.
Thank you.
So I think my take-home message is that
I'm extremly sorry. It's a wonderful topic, but
no, I'll just my take-home message is
any
that
questions?
Just one line, if you will.
Okay, sure.
To operate these patients early in the course. If you reach a point where there is a persistent pain, then whatever surgical procedure you choose will not be of any help. Thank you so much.
Thank you, sir. In addition to this, we have to understand that the neurological side is the most important problem in chronic pancreatitis. There are some procedures where we look after the nerves. Most of the times it's dealt with people who manage chronic pain. Thank you very much, sir. We are really short of time. We'll take questions after the session is over.
Okay.
Thank you. Sorry. Now I'll call upon my good friend, Dr. Arvind. A wonderful person who goes everywhere to spread the art of laparoscopy. I have had a very long association with him once he came to GMC, and he's going to tell us something about laparoscopic radical cholecystectomy.
Thank you. Thank you for the invitation. I'm presenting this laparoscopic radical cholecystectomy, and just because I can save the time, I will directly play the video. So, and in between we'll discuss. So, ठीक है आ गया आ गया ना सर अब से टाइम शुरू करना सर प्लीज so this is a little fast 2x speed so for this gallbladder cancer we retract the limitation is the liver retraction which we can do with the Hansen retractor as well as we can do with some suture. That suture can be applied on the falciform ligament and retract. And to dissect, you should be dissecting, small mistake, small steps, small mistakes. So you have to be taking care of, I think it is little faster. Or, okay. So the thing is, why it is not popularized or why it is not done very frequently? Because we all afraid of liver resections, we all afraid of vessels, we all afraid of bile duct injury. But believe me, if you have spent some more time during your normal gallbladder surgery, you can go ahead with this advanced laparoscopic radical cholecystectomy also. You start taking cystiduct at the junction with the CBD, and slowly you will gain experience. So while dissecting nodal dissection, you have to be dissecting around the vessels. So stay just above outside the tuning adventitia of the vessels. If you are afraid of the vessels, you are staying very well lateralized to the vessels, you will get into the bleeding. So if you remain very near to the vessels, there is less of the bleeding, and you will be taking out all the lymphatic tissues along with the specimen. So here you are dissecting, this is the latest harmonic, which is called SD harmonic. It is 1000i, the finer, longer blades, a little faster also. So when you dissect around the vessels, just remain near the vessels. Don't be afraid, don't be away from the vessels. Then only you will be finding a right avascular plane around it. And sometimes, the nodal dissection, the radical cholecystectomy, it has to be one single packet, but sometimes you have to open the lymphatic basket in the open book style, cut in the middle. And these are the basic limitation for the radical cholecystectomy is a retroportal nodal dissection, which we are afraid. It was thought that it cannot be done safely, but here it can be done safely. We are showing it. So that is the portal vein. So when dissecting this portal lymph nodes, you have to remain very near to the portal vein. Just dissect with the Maryland and then take out the nodes. So don't focus on the nodes rather than focus on the vessels. You dissect around the vessels and you will come out with all the nodes. So again, you can see the portal vein. I am very near to the portal vein dissecting, and around the portal vein. This is the way to remove these hepatodenal ligaments, nodes. Just to save time, I made this little on the faster side, faster aspect. That is the right hepatic artery. And when taking, controlling the cystic duct, always remember we used to apply 2 clips on the body side and 1 clip on the specimen side. But in radical cholecystectomy, you should be applying 2 clips also on the specimen side, just in case, because the manipulation, your bile leakage should not be there. So apply 2 clips always on the specimen side also. On the specimen side, I mean the cystic duct side. Yes. In case some with the suction or something displaced. So after this nodal resection around the hepatoportal ligament, hepatodenal ligament. So all around the lymphatic tissue has been cleared. So this is for marking right hepatic, left hepatic arteries, veins, and then we do the this liver resection, part of the liver resection. Sir, it is around 2 to 3 centimeters, but it should not be going slicing it. You have to go deep, vertically deep, because otherwise what happens is generally we started on the outer surface the 2-3 centimeter, but when you come to the hilum, towards hilum, it hardly 5 mm or something like that. So in those cases, the marginal positivity can be there if the specific tumor is too deep. So these all nodes are kept in the back, and then the liver section. So for liver resection, I used to because if you hold the liver with the instrument, it will bleed, or you cannot give enough traction for that purpose. So for this, you should be placing the suture, figure of 8 suture, and then on the lateral side, I take one suture which I will take out through the abdominal wall laterally, so that it can retract it by external means. So on the lateral side, I take this suture out so that the liver, lateral edge of the liver can be retracted laterally. And then, so this is around 2 to 3 centimeter marking. Unless until you are dealing with the stage 2B tumor, then you don't need to remove segment 4B and 5. And rest of the things you can do get away with around 2 to 3 centimeter of liver margin. And during this liver resection, you should be using clips for all those vessels. I can tell you one of the trick in my experience. With the harmonic, if that liver tissue is not cutting in 1 second or 2 seconds, it means the underlying has some tubular structure. So it has to be cut either in 1 second or 2 seconds. If not, then there is tubular structure inside. Then you have to prepare with applying the clips. And for that, I prefer now clips which is not from, I am sorry, from J&J. J&J clips goes to dislodge because it is a flat, it has a character of the flat shape. Rather, you should be using either Escolab or Peter Surgical or back horizon clips. They have a better grasping, better gripping, so they don't get dislodged even when you are using sometimes with suction or something like that. So you should be using, and smaller clips. 200 clips is better than applying a 300 mm clips. Number one. Number two is, I found hemolog clips have a little disadvantage here. Why? Because sometimes after the surgery, after the liver resection, you come up with some bile leakage, and in that case, you need to apply some sutures. Because the hemolog clips are larger in size, it is sometimes difficult to suture that part of the liver where the duct is there. So these are the veins. So you should be applying these small clips, LT200 from the back horizon. So sometimes what happens is when the tumor is involving the CBD or the right hepatic duct. So in that case, the tumor is involving the right hepatic duct. So I proceed. This is a para-aortic nodal dissection which we did for frozen section biopsy. When it comes out negative, then we proceed. This is a right portal vein. We dissected and the control is taken. In this case, right hepatic duct was involved, so we have taken the decision that we will do the extended right hepatectomy along with left hepatocytostomy. So this right portal vein has been taken care of, and then applying the Rudo clamp on the left hepatic duct as well as on the right hepatic duct. Sorry, CBD. So this is the portal vein, taking the portal vein. This is the falciform ligament to take down the liver, and then dissecting the suprahepatic vena cava region. So this is the Rudo clamp on the left hepatic duct, and then applying on the CBD. And then you can see the discoloration after taking the portal vein and the right hepatic artery. So this is the segment 4B and then the segment 5, 6, 7, 8. So extended right hepatectomy. Again, the same principle, applying the LT200 from the back horizon clips. In my opinion, they are better for this kind of dissection, controlling bleeding from the liver edge. And you should be doing this surgery only when you should be having a good bipolar, rather one or two bipolar on the table, because sometimes it is very, very helpful. I prefer harmonic because in ligature or something like that, we used to crash the liver tissue, but we don't know where the tubular structure are there. So sometimes the bleeding is more when you are using a ligation instrument. But here we can ligate the individual veins and ducts with the help of this harmonic dissection. And sometimes this harmonic can be used as a CUSA. These are the branches from the portal vein, middle hepatic vein to the segment 8. So again, this is a segmental 8 branch. You can see the Rudo clamp on the CBD right hepatic duct. And once the resection liver part is done, we make this Roux-en-Y loop of the jejunum and take that jejunum loop towards the for the anastomosis. So this is a left hepaticogynostomy. You can see on my left hand is a grasper which is very narrow, almost 3 mm grasping element. You should be using, if it is available, there is a needle holder which is 5 mm from the shaft and 3 mm at the tip. So you can see better, the small tissue to anastomose, you can see better. So once posterior layer is done,
Dr. Arvind.
yes, just one minute. It is going to complete in less than a minute. No. So that's why I played video at the front. No slides. So there's an algorithm also for this, how to approach with suspected CEGD. So if stage 1A is there is nothing to be done. Stage 1B, then radical gallbladder along with liver dissection and the hepatorenal ligament. If it comes to be 2A, then also the same radical cholecystectomy 2-3 margin of the liver along with the hepatorenal ligament. But if it comes to stage 2B, then we need to do a formal segment 4B and 5 dissection.
Till the time his video is carrying on, I want to tell you, Dr. Arvind, I knew right from 2005, we did fellowship in minimal exercise Gangaram together. But then after 6 months, Arvind called me once. He said, I have joined Pune, please you also come.
Can you see one instrument which I have designed for to take the suture when there is a very less space? There is a spoon-shaped instrument I have designed which can enter into the lumen and you can take the suture so that posterior wall doesn't come along with that suture in the later part of the
You're keeping the
open. So it is a single shape structure laparoscopically which we have designed.
Then I remember Arvind joined Pune with Dr. Puntabekar's hospital. Trust me, he spent a year or so there, was most of the time sleeping in that hospital because he had that fire to learn. Sleeping in the OT hospital many a times, honestly speaking. He has really worked very hard in that phase of life. Then he worked very hard to establish himself in Delhi, which is not a very simple thing. But he has proved his skill beyond doubt. I have seen him doing hysterectomy, cerectomy, esophageal. He is equally brilliant in all advanced laparoscopies. I really love to watch him. Thank you, Asad.
Thank you, Dr. Arvind. Wonderful. And see, you could not see it properly, but this takes skill. Number 2, this takes a lot of courage. And this takes that desire to excel. Thank you very much. You top the list.
Thank you very much.
Now I'll call another person who is going to talk about liver resections, Professor L. Kamal. It's liver resection in hepatocellular carcinoma.
Thank you, Mr. Chairman, for your kind introductions. Ladies and gentlemen, good afternoon. At the outset, I'd like to thank the organizing committee for inviting me for this prestigious conference, especially Dr. Maria Kapoor. Thank you. It is an honor. And I'll be deliberating on liver resection for SCC. It is a broad topic and there is a time constraint, so I will be very brief. So to overview, I have divided my talk into selection, who are the candidates for resections, preparation, how to plan for resections, and of course the executions, the approach, laparoscopic or open, anatomical versus non-anatomical, and resection in cirrhotic and non-cirrhotic, and of course the results. As you know, HCC is a very aggressive tumor, and it is one of the most common tumor. It is in fact the 5th most common GI tumor globally. And the problem is only around 30% people are eligible for resections, with a very dismal prognosis of around 15% at 5 years. But the silver lining is, if you can pick them up early and do the resection, 5 years survival may go up to 70%. And what are the curative options for HCC? Mainly it is transplant, resections, and liver-directed treatment in the form of ablation or SBRT, stereotactic body radiations. Amongst all this, transplant is unequivocally better. It kills 2 birds with 1 bullet. What does that mean is 80% of the HCCs happen in the background of cirrhosis. So if you do a transplant, so it will take care of the cirrhosis part as well as the HCC. But logistic and stringent criteria prevents its universal applications, and it is only indicated for cirrhotic patient. So surgery in combination is the only hope for those beyond transplant criteria, and it can act as a bridge those patients waiting for transplant. So today I'll be deliberating on resection part. So consideration in liver resection for HCC, it is different from standard oncological algorithm. Just to say, like, it is different from other solid organ tumor like cancer pancreas. It requires a multidisciplinary approach, focusing on 3 principles and 3 pillars: tumor topology and tumor biology, patient status, and underlying liver disease, which is the most important thing. Basically, tumor anatomy and physiology is important before taking a decision for dissections. Then how do you select your surgical targets? Who are the patients you are selecting for dissections? That depends upon the staging. And there are several staging systems are there for liver HCCs, but mainly, universally, BCLC staging system is taken for selecting your patient. BCLC, Barcelona Clinic Liver Cancer staging system, it is not a staging system, it is an algorithm that select your patient and direct and guide for further management. There are 5 stages: very early, intermediate, and advanced and terminal stages. In cases of terminal stage and advanced stages, they are beyond the realm of surgery. It is mainly the very early and the early stages which are amenable for surgery. And regarding the intermediate stage, few of the patients may be downstage by TACE, TAR, SBRT, and they might become eligible for resection. What are the body of experts recommend? That is EASL guideline, European, ASL guideline, that is American, and the APASAL, that is the Asia Pacific guidelines also endorses BCLC staging and algorithm for management of HCC by surgery. Then how do you do the assessment performance? It is difficult. It is not simple because CLD can itself influence the liver disease might influence the performance status. And for practice, we use ECOG criteria for performance status. Then conventional assessments are done by CTP score and the MEL score to predict the morbidity and mortality and outcome for liver resection for HCC. MEL is mainly the model for end-stage liver diseases, It is mainly used for liver transplant patient, but it has been extrapolated into liver resections also for HCC. The newer scoring system like LB system has been also proposed, and it has been found to be more accurate and more kind of objective. Then coming to other surrogates, when you are not very sure about the quality of the liver, fibroscan and ICGR15 scan may be used to decide about the liver resection suitability. Then assessment of significant portal hypertension presence. At present, nowadays, we don't take as an absolute contraindication, but it is still a strong predictor of mortality after liver resections. Presence of portal hypertension is helped by upper GI endoscopy, varices are there, hepatic portal venous gradient is more than 10 millimeters, and platelet count less than 1 lakh signifies that patient has got significant portal hypertension, and they might develop a significant morbidity post-op. Then Makuchi's criteria and algorithm is another way of predicting and guiding the liver resection, extent of liver resection in cirrhotic and in normal patient for HCC. Here, 3 things are considered, like presence and absence of ascites. If the ascites is there, whether it is controlled or uncontrolled, then the bilirubin level from normal to more than 2 gram deciliter, and of course the ICGR15 retention, what is the extent, and it guide you for the extent of your liver surgery from major hepatic dissection to enucleation. Once this qualitative assessment is done, then you have to do the quantitative assessment of the liver in the form of volumetry. And especially you want to find out the volume that will be remaining, that is we call as FLR, fused liver remnant. That is very important to prevent post-hepatectomy liver failure, which can be a very, very dangerous situations. So trial CT volumetry is the gold standard at present, and we stratify the liver status according to the liver status. We keep the FLR. Like in normal liver, it should be at least 25%. In steatosis liver or post-chemotherapy, it should be 30%. And in cirrhotic liver, it should be more than 40%. What is the importance of this FLR volumetry? If the FLR is adequate, then you can proceed with your extensive surgical resections. If it is borderline, then you might have to augment the FLR by, say, portal vein embolization or liver venous deprivations. And the FLR is, if it is inadequate, then avoid major resections. Consider stage approach or a surgical approach like ALPS that I will come to later on, and or consider for transplant. FLR augmentation technique, as I have mentioned already, portal vein embolization can be done. It is a key strategy to increase the FLR. Selective embolization of the portal vein is done, and it redirects the portal flow to the intended FLR and causes hypertrophy. And FLR hypertrophy can occur up to 20% in 2 to 6 weeks. Another strategy is the liver venous deprivation, LVD. This is the new kid on the block. Here, basically, radiological double vein embolization is being done combined with PVE and HBE. The mechanism is PVE causes hypertrophy and HBE causes atrophy of the disease side, and it causes a stronger and faster FLR hypertrophy. And what are the surgical strategy that you can apply to increase the FLR is the ALPS. ALPS is the associating liver partition and portal vein ligation of stage hepatectomy. It is a 2-stage procedure. On the first stage, you do a portal vein ligation along with the in situ splitting of the liver and keep it there. Don't touch the artery and vein. And after 7 to 10 days, there will be tremendous hypertrophy of the intended FLR. Then after around, say, 1 week, 10 days, you go back and do the completion hepatectomy. So this table shows a comparison of PV, LVD, and ALPS. Understandably, ALPS has got the maximum FLR increase up to 80% with the minimum time, maybe in 7 to 10 days. But it comes with a price that there is significant morbidity and mortality up to 15%. Then assessing the tumor biology, we use surrogates for that definitely, and radiological, biological, histopathological, and transcriptomic surrogates are used for assessing the aggressiveness of the tumor, and mainly in a preoperative setting, radiological and biological markers are better, definitely. Size more than 5 centimeter tumor. Number 3, vascular biliary invasions. This signifies that it is a very aggressive tumor, especially if the alpha fetoprotein is more than thousands. So these are the markers we take into account before deciding for HCC resection. And once all these informations are available, then you are preparing for resections, then you ask some questions and try to get the answers. What is your approach and technique? Yeah, it is dependent upon the surgeon and the institute policy. How much can be removed? That is, the FLR should be 30% in normal and more than 50% in cirrhotic patient. Is FLR augmentation possible? Yes, I have already shown it. PV, LVD, ELFs can be there. Can we use Pringle maneuver during parenchymal transections? Yes, it should be done. It is helpful with some reservation, of course. How to minimize blood loss during parenchymal transection? You utilize Pringle's maneuver, utilize low CVP, permissive hypotensions, and can we downstage and resect the patient? Yes, definitely. You can preoperatively give TACE, TAR, or SBRT and downstage the patient, and you can resect them. Then must have surgical pearls. So surgeon and anesthesiologist should be trained. It will be a bonus if they have got some transplant experience. Low CVP, permissive hypotension, and management of massive hemodynamic shift has to be managed. And preserve parenchyma, if it is possible, do some non-anatomical versus anatomical resection. Avoid extensive liver mobilization. And you should have gadgets like self-retaining retractor, intraoperative ultrasound, vascular clamp, energy devices like CUSA, harmonic, bipolar coagulation, surgical loop, and above all, for God's sake, minimize the bleeding during parenchymal transection. Surgical approach, open versus laparoscopic, the core principle remains same. Oncological adequacy and safety is the first thing. There should not be any compromise on that thing. Then, of course, if it is feasible, do minimal invasive surgery. Open liver resection today is the gold standard for HCC resections, especially in complex tumor, difficult location, presence of portal hypertension, and major hepatectomy. Laparoscopic liver resection is gaining momentum, as you can see by Dr. Arvind's presentations. And with a comparable R0 resection with the advantage of less blood loss, shorter hospital stay, lower morbidity, and faster recovery. Recently, Southampton Guideline 2017 has been published for laparoscopic liver resections, and most of the surgeons are following them, and we should also follow them. Then coming to anatomical resection and a non-anatomical resection, there are definite oncological rationale and indications are there. AR removes one or more coinage segment based on portal triad territory. It is mainly aiming for oncological radicality. And NAR, that is non-anatomical resection, preserve the liver parenchyma, which is very, very important in case of cirrhosis and multiple lesions, and aiming for functional preservation. What does the evidence say? Recent meta-analysis is showing that AR has got a better overall and recurrence-free survival in tumor less than 5 centimeters. Is Pringle safe, or whether it should be done continuous and intermittent? Yeah, robust evidence is lacking, but definitely there is no biochemical differences, no differences in clinical outcome, and it definitely reduces operative time. Does blood transfusion adversely affect prognosis? Definitely yes. More the blood transfusion, there is a higher post-op complications, even increase in recurrences 1 year and 3 years interval. Post-operative care and outcome should justify your heroics. Using the post-operative period, hemodynamics, fluid balance, and organ support should be continued at least for 48 hours in ICU or a SDU setting. Early post-operative nutrition and ambulation is of paramount importance with the ERAS protocol. High alert for post-op sepsis, bleeding, vascular catastrophe, and prevention and management of post-hepatic liver failure, which can be challenging multi-organ support, portal flow modulation, and Salvage